And V cyclin, sorry, only cyclin. Okay, they've got 10. Okay, 10 to others, 5 to Shivangi. Okay, with that we come to the end. If there are any tie, we have a rapid fire, but I think we have to vacate. We'll have to stop here. So I'll be stopping here. Okay, thank you so much for the quizzes, all the attendees who were there in the prelim, and thank you guys too. Okay, I think we'll announce the results in the afternoon, just before the lunch. Thank you.
You ready to start? Good morning, ladies and gentlemen. We had a very interesting and enlightening day yesterday. We covered a broad range of topic of access, India's role in global healthcare, need for innovation and transition from volume to value, and CAR T as a standard of care. Today's talks and panel discussions will take us deeper into the clinical aspect of CAR T, and we are fortunate to have with us a very eminent and experienced speakers and panelists to guide us in this journey. I now may invite on stage two very senior faculty members to chair our next sessions. Dr. M.B. Agarwal, Professor and Head Department of Hematology, Bombay Hospital Institute of Medical Science, Mumbai, Consultant, PD Hinduja Hospital, Leelavati Hospital, Fortis Hospital, and Breach Candy Hospital. A big round of applause for him, please. Sir. And Dr. Pankaj Malhotra, Professor and Head Department of Clinical Hematology and Medical Oncology, PGI, Chandigarh. On this side, sir. I now invite our first speaker of the day, Dr. Terry Fry. Dr. Terry Fry is a professor for pediatrics and immunology, executive director and Charles C. Gates Endowed Chair of the Gates Institute for Cell and Gene Therapy at the University of Colorado Anschutz Medical Campus. Prior to arriving at the University of Colorado, he served as the head of hematologic malignancies sections in the pediatric oncology branch at the NIH, where he led efforts in cellular immunology, immunotherapy for pediatric leukemia. Dr. Fry's research focuses on the preclinical and clinical development of antigen receptor T-cells for pediatric cancers. He serves as the vice chair of the Committee for Scientific Affairs for the American Society of Hematology in a leadership role on the Cellular Therapy Committee of the Children's Oncology Group and was elected into the American Society for Clinical Investigation in 2015. Ladies and gentlemen, a big round of applause for Dr. Terry Fry. Over to you.
All right, right, good morning. It's actually truly an honor to be here today. So I'd really like to thank Rahul and the organizers for inviting me back to India. I guess my first trip here was in 2015, which is when I first met Rahul. I first met Gaurav at Tata Memorial Cancer Center. And then I guess my second trip in 2017 is when I made it to IIT and was introduced to Rahul. And I really just want to say a huge congratulations to all of you that have really quite rapidly developed the CAR T-cell program in India. So congratulations. So I was asked to talk about the status of CAR T-cell therapy for ALL, and I'm a pediatrician, so I like to remind everybody that actually the first approval for CAR T-cells was for pediatric leukemia, not for adult cancer. That's an incredibly rare situation in the United States, where we often get drugs in pediatrics that are handed down to us from our adult counterparts. And that was 2017. So, a lot has happened since then, and, I'll try to talk you through some of that. I think largely what I'm going to try to focus on today is what we've seen in terms of patterns and mechanisms of relapse, right? So, Dr. Nilapu yesterday, very nicely summarized the experience in lymphoma, where there's about a 50% complete remission induction rate, and that seems to be durable, at least for DLBCL. Very different for pediatric leukemia, and we'll talk about that today. So these are my disclosures. So, what have we learned so far? So obviously, everybody in the room knows this, but I think it's important to just remind ourselves that, CAR T cells are highly successful. The primary toxicity is CRS. At least for ALL, it appears that toxicity tends to correlate with the amount of disease a patient has at the time of infusion. And at least in high burden patients, CRS is important if the patient is going to achieve a CR. Another reminder is that relative to other forms of adoptive immunotherapy, tumor-infiltrating lymphocyte, for example, the dose of CAR T-cells is remarkably small. I don't know if anybody's looked at the pellet in the bottom of a conical that actually goes into a human who gets treated with CAR T-cells, but it's a tiny number of cells. I mean, literally 2-3 logs less with CAR. And, that then means that these cells have to undergo exponential expansion if there's going to be good activity, at least with a lot of tumor. For reasons that we're starting to understand, retreatment often fails, at least with the same CAR, probably some immune rejection, although the full mechanism of that isn't entirely clear. And, for ALL, we recognized early on that some degree of CAR persistence matters. And people debate whether it's 3 months or 6 months, but that seems to be important. And, we measure that typically by duration of B-cell aplasia. There are some that argue that isn't direct evidence of CAR persistence, but it seems to associate with durable remissions in pediatrics. I think it's been a little bit less clear for lymphoma, but it was interesting, when Satva was presenting yesterday. I think if you look at the allogeneic CAR T-cell experience for lymphoma, to me it suggests that at least some persistence, whether it needs to be 3 months, is unclear, but at least some persistence is probably important even for lymphoma. So where are we at least in the United States, with CAR T cells for ALL? So we're certainly, even though the label hasn't changed, most oncologists are thinking about using CAR T cells a little bit earlier. I mean, in a lot of the earlier studies, if you look back at the early CAR T cell studies, a lot of these kids were treated with bone marrows that were 50-75% leukemic blasts. We're now frequently treating patients at MRD level disease, very little disease. Most patients haven't had a transplant. And the implication of the low disease burden is we're certainly seeing less toxicity overall. There's certainly reduced expansion. And I think something we're paying very close attention to is whether the persistence is attenuated when there is less expansion. I think it's a little unclear right now, but that is something we worry about. In the United States, because most patients haven't had a transplant prior to CAR T-cells, with a 50% relapse rate post-CAR in the patients who achieve remission, it becomes a big discussion with families as to whether patients undergo a consolidative transplant, but I think most centers are performing that at some point. And what we're seeing now is that many patients that get CAR T-cells have been exposed to prior immunotherapy, either CD19 or CD22 targeted, or both. And the data says that it doesn't impact CAR outcomes, but most centers are measuring antigen expression on the leukemia before they treat them with a CAR. And obviously, if they don't have 19 expression anymore after blinatumomab, they're not getting CAR T-cells. So there's a selection bias there. So this was the data from the original Eliana study that led to the licensing of Kymriah for pediatric ALL. And I like to show this curve because I think, in many ways it shows a lot, right? First off, it shows you sort of the term we use is glass is half full, glass is half empty. That is to say the CR rate is high, but half of the patients will stay in remission and half of the patients will relapse, right? So that's essentially, and that pattern has held up. The other thing that you'll note, and I think this has also been seen with a lot of the 19 targeted CAR T-cell studies, is that there tends to be an early pattern of relapse and a later pattern of relapse, and that showed up in this original curve here. And what we've come to appreciate is that early relapse, as I mentioned earlier, is typically associated with recovery of B cells as evidence of loss of functional CAR T cells, and then a CD19 positive relapse. The late relapses tend to be associated with CAR persistence, and almost all of them are CD19, at least attenuated. Most of them are negative. And so I'm going to spend the rest of my time today just talking about some of the work that we've done really to address and think about some of these patterns of relapse. And so, I already kind of alluded to this. So a patient gets treated, 80-90% of those patients will achieve an MRD negative remission, and then 50% will relapse. And it's roughly about 50% of the relapses will be due to poor persistence, and the other 50% will be loss of antigen. And so when you think about the antigen positive relapses, we tend to think about that being associated with something inherent in the T cell product, right? Something about the CAR T cells that are infused that potentially drives that. And yesterday, Satva presented some really nice data on the expansion of, I'll call it, preferential clones in the product in patients post-infusion. And as Satva mentioned, that's been recognized with autologous T cells for a while, right? But the issue is that when you look at what expands relative to the product, but since that product only goes in a single patient, you don't really know whether or not that would be true if multiple patients got the same product. Really nicely yesterday, Satva showed that with the allogeneic CAR T cells, the same thing happens, and it tends to be the same clones in each patient, suggesting that there's something about fitness or quality of individual clones in the product that actually drives, that expansion. So, we've been thinking about some of the factors that might impact that. And one of the things that everyone talks about, and it's important, is what is the quality of the T cells going into the manufacturing, right? What's the percentage of cells that are naive or central memory, higher quality cells? And I think one of the big questions that we hadn't really thought of was, when you manufacture a CAR product, you put these cells on beads, they undergo massive expansion, you introduce high concentrations of cytokine. The question is, do you erase that history of the T cell? And so we just published this a few months ago. A graduate student in my lab used a mouse model where he very carefully controlled the status of T cells using a vaccination in the mice prior to manufacturing or not vaccinating. And he manufactured a product from naive cells or memory cells. And essentially, he saw what you might expect, which is that the naive cells gave rise to a CAR T-cell product with a higher proliferative capacity. It was able to function extremely well at limiting dose. But it had reduced effector function, particularly in the context of low antigen density. In contrast, the memory-derived products were much better killers, so to speak, better effector function, better sensitivity for low antigen, but had reduced proliferative capacity. And I'm not going to spend a lot of time on this, I'll go through it quickly, but he went on and looked at epigenetic profiles of these cells, and what he found was that many of the family members that you might expect, the genes that you might expect to be impactful in this showed up. So the memory-derived cells, for example, had higher expression of BZIP family members. The c-Jun, BADF, these are transcription factors that have been manipulated by others to try to impact CAR T-cell expansion and activity. But also RUNX family members, and then in the opposite direction, TCF family members. Cole also went on to show that if you overexpress RUNX2, in particular in the naive-derived population, he could turn those cells into better killers by opening up loci for granzyme perforin, for example, that we know are important in T-cell mediated killing. He also went on to demonstrate that if you look at other transcription factors, c-Jun and BADF, that others have shown to be important in potentially manipulating CAR T-cell activity, that functional enhancement depended a bit on the status of the cell going into the manufacturing. And so you guys can take a look at the paper, but I think there were some really important insights that came out of this, including, I think, the observation that the status of a T-cell is not completely erased at the beginning. So now I'm going to turn my attention to sort of the other pattern of relapse, which is this loss of antigen, which, is typically thought of, and I think largely, a tumor cell intrinsic factor. I will tell you that we have data that suggests that the CAR T-cell construct, the potency, can also have an impact on whether or not tumors lose antigen, and we're trying to understand that right now. I'm not going to show any data around that. I think many of you know that 19 loss occurs via a number of mechanisms. It tends to be complete loss of CD19. We know that there are a number of really nice papers that have shown that there are alternative splicing that can happen with CD19, and there are de novo mutations within the CD19 genes, premature stop codons, et cetera, that result in loss of expression. So many of you know Neurali, so Neurali took over a clinical trial that I started at the NCI with a second CAR construct targeting CD22, and this turned out to be highly active. I'll tell you, at the time that we opened this study, the CD19 negative relapse pattern wasn't known. It was somewhat serendipitous. We had the study open, and all of a sudden we started seeing the CD19 negative relapses, put the patients on this study, and started seeing very good activity. Ended up being granted FDA breakthrough designation. We learned some things from it, that manufacturing nuances make a difference. The neurotoxicity with CD22 CARs tended to be a little bit less than 19, at least in our experience. And the other thing was that we saw an increased incidence of hemophagocytic lymphohistiocytosis, now called IECHS. And this seemed to be higher than what was seen with CD19 CAR T-cells, although we talked a bit about it last night. I think it might depend on the CD19 CAR. That after 22 treatment, these patients also relapsed frequently. In this case, with down modulation of 22 expression, not complete loss of CD22. So that's a slightly different pattern than what we saw with CD19. Overall, it seems like CD22 is more dynamic. It seems like it'll drop early, and after the leukemia sort of comes back, you tend to see re-expression at prior levels later. But if you look early at the time of relapse, as shown in the graph on the right, the CD22 expression seems to be a bit lower than it was prior to treatment. The other thing I'll point out about 22, and I mentioned this, is that the mean antigen density of 22 is lower than CD19, maybe on the order of about 500 to 1,000 molecules per cell. At least for leukemia, 19 expression is probably about 5 to 10,000 molecules per cell, so quite a bit higher, and I'll come back to this point in a little bit. I mentioned the ICHS that seems to occur in a high percentage of patients, and many of you are probably familiar with Nurali's paper describing sort of the characteristics of this in the CD22 study. It happened in about 40% of patients who developed CRS, and it only happened in patients who developed CRS, which is very similar to what's seen, for example, with ICANS. So we spent a little bit of time trying to develop a model, and I'll tell you, there really isn't a great model, but we started with with perforin deficient CAR T cells, and the reason we did that is because we know that primary HLH is associated with mutations in granulocytic pathways, and so Kazuz in the lab just ran a pretty simple experiment where she made CARs that were deficient in perforin, and then looked to see what happened in the animals. And what she found, as you might expect, is that without perforin, CAR T cells work, but they don't work as well as when CAR T cells have perforin. So perhaps not a huge surprise. That these animals went on to develop huge spleens, and histologically, these spleens showed complete loss of splenic architecture, very consistent with what you see with HLH and secondary lymphoid tissues. And in fact, we saw hemophagocytosis in the spleens of these animals. And we also saw that these CAR T cells that were perforin deficient re-expanded at late time points in the absence of any detectable CD19, which again is something that's characteristic of these inflammatory toxicities. And we found that this was associated with elevations of cytokines that one typically associates with HLH, interferon gamma, IL-1 beta, IL-18 is an important mediator here. And this was similar to what we actually saw in our clinical trial, the same genes and cytokines being upregulated in humans. We used the mouse model to show that if we blocked IL-1 using anakinra, a commonly used drug now to treat HLH, that we could actually ameliorate the inflammation. Did not have a huge impact on leukemic cell clearance. And right now, I think anakinra is maybe one of the gold standards that an interfering blockade in the United States. Ruxolitinib is also being used, JAK2 inhibitor, to treat steroid refractory HLH. And we had previously reported that that targeting IL-1 was effective following the CD22 CAR. One point I'll make on this slide is that if you look at the graph on the right, this is what we typically saw with the CD22 HLH, was a very clear separation between CRS and onset of HLH. It was not CRS evolving straight into HLH. These patients had complete resolution. They left the hospital, they went home, they were being seen in the clinic, they're doing fine, and all of a sudden the ferritins go up. And the ferritins don't just go up, they reach levels that are way above the upper limit of what the laboratory can actually measure. You actually have to dilute the serum in these patients to measure the ferritins. Ferritins are up in the 200,000, 300,000, 400,000 range when these patients get rip-roaring HLH. They also develop a coagulopathy that we never really totally understood. I think our general observation was that there was probably some platelet dysfunction. You certainly see changes in fibrinogen as well. But when patients develop rip-roaring HLH, it's difficult to treat. And so most of the algorithms now that are being used with the 22 CAR are really focused on early detection. So in summary, what we showed was that, CAR T-cell associated HLH, could be modeled with perforin deficiency, and that, our model was that it was due to sustained activation of the CAR T cells due to inadequate killing of target cells, which is what is typically thought to be the pathophysiology of primary HLH. So the other feature of the 22 CAR that I want to just quickly mention is that it's an unusual binder. Most of the heavy light chains that are used to make CARs have a flexible linker that allows for self-association of the heavy and light chain if it's an scFv. The CD22 CAR has a single G4S. It does not associate in terms of the heavy and light chain, results in dimerization and clustering on the surface, and it results in a tonic signal. The other thing is that a non-tonically signaling version of the same CAR went into the clinic at the University of Pennsylvania, and it didn't work. So it turns out that the tonic signal, at least with the CD22 CAR, typically thought to be negative, seems to be important for CD22 CAR activity for reasons that we don't totally understand. And this is just the data on the clustering that you get with the short linker versus the long linker, where you get nice distribution of the CAR in green on the surface of the membrane. And in a really nice paper published by Nathan Singh with Marco Ruella, they demonstrated that if you looked at phosphoproteins downstream of the CAR or the T-cell receptor, you see that at baseline there's evidence of phosphorylation of a lot of these molecules in the absence of antigen. So, we don't really know why the CD22 CAR drives a higher incidence of HLH, but one of the hypotheses we're working with is that it's due to the two factors that I just mentioned. One, CD22 is expressed at lower antigen density, and two, the CAR itself tonically signals, which would be predicted to drive sustained activation of the T cell. And so we've done some work to try to see whether we could remove the requirement for the short linker and the tonic signal. So we took the same binder, M971, which binds membrane proximal on the CD22 antigen, and affinity enhanced it just to see whether it's a very low affinity binder. And so we made a higher affinity version, and this paper's under review, but the long and story short is that we saw very good activity of this CAR irrespective of whether we had a tonic signal or not. So at least right now, it looks like we can get in the preclinical models good activity without that tonic signal using this higher affinity binder. I will mention, though, that for other antigens, CD19, that the Autolus product that I think was discussed this morning in the question and answer with the residents of obinutuzumab, Obe-cel, has very good activity with reduced toxicity. So I'm not suggesting that having a higher affinity binder is always a good thing. I'm just saying that at least with CD22, it's a way to reduce the tonic signal requirement. So I'm going to finish up just with, in the last few minutes, just talking a little bit about some work that we've done to try to think about how you would combine two highly active CARs in the case of leukemia. And certainly, when you think about how you might do this, one way to do this is to obviously manufacture two products and co-infuse them. That's been done at Seattle Children's by Rebecca Gardner and her team, although the CD22 CAR they used was probably the CAR that wasn't functional. So that's not well known, but I think that there's some evidence that it probably wasn't as potent as this one. The other way to do it is to make a single CAR construct that has two scFvs on it, so-called bivalent. We made one. It went in the clinic at Stanford, and what they saw at Stanford and what we saw in the preclinical models, it was very difficult to retain the CD22 potency through the generation of a bivalent CAR. And then the other way is to do co-transduction. We actually put two viral vectors on the same T-cell product. You end up with a mixture then. But the other way that we approached it was to make these bicistronic constructs where you essentially had two CARs in sequence separated by 2A linker. And early on, we did work with this and came up with a number of different constructs that differed in the combination of the co-stimulatory domains in the 19 and the 22. We knew that the 22 really needs a 4-1BB co-stimulatory domain. So the construct that looked the best was one that had a CD22 CAR with a BB co-stimulatory domain, and a 19 with a 28, essentially Yescarta. So Yescarta plus the active CD22 CAR, and this is the preclinical data on that. And there are open trials at the University of Colorado and NIH, and I'll show you a little bit of data in a minute. But one of the things that we've looked at in the lab, and this was data from Eric Kohler's lab by Alex Rankin, was that if you look at the characteristics of these T cells, the dual signaling actually generates some unique characteristics. And so this is just data showing that For example, some of the cytokines are primarily driven by stimulation through CD19. Perforin seems to be equivalent between 19 and 22 stimulation. But when you look at nuclear translocation of, for example, phospholipase C or NF-kappa B, what you see is that you get better nuclear translocation when you stimulate via both antigens. And that's associated with better in vivo efficacy relative to the single antigen CARs and a reduced exhaustion profile of the T cells. And which is a bit unusual given that at least the 19 has a 28, which is typically associated with more exhaustion. So this was abstract that Bryn Duncan presented last December at ASH. So this was the preliminary data at the NIH. There's 100% CR rate in 19 CAR refractory ALL. They're up to 10 patients. We've treated a similar number at Colorado, also at 100% CR rate. The lymphoma experience has been a little bit more tentative, I would say. The CAR seems to be very active. There's a pretty high toxicity profile, and so we're sort of trying to manage that and understand, the right dose to be able to deliver this with. So, more to follow, but at least right now the data for ALL looks promising. And then in the last, 4 minutes or so, what I want to do is I just want to change gears a little bit. I've talked primarily about dealing with CD19 loss. As many of you probably are aware, it turns out that at least in ALL, we also see very complex patterns of leukemic resistance, including complete lineage conversion of a B-cell ALL to a myeloid malignancy. And we had published this early on in 2016 when we made this observation in our mouse model, and about the same time we started seeing the same thing shown on the right, Rebecca Gardner's paper, a case description of a pediatric patient lineage switching post CD19 CAR. And turns out, not a big surprise, these patients do very poorly when they lineage switch, and this was a paper that was published a couple of years ago by Nurali and team. And I encourage you, this paper just came out, I think last week. It's not fully published. It's preprint right now in Blood, and I encourage you to take a look at it. Nurali, these are relatively rare, and I give Nurali a ton of credit. She essentially, working with a consortium, an international consortium, collected 92 cases of patients that apparently had lineage switch. Turned out that 75 were true lineage switch. There were others where the data was insufficient. Almost all of them were BALL. Turns out that there were a couple of T-cell ALLs that lineage switched under CD7 CAR pressure, and this is also in the paper. This is an example of one of the cases sort of shown schematically. It was a KMT2A rearranged leukemia. That's pretty common for these lineage switch patients. You see on the left kind of the phenotype pre-lineage switch, as you'd expect, looks like a B-cell ALL, but as is often the case, a little bit of myeloid marker expression. What you see on the right is what happened post-lineage switch. So loss of 19, loss of 22 as well, expression of myeloid markers, c-KIT, CD64, a monocytic marker, and this is very typical of these patients when they lineage switch. In the paper, they create definitions for this, and the one important point I'll make is that these lineage switch cases retain a lot of the genetic characteristics of the original B-cell ALL, including the same B-cell receptor rearrangements, even though they're truly myeloid. And so these are the definitions that they created. As I said, it tends to be more common in the KMT2A rearranged leukemias, about 2/3. And as I mentioned, outcomes are pretty dismal. This is just showing the survival curve. And interestingly, in the patients who survived, 3 of them, through sequential therapy, had reversion back to the B-cell ALL, showing the inherent lineage plasticity. And so what do you do about this? So we've been thinking about alternative targets. It turns out that these KMT2A rearranged leukemias overexpress wild-type FLT3 receptors. We developed a CAR targeting FLT3. I will tell you the FLT3 is retained on the myeloid version of the leukemias. We've seen that consistently in all the patients, and this is just showing the clinical activity of the FLT3 targeted CAR that we published a couple of years ago. So hoping to get that in the clinic to try that out. So, my last slide here, just to summarize, I think single antigens comparable to 19 they're going to be hard to find, maybe impossible. Obviously, I showed you today that antigen modulation, as well as more complex patterns of resistance, will frequently emerge, at least in ALL. I think we'll probably see the same thing in other tumors. CAR formats, I didn't show you a lot of this data, but, they're T cells, obviously, but they don't fully recapitulate the same biology that you get when you stimulate through the native T cell receptor. And I think we're learning that the details of the CAR construct make a difference. I wish I could give you rules other than BB CARs persist and CD28 CARs don't, but for us it's been a little bit of a trial and error. So with that, I'll stop, and I thank most of the people who did the work along the way, but I'll thank you all for your attention.
Thank you so much, Dr. Fry. Can we give a big round of applause for him? I request both our chairperson also to please join Dr. Fry. We'll be starting with the next panel, so could you be seated on this side? Yeah, on this side. Thank you. All right, everybody, and now I invite Dr. Hasmukh Jain to lead our next panel discussion, treatment selection, sequencing, and post-infusion management in the optimal use of CD19 CAR T in BALL. Dr. Hasmukh Jain is Associate Professor, Department of Medical Oncology, Tata Memorial Center, Mumbai. I would also like to invite the panelists at this time. Dr. Sanket Shah, Consultant Hemato-oncologist and Bone Marrow Transplant Physician, Vedanta, Ahmedabad. Dr. Alka Kadwal, Professor Clinical Hematology and Medical Oncology, PGIMER, Chandigarh. Dr. Santosh Devdas, Professor and Head of Medical Oncology and Hospitals, Bangalore. Dr. Anupam Chakrapani, Senior Consultant, Hematology and Program Director, BMT Apollo Multispeciality Hospital. Dr. Rakesh Reddy, Senior Consultant, Medical and Hematolo-Oncology, Apollo Cancer Center, Vizag. Dr. Shilpa Prabhu, Consultant Hematologist and BMT Physician, Narayana Health City, Bangalore. Over to you.
Thank you. So, so the panel will focus, the discussion will focus on treatment selection, sequencing, and post-infusion management to optimize the use of CD19 CAR T-cell therapy, and also little relevant to our context. So I'll essentially take you through the case scenarios. I've put together the common cases that we see, and I'd like to take the opinion of the panels on how they approach these patients. So these are cases from our clinic. So this is one patient, 26-year-old gentleman, who was diagnosed with BCP-ALL. He was MRD positive after 2 blocks of induction. He was treated with the BFM90 ALL protocol, and he turned MRD negative much later, but then could not get a transplant done. Went on to finish his therapy, and he relapsed during the maintenance phase. So he then received salvage chemotherapy with mini-hyper-CVD inotuzumab. At the time of relapse, he had a good CD19 expression and CD22 expression. So he got mini-hyper-CVD with inotuzumab, attained a remission. And then after the first cycle, he had got, the cells were collected for a CAR T-cell therapy, possible CAR T-cell therapy, and then he was bridged with the second cycle and then got the CAR T-cell therapy. So it's been a year now, and he remains in remission with ongoing B-cell aplasia. So the question that I would like to ask is, what is the choice of salvage regimen in your practice, and how do you incorporate immunotherapy into the salvage regimen, given the fact that there is a concern with the use of inotuzumab? Even if you're planning for an allo transplant, there's a concern that it could increase the risk of VOD, and if you're keeping CAR T-cell therapy, there's also some concern that inotuzumab could interfere with the CAR T expansion. So Dr. Sanket or Dr. Alka, if they can take this question.
First of all, thank you, organizers, for inviting us. So, choice of relapse salvage regimen is a bit tricky. Particularly, the most important part in deciding is what is the intent. If a patient is going to go for any consolidative, either CAR T or transplant, then there makes sense to use the immunotherapy, achieving the remission, and go for the consolidative therapy, because that is the main aim of the therapy. If patient is not going to go for a transplant or CAR T or anything, then I would go more for the conventional chemotherapy regimen, because it is more of a palliative or just extending the lifespan. So rather than going for the immunotherapy, which is a short span, I'll more focus on the chemotherapy in such patients.
Thank you. So I would also agree with Dr. Shah, what he has explained about the salvage regimen. So it all depends upon what is our intent and what is the family's thinking about the relapse and further management and their resources, and also about the supportive therapy. So if we have if patient has relapsed and we have ample amount of funds with the family, and if there is a target, we would first go with the immunotherapy so that we bring down to lesser MRD or negative MRD, and then depending upon whether further funds are arranged, patient can be counseled about transplant if there is a mass sibling donor, or we can go for a CAR T therapy.
So any concerns with the usage of dose, with particular to the dose of inotuzumab, you have that in the back of your mind, even from a transplant context or from a CAR T context?
So yeah, with inotuzumab, it is kind of, there is a concern regarding if the patient is going for transplant, again a concern is about a development of VOD, sinusoidal obstruction syndrome. So or if the patient is going for a CAR T, later on may relapse and again will require a therapy. So we would like to go for a little lower doses than what is recommended of 1.8, but we will go a little bit lower, 1.2 to 1 milligram per meter square.
Okay. Any other panelists?
So practically, basically, whatever the vial is available, we use. As a practical purpose, it is this whole vial is being used for that patient. For the BSA, we might change, and the duration, whether it's weekly, we may change it to 15 days or 10 days or something that happens. With a transplant, we obviously have a VOD, but most of the time what we have seen is a single cycle gives a very good response, and after that we don't go with the second cycle. Rather, he has achieved CR, MRD negative. We just give some salvage chemo for that 6 weeks and then go for the transplant to reduce that.
Okay. So this was one of the recent publications with the use of inotuzumab, because this has been discussed a lot about concern with the use of inotuzumab prior to CAR T-cell therapy. So about 189 patients were analyzed. The patients had received Brexucell. This was a retrospective analysis. And patients were categorized into those who were INO-naive versus those who had been exposed to inotuzumab. And again, these were classified into responders, non-responders, and the response unknown. When you look at the PFS, the INO-naive and the patients who were exposed to INO had a response, had similar outcomes. But if you were exposed to INO and did not have a response, they had, as expected, worse outcomes. This difference was significant on the univariate analysis, but when they did a multivariate analysis, this exposure to inotuzumab did not make a difference. And possibly the reason being that this is more of the biology. It relates to the disease biology that patients who have a less aggressive disease are the ones who are not less likely to be also exposed to inotuzumab. So that was one of the takeaway from this. And the second takeaway was most of these patients had received this before the apheresis at different time intervals, and few of them had received it during the bridging with the median time as short as 3 weeks before the infusion, and in spite of that, the post-CAR T outcomes were similar. So I think there is some data to suggest that inotuzumab exposure may not be really that harmful. Moving on, so when do you consider CAR T-cell therapy in this setting, that is in the setting of relapsed refractory ALL? What is the approach in your practice, Dr. Santosh?
Thank you for the question, Hasmukh. So it's quite context dependent, as we know in the practice. It depends on various factors. Just a salvage therapy many times is able to cure, especially the pediatric patients. We tend to a planned treatment based on MRD positivity or the availability of various options. As of now, our salvage strategy is a chemo followed by some salvage, either CAR T or allo transplant. I think the jury is yet out on whether CAR alone can cure all relapsed ALL patients. We know that it can cure about 30-40% of patients, but addition of allo transplant, if possible, would be prudent. That's something that we counsel our patients.
So is there any situation where you would prefer a CAR T-cell therapy over an allo transplant? So I mean, a patient has been treated with salvage therapy, has attained an MRD negative remission. Is there a situation where you would say CAR T-cell therapy would be preferred over allo transplant in your practice, or to anyone else in the audience?
For example, just as we discussed just now, for example, somebody who's got inotuzumab as a salvage, there are especially 2 cycles of inotuzumab, and has responded, be very concerned about doing allo. Because VOD rates have been very high, and once the VOD develops, we tend to lose patients. So that's probably one situation where we would look at CAR T as an option. And there are especially areas where patient preference takes a huge important role in decision making, where they are not too keen to go through the allo risk, the GVHD risk, etc. And we are looking at a very short duration of a follow-up post-CAR T, and we are able to expect complications and manage complications better post-CAR T compared to a allo transplant, where things can go either ways. For example, a severe VOD or a severe GVHD or a bad viral infection can be life-threatening.
Yeah.
So I think at the time of relapse, actually the subset of patient is very important. All 3 options can be done.
Yeah.
So whether your relapse is quite late, then only salvage maintenance can take care of things. If suppose patient is elderly at the time of relapse, you cannot go for allo transplant. So CAR T is going to be the way to go. Or patient has relapsed multiple line of salvage and still not in remission, then definitely CAR followed by allo SCT should be the way to go. So all these 3 options are feasible based on the patient subset what we are dealing with.
Yeah, please, Dr. Lakshmi.
So this is a 26-year-old male patient, otherwise what we will consider as a fit for transplant. And if the patient has got an MRD negative remission at the end of salvage therapy or whatever, we will try to limit INO doses to one cycle only. And if the patient has reached MRD negative, so I think we can definitely consider allo HSCT over CAR T-cell therapy in this particular scenario. That's what I would look at it.
So do you take into consideration the donor type? So if you have, for example,
Absolutely.
a haplo versus a CAR T, does that influence a decision in the exact same situation?
Absolutely. If it is an MRD negative remission that I have achieved and I have documented that, I'm not, if it is a match sibling donor, then definitely it's a given that I'm going to go for a transplant. If it is a haploidentical, it's a discussion with the patient. But I'm pretty comfortable now with doing a haploidentical transplant, knowing that there is it's proven entity for me. We have long-term data. We know how to handle it now. With PTCY there to help us, then definitely yes. I would still consider it haploidentical transplant in this.
So if cost is not an issue, for haplo, I prefer to go with the CAR T and keep the haplo in the later part of the relapse or something like that. For MRD, it is a no-brainer. We'll just go with the transplant.
Any other opinion?
One more point, not pertaining to this particular case. If the patient, allo transplant is not possible, but the patient is having relapse in the CNS also, so their CAR T would take over.
Would you prefer using CAR T in that setting? Okay.
I just had a question. See, in most of the cases, people who are transplanting preferring CAR T over transplant, if it is a MRD negative, in an elderly case, yes, CAR T may be the option. But if it is a young patient and he is all good, like he is a standard risk, very late relapse, late medullary relapse, no extramedullary, and MRD negative, like on even on NGS. And at that point in time, are we okay with leaving them on CAR T, and after CAR T they have a sustained persistence of CAR T, all negative MRD? So is it okay to leave them, or do you always top it up with a allo SCT, especially in a young patient?
Dr. Terry, would you take that question?
You know, is it on? Okay. I think in the United States, it's center by center, and I think family by family. I really don't think that we know what the right answer is for those patients. And I think, at least for me, you know, there's obviously, if the patient is exactly as you described, they're otherwise no comorbidities, organ function's good, there's a matched sibling donor available, my general sense is that most families are choosing to consolidate the remission with a transplant, even though, as we've talked about, we know that half of the patients who achieve an MRD negative remission with CAR may not need any additional therapy. We just don't know how to predict who those are. So my sense is that, at least in the United States, a lot of those patients are choosing transplant. I think I would agree with what was said earlier. I mean, I think 2-3 years ago, I think you know, that would have been probably a deciding factor. I think the comfort level with you know, with haploidentical transplantation is so much higher now that I'm not sure that it is. It certainly isn't as impactful as it was a couple of years ago. I'm not saying it isn't impactful at all in making the decision, but I think it's less impactful.
Okay, so just to look at some of the long-term data which has come with CAR T-cell therapy in the ALL, this is one of the systematic review which was published, about 1,400 odd patients. This included pediatric and adult patients, real world as well as clinical trial data. What they did show is that there is durability of responses, but again, the transplant was not predefined. The need for transplant was left to the clinician's discretion. So almost 30% of the patients did end up getting a transplant. But they still showed that the overall, the 5-year EFS was 35%, overall survival was 44%. And then when you split it according to the disease burden, a patient who had morphological remission at the time of infusion, they as expected, did well as compared to those with active disease. So moving on, now we have one of these important problems that we have regarding the salvage and the bridging therapy in these patients. So what factors you take into consideration when you decide on this, the therapy options in these patients who are planned for CAR T-cell therapy? Dr. Anupam.
Yeah, so bridging therapy is a bit not a uniform. So bridging therapy is a bit controversial. So when we are dealing with relapsed refractory patients and we are planning to do a CAR T-cell, so our priority to keep the patient alive and fit to take the patient to the CAR T-cells. So definitely we should not bombard with high-dose chemotherapy so that patient becomes sick. But definitely the data suggests that at the time of transplant, the CAR T, the disease bulk is less, means the blast percentage is less, then the outcome is good. So definitely some intervention has to be done. So in that, I think monotherapy with inotuzumab is a good option to bridge till your product is ready for infusion. Definitely chemotherapy in a low dose to keep the blast under control. CNS directed therapy is not much of a help, but triple IT can be given. But as the CAR outcome data has shown that it works very well with the CNS disease as well. So no additional therapy or like cranial irradiation is required as a bridge therapy. Between pH positive and pH negative, I am not sure whether a short course of TKI is going to help in your overall outcome of your CAR T after the cell infusion. So it's a kind of not a black and white decision. It's a patient to patient. You have to take the call what kind of bridge therapy you are going to offer.
So in a patient who's had attained morphological remission before apheresis, would you prefer using a little bit more of inotuzumab to keep the disease under control, or would you just observe or use some low dose chemotherapy? What would be your preference?
So I just share one patient which I did leukapheresis last week, and yesterday night patient developed IC bleed and now he's on ventilator. So patient received upfront mini hyper-C with inotuzumab. After 4th cycle, he had a florid relapse, medullary relapse. We tried to give some salvage therapy like RBED, that etoposide, rituximab and bortezomib. Patient didn't go into the remission. He went into cytopenia. Elderly 71, family was not able to give up. We did leukapheresis by, at the time when the platelet was just 10,000, WBC was 1500 with circulating 22% blast and hemoglobin was fine. We were able to do the leukapheresis, but we could not take him to the cell infusion. Within 7 days he has IC bleed and he's dying. So it's very difficult decision. I think if your patient is young, fit, then you can give some chemotherapy. Definitely lower the disease burden at the time of CAR infusion, the outcome is going to be better.
Any other thoughts? So the question is related to the disease bulk at the time of post-apheresis. In a low disease burden patient, would you still go on giving therapy? Versus, of course, if you have a high disease burden, you will try to get them into some sort of a remission. So particularly in the low disease burden.
No.
No. Any other? Yeah.
So I think what is the most important, what I have learned is over a period of time that you achieve the first remission or CR something, then go for apheresis rather than trying to go for apheresis first and then play with bridging therapy. So better you achieve salvage, because one of the patient, same episode, patient died, that the time product was ready to be infused, patient died because of the relapse. And then all the medical legal and all comes. So what now we have done is we go with enotazumab, get the CR, at least some morphological CR, not MRD, then go for apheresis, and then the bridging 3 weeks we need. Then there is a low dose side chemotherapy along with some CNS directed therapy. That makes sense for that low burden disease. It gives around 20 days. For pH positive, we are much easier because we have so many drugs.
Is there, Dr. Terry, this is a question for you. Is there a concern that when you do an apheresis with active disease in the circulation, does it affect the T-cell quality?
Yeah. I think that's, so I think there's concern about blasts in the apheresis product during the manufacturing. Now, this is really based on a case report and some discussion of a leukemic cell getting transduced during the CAR manufacturing process. I know about this because that patient ended up getting enrolled on the CD19 CAR study. He was actually the first patient on the CD19 CAR study. So there is concern about blasts in the apheresis product. I think most people believe that patients that have a high level of circulating blasts, even if you do a T-cell selection on the apheresis, that it may have a negative impact on the quality of the CAR manufacturing. So I think in that situation, I think there's a higher degree of comfort with giving at least low-dose cytotoxic therapy to reduce disease burden, do the apheresis, and then try to bridge from there if you need to. So.
Okay. Typically, these patients, if they are morphological remission or have low disease burden at the time of apheresis, would you consider doing a response reassessment post-bridging just before the infusion?
Okay, so it depends upon the clinical scenario. So if I have a florid relapsed acute leukemia and we'll try to get the disease burden down first with some salvage treatment and then do a leukapheresis, and if my assessment prior to leukapheresis is suggesting that the disease burden has gone into a morphological CR, I conventionally don't do it again in another assessment prior to CAR T-cell infusion. But if I have done like what Dr. Chakrapani has just suggested in a patient who had a florid relapse, not really going into response with any of the salvage, and we don't want to overdo the salvage, and we have done the leukapheresis, and then we do a bridging, then yes, definitely I would do a response assessment, because as physicians I would want to know what I'm going ahead for that patient, what is the toxicity that I'm going to face for that patient. So our understanding is that if there is active disease or a high disease burden in EMD, CNS or non-CNS EMD, these patients tend to have higher toxicities, CRS, ICANS, as well as poorer outcomes. So I would want to know what I'm going ahead with. So that's what I would.
We routinely do it for all our patients, and just that, especially in a patient who has a bulky disease, or say less bulky, but I mean not to a certain extent, but definitely circulating blast. I wouldn't say it's a florid kind of a relapse, but say 20% odd disease. That is because we have changed the lymphodepletion chemotherapy there. We are using a little bit intense lymphodepletion and we are getting good results. Like recently we've used for a patient who has 60% blast, and I mean he was post-INO, post-TKIs, all sort of things, and maximum therapy on board, and despite that he had a florid medullary relapse. For him we had done a CAR T apheresis, and we tweaked the lymphodepletion. We have given him the fludarabine with cyclophosphamide being capped at about overall about 2 gram per meter square. There was a paper on the EBMT that if there is a bulky disease, you give a high intensity conditioning, lymphodepletion. So post that he went into MRD negative post CAR T, and day plus 100 also he continues to be in MRD negative, and we are planning to top it up with a MUD. This is in a person who has had a post MSD allo. Following 2 years of allo, he relapsed, had a CNS relapse, and all sorts of medullary, extramedullary relapse. In him, this is the plan, but we found it definitely beneficial in doing a just pre-infusion marrow.
One comment. The other thing so unfortunately I've seen this as well, is during bridging therapy, I've seen patients lose CD19 expression on some of their blasts. And that is one scenario where you see I mentioned that, that it's, that the early relapses are 19 positive. Yeah. That is one scenario where the early relapse will be 19 negative, because CAR T-cells are very good at selecting out the CD19 negative clones. So depending how long it's been and what has been given for bridging, it can be worth taking a look at antigen. The other thing I'll mention is that, and I got to look at that paper with the inotuzumab, because CD19 and CD22 are sort of co-regulated. So you often will see with 19 loss, you'll see a drop in 22 expression levels, and you can see the same thing in reverse.
So would you still go ahead and infuse the patient if there's a CD19 antigen loss if the product,
no.
even if the product is ready? No.
I wouldn't. I mean, I think the data is extremely good that those patients will relapse with 19 negative disease. In fact, if you go back to the original New England Journal of Medicine paper where the 3 cases of ALL were presented, one of those patients had gotten blinatumomab. There, I think, was 1% of the blasts or less in the flow plot that were 19 negative, and that patient very rapidly progressed with 19 negative disease. At least I wouldn't. I don't know if anyone else is.
Yes.
Can I ask one question? So, taking to this question, so is there any point of intensifying what Shilpa was telling? Intensifying the lymphodepletion is of any help prior to CAR infusion? In her case, she has done. So, what your suggestion or recommendation?
Yeah, assuming you're saying that we know the patient still has CD19 expression. If they're high disease burden, is there value in enhanced lymphodepletion to try to reduce toxicity, et cetera? Okay. Yeah, not something I've typically done. I'm aware that people are doing that. It makes some rational sense as long as there's enough time between lymphodepletion and the CAR T-cell infusion for, the reduction, in blast count. So it seems reasonable, but not something that I've done.
Yeah, just one quick question. Is that loss of CD19 that you are talking about when you use anti-CD19 like Blina in bridge, or is it with any other treatments as well?
We had a patient who had gotten Blina, had a bone marrow before CAR T-cell manufacturing, 100% blasts, 100% of the blasts expressed CD19. During the manufacturing, the patient got standard cytotoxic chemotherapy. I mean, we tend not to give, obviously you're not giving it with curative intent. You're just giving enough to be able to control disease and reduce disease burden. And the patient was partial CD19 negative with no intervening CD19 targeted immunotherapy. I assume that those CD19 negative cells were probably there before. We just didn't see them.
So one question. So suppose this patient just prior to infusion, like in her case, so CD19 is negative, CD22, as you said, it will be also be negative. Suppose CD19 expression goes down and CD22 is, then what should we do now?
Yeah, I mean, there is data on this. I mean, the patients who lose 19 and then have regulation at 22, their outcomes are terrible. I mean, it's sort of like, I mean, it's partly like those lineage switch patients. I mean, there obviously isn't, as you know, I mean, ALL doesn't express a lot of CD20, so there isn't a lot of other good immunotherapy. So I think in most patients, it's palliative at that point. If they lose both antigens, at least that's sort of been our approach.
So the next thing is, how do you manage patients post-CAR T-cell therapy with the frequency of follow-up, particularly aspects like disease monitoring, infection prophylaxis, and hypogammaglobulinemia. So Dr. Shilpa can start, and others can also join in. Thanks.
So MRD assessment, we generally do day 28, day 100, and it's by NGS as well as by flow. And T and B cell enumeration, again, typically we do it at 1 month, 3 months, 6 months, and at 1 year to look for the prolonged B cell aplasia. Infection prophylaxis standard we give for PCP prophylaxis with the TMP SMX, and we give acyclovir or valacyclovir, and antifungal prophylaxis is only till day 30 we give, or if the cytopenia is longer, and depends on what kind of previous exposures they have had. Again, we would avoid azoles in somebody whom we have already given inotuzumab in the recent past. And hypogammaglobulinemia, so we typically do like serum immunoglobulin levels from day 7, 14, 28, weekly immunoglobulin levels. If they are pan-hypogammaglobulinemic, past history of recurrent infections and other things, we usually top it up. As a part of trial, we had given upfront to everyone IVIG prophylaxis. It was typically given once in every 2 weeks or 3 weeks. And in real world setting, we are only giving to people who are actually hypogammaglobulinemic with the history of infections, which is recurrent infections and severe infections.
Any other difference, particularly with the use of immunoglobulins and antibiotic prophylaxis?
TB&K, the TB cell enumeration is what I've been practicing is monthly, rather than a little different from what Dr. Shilpa is mentioning. MRD assessment both by flow as well as NGS MRD at 1, 3, 6, 9 and 12. TB&K usually for the monthly for the first 6 months. After that, I'm not really sure if it has any major impact in the result of that particular after 6 months. This is regarding disease monitoring. I had just one question regarding utility of PET scan. Would we consider to look for non-CNS EMD? Does that have any benefit in making
So
it?
we have not treated too many who have had non-CNS EMD ALLs, but we have a couple of patients whom we have treated, and in them we have done PET scans as a follow-up. I think there's also a paper published by Dr. Nirali's group where they looked at the activity of CAR T-cell therapy in the presence of extramedullary disease. So essentially they prospectively did a baseline PET scan in every patient who had relapsed disease to document the sites of extramedullary disease, and then they looked at what was the response. But any thoughts on that?
Yeah, I mean, I would say that I know Nirali's experience, and I know at the NCI we were routinely doing PET scans on patients, and even patients without a history of extramedullary disease. And we often, I shouldn't say often, we found patients who had unexpected extramedullary disease. But whether there's utility in doing that routinely, I don't think there's any data to support that yet for ALL. I think the NIH was in a unique situation where they could do that sort of study, so to speak. So I don't think most centers are doing routine PET scans in patients without a history of extramedullary disease. But there's probably variability there.
So this question is to Malhotra sir. Have you noticed any difference in terms of infection, or do you think we should be careful about any different patterns of infection given our experience with transplants? When you're going into CAR T-cell therapy, do we just extrapolate from what we have seen from the West, that's a standard PCB prophylaxis, antiviral prophylaxis, or do you think there's something else that we need to look out for in these patients?
So I think as we are using more and more CAR T as well as bispecifics in myeloma, so we are beginning, we have to be keen observant of that. So all those infections, viral infections and fungal infections are okay. I think the major challenge is when we look at the tuberculosis. because tuberculosis is endemic here, and if you look at the WHO guidelines, they say if there's a latent tuberculosis, that means if the patient has IGRA which is positive or MON2 which is positive, that these patients should receive prophylaxis. Now, when you talk of prophylaxis, the problem in India is about the INH resistance, which is close to 15 to 20%. So that means if you want to give prophylaxis, you have to give both rifampicin and INH as prophylaxis to these patients. And the next question is obviously how long to give this prophylaxis. So, whether to give for 3 months or 6 months. So that is an area which is, kind of under active investigations. If you look at the guidelines from the Gastroenterology Society of India and Rheumatological Society of India, they feel that these patients should receive prophylaxis whenever they are giving any biologicals, in the inflammatory bowel disease or biologicals which are used in rheumatoid arthritis. But somehow in our transplants, we have not seen that high incidence of tuberculosis in our post-transplant patients. So right now we are, just observant on that and not changing our practice of giving prophylaxis to these patients, the anti-tubercle prophylaxis.
And with the practice of using immunoglobulins, do you use them prophylactically, or do you measure the levels and then decide on the immunoglobulins in the post-CAR T setting?
I think in India it's always, some economy or, cost effectiveness you have to see. So we basically follow that if the immunoglobulin levels are low, only then we use the supplementation.
Thank you. So maintenance post-CAR T-cell therapy to Dr. Sanket, Dr. Alka. So is this something which you consider preemptively, or when you consider a maintenance post-CAR T-cell therapy? And this is both chemotherapy as well as TKIs.
Tough question regarding maintenance therapy post-CAR T. We don't have much of the data on that. There are few papers which are suggesting that giving the maintenance therapy might be useful. What we have done in our recent 6-7 patients with the CAR, one of the patient who has lost the B-cell aplasia early but still MRD negative, we have put him in the POMP maintenance and she is doing fine for last 6 months. So for that patients, I think that makes sense for those who are losing. For those who have relapsed on maintenance treatment, and when we are using the CAR T, how much benefit with the maintenance therapy we are going to give them is a question, and I don't think so that gives us much benefit. For yes, pH positive, we definitely tend to give because it is easier to give administration. It gives us as a placebo effect that we are giving something to the patient more. Even if it is MRD negative, BCR-ABL negative, we give it to the patients, probably 2 years is or so. With that starting time, probably it's once the patient is stabilized, usually at 3 months is probably when we started. I think so.
So right now we are not using any maintenance therapy post-CAR T, but rightly said, in pH positive patients, so we monitor BCR-ABL. Once we see there is a rising trend, we initiate TKI.
Any other thoughts on this?
There is some, in lymphoma space, there is some data of using BTK inhibitors, especially in patients who are worried about a central nervous system involvement. That's the only thing I've come across. I'm sure, I believe you also have a trial with nivolumab in the post-transplant, post-CAR T.
Any comment on that, Dr. Terry?
No, I think I agree with everything that was said. I mean, I think, I think centers with pH positive patients, if, as was mentioned, if they lose B-cell aplasia within the first 3 months, there's a huge concern that those patients are going to relapse, 19 positive, and most centers would start probably maintenance in those patients. Whether there's any value in starting it, sort of prophylactically, so to speak, irrespective of what happens to B cells, I think in many ways it makes the physicians feel better that they're doing something, as was said. I'm not sure there's any data that really supports it. I'm interested over time in seeing, now that there's a number of, obviously molecularly targeted agents for lots of different subtypes of ALL, and I mean, I mentioned the lineage switch, right? I mean, in that case, there's, approved, agents, epigenetic regulators that are used in those patients. They're not great, obviously alone, but in post-CAR maintenance, there may be some value there. And I think we don't have any data yet.
I have just one different question, like maintenance. So based on CAR T persistent and loss of B cell aplasia, is there any study or has been done to do intermittent CAR, like every 3 months see the CAR persistence and do multiple infusions?
Yeah, I know. Certainly, I know centers that are. Is this on? Okay. I know centers that are reinfusing, particularly with the academic trials, are reinfusing CAR T cells if there's loss of B cell aplasia within the first 3 or 6 months, depending on the center and kind of your belief on that. Again, I'm not aware of any data that says that those patients do better. You can definitely, we've done it with some of our academic CD19 studies, and you can definitely re-induce B cell aplasia, right? Whether we're actually helping the patient is, in terms of their, leukemic relapse, we don't really know yet.
Just a question. If there is a CAR T persistent and loss of B cell aplasia, is this the time that you just take them up for transplant if everything is ready? Because they are definitely going to relapse in the next few months. And we have everything in place, so should we just go ahead with the transplant?
Yeah, definitely. I know there are centers that will make the decision about transplant based upon duration of B cell ablation. I know that for sure. And I do think the data. I think it was probably originally it was Rebecca Gardner on that Platt study, where she showed pretty clearly that the patients who lost B cell aplasia, certainly within 3 months, it was close to 100% of those patients relapsed 19 positive. So I think if there's a good transplant option and that happens, I think that's commonly done in the United States.
So I think one of this series was published by the UK group. This is a registry analysis of patients who received multiple different types of CAR T-cell therapy. What they did was they monitored for loss of B-cell aplasia. And they looked at what are the outcomes with each of these strategies. And the 6 patients who did not get an intervention after the early loss of B-cell aplasia, all of them relapsed. But then some of them also got maintenance, some of them got allotransplanted, a few of them got reinfusion. The numbers are very small. As you can see, only 11 patients got transplanted versus 8. And when they compared the outcomes, it seems that they seem to be doing well. But I think presently, if there's an early loss of B-cell aplasia, I think most of us will act at that point of time. Now, whether it's transplant or whether it's reinfusion or whether it's maintenance is something which is a question that needs to be answered. Okay, so this is a second scenario. Given the fact that we don't have access to blinatumomab and everywhere else MRD positive after 2 blocks of induction, you would consider blinatumomab. So we are faced with this situation very often. A 22-year-old young chap, BALL, MRD positive after 2 blocks of induction. This is a patient again who was treated with us, got bridge therapy with high-dose methotrexate. IFRS bridge therapy with high-dose methotrexate, remained MRD positive and then got CAR T-cell therapy. He had a persistent response for about 7 months and then subsequently did have a bone marrow relapse. So would you consider CAR T-cell therapy in a setting where you just have persistent MRD after 2 blocks of induction?
Yeah, so it's a difficult situation for the patients, as Dr. Terry has presented that the relapse is whether CD19 positive or negative. Based on that, your decision of second CAR will come. So suppose it is negative, then the outcome is very bad. So you need to think about dual CAR, which is not available with us. So some kind of salvage followed by haplo or allo transplant is the option. Risk versus benefit, CAR T therapy versus LOSD, MRD, definitely.
But before that, so if the patient is having a CD19 expressing MRD positive disease after 2 blocks of induction, would you at that point of time consider CAR T, or would you still want to give some salvage therapy and try to take them for a transplant?
So in your case, you have done the CAR T followed by MRD negativity, and after that, the patient should have been consolidated with allo transplant, which was not done.
So what I'm saying is that at the point when the patient is MRD positive, would you even consider CAR T-cell therapy at that point of time for a patient who's just MRD positive after 2 blocks? So, or would you take an alternate approach?
I think with the availability of CAR T and the non-availability of this blinatumomab and cost and all this, I think CAR T is a good way to take the patient into MRD negativity and consolidate with LOSCT. I think that is the way to go before your patient become very sick or unwell for a definitive therapy.
Any other thoughts on that?
I think that is an ideal scenario, but the cost is too high for our country. So practical purpose, I think when it is MRD positive, you use inotuzumab and use either CAR T, or better use allo transplant rather than using CAR T as a bridging and then go for the transplant, which is practically not feasible at all.
So this is a situation where we have a refractory patient with heavy disease burden at the time of infusion. So 29-year-old patient was diagnosed with BALL in 2021, had practically a progressive disease, did not respond to any line of therapy. Initially with the CNS testicular response, relapse, received more chemotherapy, then had CNS progression, followed by bone marrow progression. So at the time of apheresis, that was the only time when probably he had the disease under control, but even between the apheresis and the bridge, between the apheresis and the infusion, the disease again progressed rapidly. This is a CD19 expressing, uniformly expressing blast population. This patient was given talicaptogene, autolysil, and this patient had a relatively stormy course with sepsis and CRS and neurotoxicity. So, a similar scenario where the patient had a second CNS relapse, a pH positive elderly lady, and was treated with mini hypercivity and inotuzumab, had persistent disease, and before the infusion had 15% blasts. So the question is, this scenario we get when we have patients with heavy disease burden, they're refractory to chemotherapy, inotuzumab, and you're forced to take them up, you're forced to make that decision of whether you want to go ahead or not with that CAR T-cell therapy. How do you approach this scenario in your practice?
This in the morning with Dr. Nilapu regarding why it's important to get a reduction in disease burden and how we should do everything possible to reduce the disease burden before we take the patient for CAR T. And definitely that is something we strive to do. And we definitely know that lower the disease burden, the better the outcomes. Regarding extramedullary relapse, we know that in ALL there is some data regarding benefit of using CAR T and long-term responses. In our experience, at least the ImmunoAct experience, we have seen the ALLs doing better even in the extramedullary disease compared to, for example, lymphomas.
So would you use CAR T-cell therapy in this setting when you have heavy, other to Dr. Shilpa or to others?
So my thing is, like in our practice, what we have seen is any patient with the ALL with the CNS disease, especially we had some patients with the nerve infiltration, neural infiltration, sacrococcygeal mass with the neural infiltration. Those people, they go into remission, but again for a short while, and again they relapse with that persistent disease in the nerve. So I don't think, we didn't find CAR T that useful. Neither is transplant that great, because they eventually, so that kind of a disease is bad. Although CNS disease, we have had a good response to CAR T as well as this. But if it is like neural infiltration, then it is pretty bad.
So I'll just summarize some of the data. This is the trial data. When we, this is the cohort of patients who got, ALL patients who got the CAR T-cell therapy. So as you can see, 15 patients actually got infused, and many of them have still ongoing responses. The PFS was around 50%, and this was true even according to the disease burden. According to the disease burden, if the disease burden was high, these patients did not do as well as the ones with low disease burden. What has changed in the real world setting from this experience is, I think, this early data, as we look at Jan 25 till Jan 25, about 250 patients were apheresed, 200 have been infused. And about 80 of them have been leukemia. I think the most important change has been the average blast percentage on the trial was 60%, but the average blast percentage here is 2%. So typically the patients of some sort of a disease control only are getting infused with CAR T-cell therapy. The median vein-to-vein time still remains 4 weeks, and it is similar to what was on the trial. But the survival outcome seems to be better. Again, this is early follow-up, but it seems to be better compared to what we saw in the clinical trial, and now this is across the centers. So I think this is one thing which has changed for us. I'll just take up the last question. Dr. Rakesh, sorry.
One point I was going to make, the high disease burden patients, just remember that the other thing to remember is that the early Children's Hospital of Philadelphia study, they split the infusions for patients with high disease burden, and that is also true for the obe-cel study. So, not something I've done routinely in my trials, but it is something that is worth considering in high disease burden patients. And I think in the CHOP trial, they gave 10% of the dose initially, and then the other 90% like a week later. So, I mean, that is something to consider.
So, Dr. Malhotra, any comment on that? Since on your trial also the fractionated strategy was used.
Yeah, so doing a fractionation definitely helps you because, in a high burden disease, you have a CRS, so you do have a flexibility, once the CRS settles down, so then you can give the second dose. And we have seen that, once the first time the CRS is, the incidence is high, but after the second dose and the third dose, the incidence goes down. So that is a good strategy, but obviously we need more information on that, whether this strategy works in a long-term basis or not.
So the last question, Dr. Rakesh, Dr. Shilpa, you mentioned about the risk of concern with neurotoxicity, and as we are using more and more of these therapies now in patients who have CNS disease and have received CNS-directed therapies, which is not the case in the trials, your thoughts on the concern about neurotoxicity and any strategies to prevent them?
Okay, so in patients who had obvious CNS disease, there is obviously concern whether neurotoxicity, especially ICANS, is how much of a concern would it be. So whatever literature that we have now, I can't say for certain that it definitely correlates. There is definitely an increase of grade 1 and grade 2 neurotoxicity, ICANS specifically, and the grade 3 or irreversible ICANS is probably not as correlating with the presence of CNS disease. Obviously, the response is a different entity altogether. These patients will not do as well compared to those who do not have. But predicting the risk of neurotoxicity, we have to be more vigilant. Grade 1, grade 2 definitely higher. Grade 3 and irreversible ICANS is not as correlating with CNS disease.
Dr. Shilpa, any thoughts on that?
So in our real world setting as well as in trial we had not used the CNS disease, but in real world setting we have used it for CNS disease. And in this what we saw was that there was no grade 3, grade 4 ICANS. Probably the fractionation is the one which is a thing because we give it at day 0, day 7. In lymphoma cohort, when we have given as a single infusion also for a patient with secondary CNS lymphoma, it has not caused any much of ICANS. So I would not score it that way. Probably the bridging works well. So that's
okay. So I'll just summarize with the safety. This is the trial data. Safety, as we've discussed, the humanized CAR Ts have generally been much safer in terms of the lack of neurotoxicity as compared to the other products, where typically about 15 to 20% of the patients will have a grade 3 or more neurotoxicity. But this is the data now from the real world experience. So we do see some neurotoxicity now coming in, but still the grade 3 grade 4 neurotoxicity still seems to be less than 5%. So that has been the finding, and yeah, with this I conclude. So any questions from the audience? Yes, ma'am, please.
This is Rajat. So I'm going to ask Hashmukh, your MRD, the persistent MRD, as the famous Jim Nachman used to call it a maximal residual disaster. So I think 2 cycles, MRD positive, this is chemo-refractory disease. You need to change the strategy of immunotherapy. So how do you, ICE transplant or CAR T or CAR T plus transplant, vice versa. So how do you take it? Do you try Blina, I know, and then transplant and risk the CAR T efficacy, or you say, okay, no, we take the CAR T and then just what? I think in the Immunact product, there will be one natural selection that many patients cannot afford a transplant after CAR T. And so that will probably, I think I'll ask you guys to just monitor that data very carefully, and it will be a natural selection. You know how many patients you can just cure with just CAR T. And this is relevant for pediatrics because we don't want TBI-based transplant. And not we, parents don't want a TBI-based transplant. So I don't know how to sequence, whether to give Blina and then risk CD19 downregulation, and then if the patient doesn't go into remission, then you're a little stuck with the CAR T efficacy.
So I think the pediatric group, I don't know, Gaurav sir is there, but pediatric group has experience of using Blina. We don't have an access to Blina, so we hardly, I've personally never given Blina to any patient, so that's one. So Blina is practically out for us. So we end up using CAR T-cell therapy. So the next alternate CD19 directed therapy which we have is CAR T-cell therapy. So we end up using CAR T-cell therapies. And of the patients in the real world, most of the patients in the real world have been in remission, but half of them at least have been the ones who are persistent MRD on chemotherapy. So they have got CAR T-cell therapy. At our center, none of these patients have got transplanted. Again, I think that's the experience across the country. Not many patients are getting transplanted post-CAR T-cell therapy for various reasons. So it gives us a chance to actually look at the persistence and whether this therapy, this approach of using CD19-directed CAR T-cell therapy alone is a sufficient strategy. So that I think will take time, but I think it probably answers that question of whether we really need to do a transplant or how good this strategy is. Any thoughts on that, Dr. Malhotra, Dr. Terry?
No, I mean, I think that the scenario you described is one that is being discussed a lot in the United States in terms of, persistent MRD after a certain number of blocks. We know those patients are going to do poorly. I think there's a bit of a debate because, intensifying chemotherapy may be beneficial in those patients. And so I think the leukemia non-CAR T-cell doctors will tend to do that. The CAR T-cell doctors will start thinking about CAR. Unfortunately, it's not in the label right now, so that needs to be done in academic studies. And there is a discussion to do that study in the COG using actually obe-cel, potentially.
Yeah. Thank you, Hasmukh. It was an excellent discussion and a lot of hands-on experience from India. We discussed the role of CAR as a bridge therapy to transplant. Any experience of the house in a young fit ALL patient Ph positive who has relapsed after a matched sibling donor transplant? So anybody has, with isolated CNS relapse, so anybody has used CAR T post-transplant relapse? Any experience or professor you have?
Yeah. Any comments?
We had one patient who was ALL in 2013, then relapsed in 2019, haplotransplanted, then again relapsed in 2014, didn't want any transplant, so we did the CAR T, and now it is around 1 year. He's still MRD negative, immunoglobulin dependent, doing good as of now.
Okay, thank you.
So I'm Aditya from TMC Chandigarh. So my question is regarding the mitigation strategies for CRS. So we discussed about splitting the dose. I want to know your perspective and the perspective of panelists regarding the prophylactic use of tocilizumab in India, given the risk of tuberculosis reactivation and the concerns regarding INH resistance raised by Dr. Pankaj.
Yeah, a number of years ago, I have to go back and look where it was. I believe it was in Russia. They did a prophylactic TOSI study, and actually what they saw was a higher incidence of ICANS. So it is one of the things to pay attention to. Remember, tocilizumab as a drug leads to increased levels of IL-6. Tocilizumab itself, as a receptor antagonist, does not cross the blood-brain barrier, so you end up with high IL-6 concentrations in the central nervous system without the TOSI. That's the hypothesis. So I think there's a little bit of concern for TOSI prophylactically. It hasn't been well studied, but I know there's been some, and there are people considering other agents. I actually know some centers that are giving very early steroids, low dose steroids, instead of waiting for patients to develop grade 2 or grade 3 CRS. If they know they're high risk, as soon as they develop fever, they start giving those patients steroids, and it doesn't seem to have an impact on CAR T-cell activity. So,
thank you.
In these patients whom they have given low-dose steroids, I presume it is dexamethasone, and if that is so, whether it affects the CAR T persistence? Because there were previous studies where dexamethasone interfered with CAR T persistence.
Yeah, I mean, I think the data suggests that, others can chime in. My interpretation of the data is if steroids are given after onset of CRS, at least some fever, I think the data suggests that there is no impact on CAR T-cell efficacy. I personally worry about giving prophylactic steroids before the CAR T-cells begin to expand. So I'm not sure I would recommend, and again, not because there's great data, but I'd recommend giving steroids immediately after lymphodepleting or after CAR T-cell infusion. But that's been my interpretation. I don't know if others feel different.
So just to answer Rajat's question as to Blina versus CAR T. So fortunately, the pediatric side has access to Blina, and what we have seen that most of the patients go into remission. Our problem is that we are not being able to take them to transplant, but they remain in remission for at least 4 to 5 months, which gives a window of opportunity to go for transplant. So I think Blina will work as well for our patients, provided again your blast percentage is less than 5%, and we have seen very good responses with Blina.
So, Dr. Rajiv from Kolkata. We know that post-CAR T transplant, non-transplant, there is a confusion and we are not reached to a point. But while counseling the patients, we need to give some specific informations to the patient's relative. Now, for the time being from this forum, can we select few indications where from the beginning, not that after doing CAR T, if relapses, see. So in these conditions, we need to do transplant so that patient's relative can take decisions whether they are want to go for CAR T or again intensive chemotherapy followed by transplant. So some indications which we can do before counseling.
I think that's really, at some point, that's what we need to figure out is, I mean, again, it's 40% of patients who get CARs, 30, 40 who have durable remissions. Half of the patients who go into relapse will stay in remission. Go in remission, will stay in remission, half will relapse. I don't know of any great studies that have indicated which patients are high risk, but I think we talked about a few here. I mean, I don't know, for example, if you do have a patient where the flow suggests that there's some 19 negative blasts, for example, and you give a patient CAR T cells, you do a marrow and they're MRD negative, I would not wait in that patient. I think the patients who lose B-cell aplasia are worth considering. I think the high disease burden patients, some of them will achieve a CR, but the data suggests that those patients might be higher risk for relapse. Actually, the Obicell study showed that pretty clearly. So, I mean, I think there are beginning to emerge some subsets where you might be a little bit more worried about relapse, but I'm not aware of any data that systematically looked at those risk factors.
Any particular genomic subtype you would be worried about? Any particular genetic subtype?
Yeah, it's an interesting question. I mean, my interpretation is that even the traditionally high-risk ALL subsets tend to do well equivalently with CARs, so I'm not aware of any data. I think I saw something recently about maybe P53 mutations, but I have to go back and look more carefully at that. But I think in general, it seems like CAR T cells, unlike standard chemotherapy, seem to work pretty well across a range of subtypes of ALL. The KMT2A, the infant ALLs, we were worried about those patients. And even with the lineage switch, I mean, the outcomes are pretty good for infants if they get CAR T cells early. So I'm not aware of any.
So I think we'll have to wrap up. So thanks the panelists, the chairpersons, and thanks the organizers. Thank you so much.
All right, everybody, can we give a big round of applause to all our panelists, moderators, and our chairs? And now I would request our chairpersons to please present the mementos to our panelists and our moderator. Can we bring up the mementos? Can we have some BGM, please? Ladies and gentlemen, we'll be starting the next panel discussion at 11:30, so please be back soon. All right, everybody, we can start going up with the round of applauses. That's for our moderator. All right, everybody. Thank you so much, everyone. Thank you to our moderators, panel members, and to our chairpersons. Thank you once again. All right, everybody. So we'll go for a short tea break now, and we'll be back at 11:30 right here. मैंने किया हर बार किया Ladies and gentlemen, please welcome on stage Check 1, 2.
I'll go with the checkout announcement now.
All right, everybody, welcome back from the good, healthy tea break. And it's a quick, gentle reminder for all our guests to please make sure that you check out before 12 p.m. out of your accommodations. And also, if you need any sort of assistance in regards to the coordination for your flights and logistics, please feel free to reach out to our registration desk just outside. Well, ladies and gentlemen, we are now next moving to our panel discussion, which is on a very important topic: treatment selection, sequencing, and post-infusion management in the optimal use of CD19 CAR T in BNHLS. To chair the panel, I request two distinguished faculty members. Please welcome Dr. Lieutenant General Velu Nair, Head and Chief Consultant, Hemo-Oncology and Bone Marrow Transplant, Apollo Cancer Center, Gandhinagar, Gujarat. Dr. Vikram Matthews, Professor of Clinical Hematology and Director of Kristen Medical College, Vellore. Dr. Dinesh Burani, Director, Hemo-Oncology and Bone Marrow Transport, RGCI, Delhi. A big round of applause to all the three of them. All right, everybody, and now we will be moving on to our panelists and our moderator for today. We have got Dr. Asha Kaul, Director, Medical Oncology at Max Super Speciality Hospital, Delhi. I would also like to invite the panelists, Dr. Priyanka Samal, Professor and Head Department, Clinical Hematology at SUM Hospital, Bhubaneswar, Dr. Sameer, Consultant, Hemo-Oncology and Bone Marrow Transplantation at Kokilaben Dhirubhai Ambani Hospital, Mumbai, Dr. Jeevan Kumar, Senior Consultant of Clinical Hematology and Bone Marrow Transplant at Tata Medical Center, Kolkata, Dr. Ram Abhinav, Consultant Medical Oncologist and Hemato-Oncologist, Kovai Medical Center and Hospital, Coimbatore, Dr. Ramaswamy, Head of Department of Clinical Hematology, Lizzie Hospital, Kochi, Dr. Deepam Pushpam, Associate Professor, Department of Medical Oncology, AIMS, New Delhi. A big round of applause for our panelists, our moderator, and our chairperson. Over to you. Help you with this.
Thank you so much. Very good morning to all the audience, esteemed chairpersons, and my panelists. So we've had a very, I think, exciting leukemia panel discussion already. It just brings to the front that there are so many unanswered questions still. So when we are talking about this panel discussion, I think there are no absolute rights or absolute, wrongs. So this is just, whatever experience we have gathered in using this product for the last year and a half, just to, bring that to the forefront, discuss it, and see, how we are going to take this forward. The panelists have already been introduced. So the first case, so this is a 44-year-old woman who initially presented with a left supraclavicular mass, diagnosed with DLBCL, GCB type. She's staged as a stage 3, undergoes standard R-CHOP for 6 cycles. So 2.5 years after her initial treatment, she again is now diagnosed with a relapse confirmed on biopsy. Good performance status, no comorbidities. So this is a scenario which is not so common because this kind of late relapse in lymphoma is seen in about 20% of situations, but it's still seen sometimes. So now that we are spoiled for choice, my question to Dr. Priyanka, what is your choice of salvage regimen in this situation? And how do you come to that conclusion? How do you think about what regimen you're going to use?
Yeah, thank you, Dr. Isha. So she is a 44-year-old female. Then it is 2.5 years post her therapy she is completed, so it's a late relapse. It should be possibly a chemosensitive disease, I feel so. So the normal protocol which we are using is RGDP. So I would go with 2 cycles of RGDP followed by an assessment, and if still it is a chemosensitive disease, as we expect in a late relapse condition, would consolidate with the transplant, auto transplant.
So any reason why you go for RGTP as your preferred
Yeah, that is
regimen?
because we can give it on a daycare basis.
Okay.
So that is one of
Okay.
the reasons. And there are multiple trials which have showed that in spite of these 4, we have 4 or 5 salvage regimens, they almost have the same outcome as per the response rate as well as according to the PFS.
So by and large, I think we can all agree that this is a patient who's transplant eligible by virtue of her age and performance status and the fact that she has a late disease. So, everything is on the table. There is very little data to say that one is better than the other whenever these have been, used head to head. Of course, with the advent of bispecifics now, the choice of salvage has become a little bit more complicated. But in general, chemoimmunotherapy, platinum-based, generally is the standard. Dr. Ram, is there any situation in which you would say that, okay, this kind of salvage I'm absolutely not going to use, or your experience, or for the audience, your thoughts on that? Absolute no's for combinations or drugs that this patient should not be exposed to.
Stem cell toxic regimens like bendamustine based, I would generally not use.
And why would that be?
Because this is the apheresis and the chance of stem cell collect, that'll be a problem. And also, if in future CAR T-cell therapy is going to be planned, there's a T-cell quality problem with the use of bendamustine-like regimens.
Right. So, when we look at the NCCN guidelines, they basically for second-line therapy, they are divided by the time of relapse. So this is a late relapse, likely to be chemosensitive disease, transplant candidate. So you can use anything, but a lot of preferred regimens are coming as being in combination with bispecifics. However, one important takeaway is even though this patient is being planned for transplant, there may be a CAR T or a bispecific will come as 3rd line or 4th line in this patient. So you absolutely don't want to give a bendamustine based salvage. One thing that has come out clearly is that any exposure to previous bendamustine containing regimens adversely impacts CAR T survival. A lot of randomized data retrospectively looking at patients who were exposed to bendamustine has clearly shown inferior PFS and overall survival, just response rates in general. But the second question is if the patient has already received bendamustine, if when the patient is coming to you, you can't avoid because the exposure has already happened, how do you factor that in? And the second thing that you have to think about is the duration from the time of bendamustine. So bendamustine actually has one of the longest washouts. So you do try that the exposure be more than 9 months if possible, because a very recent exposure within 9 months is one that is associated with inferior outcomes because it impacts the T-cell quality and manufacturing. All right, so RGDP.
Just a minute, Dr.
Yes,
Isha,
yes, please.
I would say that even for a autologous transplant, we try to avoid bendamustine because it even hampers the mobilization of the stem cells. So we
That's right.
Yeah.
That's
so for
right.
the CAR T as well as for this, we would try to. I think bendamustine will go much below down for the present scenario, whatever the options we are left with.
I think that's a great point, and I think in the situation where we have so many other salvage regimens to pick, unless there is a situation where you know absolutely for sure that this patient is not going to go for CAR or transplant or bispecific, a very elderly patient, but it still happens that the patient is referred from the community. Bendamustine is used very widely for lymphoma in our patients, so I think we sort of have to modify our strategy. Even if you are somebody who's not doing transplants or CAR T, you don't want to impair somebody's candidacy for these treatments by exposing them to bendamustine. So I think that's one message in the practicing community of oncology that we should spread. RGTP is very popular in our country, like Dr. Priyanka said, by virtue of it being easy to administer, outpatient, cost effective. It's quite fair. So now this patient has achieved a CR. You have 3 cycles of RGTP. Are you absolutely clear in what you are going to do? Is it going to be a transplant, CAR T, anything else? Dr. Ramaswamy, do you want to discuss that?
Because she has responded CR and more than 2 years the relapse, so definitely that cost effective and confirmed trials, I will go with autologous stem cell transplantations, and that's my priority.
Any counter arguments? Anybody wants to differ and say that don't transplant, go for CAR T?
At this sort of point, I think if the patient is absolutely fit, then I think auto transplant makes the most sense. But for some reason, if the performance status is not all that good, or they've got a bit more comorbidities, then one may consider going for a CAR T therapy in this sort of situation, because beam, I think conditioning is quite intensive. So, if the performance status is not all that great for whatever reason, then maybe CAR T may be an option here.
Right. So I think when we talk of transplant, it's both things, right? It's whether the patient has chemosensitive disease, but it's also the patient's eligibility, because auto in general, the morbidity, mortality associated would be higher. And even though this patient is fit and eligible, there might be situations in which a patient just prefers to undergo a CAR T. I think it's likely that we will be faced with this situation where the patient might say, I just do not want to take a more toxic regimen. So I think these are questions that we will be faced with.
I think, but the retrospective analysis from Dr. Shadman actually pointed out that there is probably in a chemosensitive disease, probably autologous transplant might be better than CAR T-cell therapy. That is something you'll also probably have to take in mind.
Right. So, there are broadly some areas of agreement in looking at all the data that we have, that for primary refractory or early relapse disease, there is basically no role for, autologous transplant in that situation. But for selected patients, there might be of benefit for a minority of patients. Looking at the trials, where randomized trials, we obviously have some retrospective data, but prospective randomized trials are the gold standard, where CAR T-cell therapy has been compared with standard of care. But when looking at the results, we have to see what these patients were. So these were patients who had relapsed within 12 months. So that was part of the inclusion criteria. And in that setting, in a randomized setting, the response rate as well as survival of CAR T was superior to standard of care mostly being autologous transplant. This was true for both Axicell as well as Lisocell in the Transform trial. So CAR T is superior in second line in patients who are who are relapsed with less than 12 months, but it's expensive, it's complex. I mean, we hope that the costs will continue to come down. And at one point, we might be at a time point where cost is no longer a factor in taking this decision, where the cost is nearly comparable. And actually, I think even in the West, logistics has been a very big issue. When the product was launched here, we also thought that logistics was going to be a major factor, but my experience is that it is not, in fact, that much of a factor. We are vein-to-vein time or decision from planning to infusion time has been better than I think any of what we expected. So I think if we even take cost out of the equation and we say that we can get the therapy ready and going very quickly, that's where it becomes really tricky as to what you do. And also in a situation where patient is eligible for CAR T or likely to benefit, it's one thing is clear that the longer you wait, the more lines of therapy, the efficacy reduces. So do you really want to expose the patient to several lines of treatment and move there? But we cannot completely discount autologous transplant at this point. Sometimes whether it's organizing money or just logistics, it takes time, but salvage you can give quickly. There is, the data which we were talking about as to the response in chemo-sensitive patients. This is CIBMTR retrospective analysis. So it comes with a lot of confounders as to why the treating physician chose auto versus CAR in these patients. But in patients who underwent salvage and achieved at least a partial response, the outcomes seem to be a little bit better than CAR. So the survival was 69% versus 47%. So I think we cannot completely discount autologous transplant. So if you are in a place where it's not available, you can still offer it to chemo-sensitive patients. But again, with a pinch of salt, with a lot of confounders being retrospective analysis. Anything else that anyone wants to add on the panelists in the transplant versus? All right. So, but unfortunately, most patients actually, 80% patients actually relapse sooner, within 18 months is, what we know. And we know that time to relapse is one of the strongest adverse prognostic marker in lymphoma. So this is just summarizing what we discussed. Okay. So this is another situation, a second case. So this is a 55-year-old man, presents with B symptoms, abdominal pain, imaging suspicious of lymphoma. There is a large mass, 8 into 8 centimeter. It's diagnosed high-grade B lymphoma, double hit. He starts off with R-CHOP, receives 3 cycles, and you do an interim PET, and at this point there's about a 20 to 30% reduction in the size. Some reduction in activity, it's dual 5 right now, and some improvement in B symptoms which were present. So this situation, how would you approach? Dr. Deepam?
So this is a primary refractory DLBCL, and post 3 cycles it has not responded. So I will not go for any further R-CHOP. Ideally we should plan for CAR T in such patients.
So you think that this is a clear-cut situation of declaring this patient at this point as being refractory and planning a CAR?
Yes.
Dr. Jeevan, any thoughts?
Yeah, I also agree with, because this patient has a primary refractory disease and this patient had DLBCL which is double hit. So as such, we are predicting that the response will be less. So we can directly take this patient for CAR T. In between, if we have some delay in CAR T, we can give some bridging therapy.
Anyone want to just try something else, give an RGTP and then do a little bit of radiation? Is there any thought of that? Maybe this patient can still get cured?
Only radiation cannot cure this patient. This is already double hit lymphoma. So even autologous transplant results are very bad in a double hit lymphoma.
Right. Dr. Priyanka, do you want to make a comment?
If the patient is willing for a definitive therapy, I think we need to be more aggressive, get the patient into a little bit of more remission status. Might be I will introduce POLA in this case, or if it is a CD30 positive rituximab, add it on and then proceed for either for an auto transplant or for a CAR T. But as Dr. Jeevan just said, that even an auto transplant is not that fair enough in a double hit lymphoma. So possibly CAR T will be a better option in those cases.
I think in theory we can all agree that this is the situation. I'm not sure if this kind of a situation, this is what might happen in the community. Any comments from any comments from you, Dr. Nilapu, about this kind of a situation?
Yeah, so definitely. So I agree.
Should we just completely give up on trying to cure this patient without a transplant or CAR T, or is there still some role of trying to do that?
No, so I agree with the comments that were made. I think this is a patient where CAR T should be the preferred option. With primary refractory disease, the outcomes with auto transplant is long-term durability is less than 10%. So I think it makes sense to move forward with CAR T in this setting.
So yeah, I think the data is clear on this to a large extent, but I think the gray zone might be in some situations where you, yes, Dr. Ramaswamy, please.
At this point of time, because his performance status is clinical symptoms are improved, I will collect the T cells now. This is the time he is symptomatically better without going for any salvage.
Yeah.
After collection, I will consider to give us something bridging and then I'll go for that.
I think that's a good comment. The challenge, I think I've made this in a way that it's clearly that this is a refractory disease, but there might be situations where, if you look at the response criteria, it might be sort of in the gray zone where one person looks at it and says that, no, this is a partial response, keep going, and there might be another interpretation which might say that this is refractory and don't go. So that's how it might be. And I think a lot of people still may not give, just plan and declare that this is bad, and they might still receive a few more different iterations before being labeled as chemorefractory. And so I think that kind of messaging, also the importance of interim PET. I mean, in lymphoma, treating lymphoma, we've always recognized the importance of interim PET, but are we at a point where just on the basis of a not so satisfactory interim PET, we are planning for CAR T?
Because it's clearly score 5. So there is no question of whether it is a 3 or 4, you can try something. 5 is something which is a maximum.
Done, yeah.
So there is no question of thinking about it.
Any comments from the chairpersons on this situation? Bad interim PET, plan for...
The reality
the reality.
So the reality is very different both for upfront the first case. And in this case, it's really a minority that can go to CAR T-cell straight here as much as it's indicated. So for me, especially the earlier case that you presented, if it's chemosensitive, even if it's early relapse and you get into a CR, we would still offer an autologous. The cost difference is staggering and the outcomes are not bad if it's chemosensitive.
Right.
So that in my mind is I mean, whatever is being pushed as, you should be CAR T up front, and that chemosensitive group of patients, for us, the cost difference is just huge. In this situation, again, yes, the fact is the outcomes are going to be poor, but it's going to be a minuscule minority who can afford to go to CAR T at this point over here. So the reality is most of us will do some kind of intensification, whether it's dose-adjusted EPOC or DAP, etc., in the 3 cycles, achieve a CR. If they get into kind of a remission, maybe offer an autologous transplant. I don't have good data how good that survival is, but I suspect if there's a response and there's chemosensitivity, you may have a better outcome than the 10%.
Yeah.
So that's the reality I think most people would actually end up with.
I think the decision is very clear in a clearly relapsed patient, but this kind of a patient, it's really, in real world, how you work with it.
Yeah, actually, I think what Dr. Vikram said, in the real world, actually, by and large, what he said is what we do. The second thing is that response assessment is vital.
Yeah.
And if we don't do that, we are guessing. And that we are religiously doing. And if you have a response, I presume it is chemosensitive. And if it's chemosensitive, like somebody said from the panel, last 5 years, we've generated good data on our GDP versus the others like DAP and the others which all require IP admission to actually administer it.
Right.
And we found very good results. Actually, we are just sending it for publication. And after that, we followed up by most of the cases about auto, and they've done well. So, this 10% thing may be fine. I think at the end of 5 years, we must put our data together to see it actually may be better than that.
Right. I agree. I think so. Yes, yes.
I have a question. So, this patient has a bulky
You
disease.
can't ask questions. You are the panelist.
Okay, I have a doubt.
If you have a comment, you can make it. Otherwise, we move on.
No, this patient has a 8 centimeter nodal mass.
Yeah.
Presuming that he's asymptomatic. So we can try a second line chemotherapy. So, but if he is symptomatic or he progresses on chemotherapy, then it becomes more difficult because then we are just scrambling for time.
Right.
We don't have time. So
Right.
when a patient who is actually eligible for CAR T and he has a refractory disease, I feel CAR T would be better, especially these kind of scenarios. 8 centimeter, 10 centimeter.
Yeah, I think one thing is that how we are assessing interim PETs, we'll take it in the end. How we are assessing interim PETs becomes very, very important, because if it's progressive, it's in your face, But these kind of, partial responders, are they chemosensitive, are they chemorefractory? Our nuclear medicine colleagues, we'll have to work with them very closely to say that we are, because for the labeling, primary refractory is also included in the, label. It's not just that. And specifically, looking at, retrospective data on double hit, we know that double hit autologous transplants, by and large, not so great, even if you do it as consolidation. But, just looking at patients with a double hit, the response rate when CAR T has been around 60%, and there is some, PFS of 28%. So some maybe 20 to 30%, I would say, patients possibly are being cured, double hits with CAR T. These were obviously, initially, these were not patients with bad interim PETs. These were patients who were mostly multiply relapsed, so they got CAR in third, fourth line treatment. But the data also said that increasing time to CAR, impaired the overall survival. So if it's clear, then that decision should not, there's no point in lingering through 4 or 5 lines of therapy. If you are in the gray zone, maybe try one more thing and then decide, but possibly collect cells, but don't wait forever and ever, because there is a proportion of patients who can potentially get cured.
I think just a comment here, just with the data, and especially with a lot of people working in the private sector, it will be very difficult not to offer CAR T. That was my only point with that data. If they have sort of seeming to be double hit, large mass, less than 50% response on an interim PET, it will be difficult not to offer. I mean, what actually happens will be different.
I think there's no confusion. We're not making any confusion here that CAR T is the way to go. But we're just talking about the ground realities and what we end up doing. So we're not saying that's ideal.
I think we all agree, by and large, mostly everywhere this patient will get another, few cycles of chemo. Maybe in a couple of years, when we are more confident, the cost has come down, we'll be very confident that we are just doing it. But by and large, the confidence level right now might be a little.
You have a chemorefractory in order to
right.
So you will eventually end up doing the CAR T.
So there's no point in exposing that patients to multiple lines. And
it's a question of labeling it as chemorefractory or not. If you're saying
right.
chemorefractory, I don't think so.
There's no
whether
point
you
messing
label
around
it as
with
3 cycles or you give it 2 more cycles and then you label it, but once you label it, changing the A to B chemotherapy doesn't make sense.
Doesn't matter.
Yeah. Here also, there's no debate on the science.
Yeah.
Okay, but the problem is he's already failed multiple lines, exhausted his finances. When he comes to you, he's a CAR T candidate. To arrange to get one, sooner than later is the question, and most of them end up not getting it.
This patient actually, by this time, everybody knows that it would have been a double R-epoch, as he mentioned, Dr. Vikram mentioned, at the initial setup. Instead of that, he received the R-CHOP.
Yes.
That is the one thing. Second thing is, in this particular time, as Dr. Dinesh mentioned, that changing out to the next chemotherapy may not be working. Third, if you give another chemotherapy, that is going to affect the T-cell quality, quantity also. It's not that chemotherapy will not affect. So that's the reason I was stressing that better to collect as is stable and fit. So collect the stem cell, and then definitely you have to go for some bridging, which is capable of what is.
Right, so I think this is somewhere where, with the manufacturers or within our centers, if we can come up with systems, processes where we can collect the cells and freeze them, not necessarily manufacture. So if we can come up with, methods to do this, then you don't worry about impairing the T-cell health that much. Because once you are doing the full billing of, paying for the whole thing, then it becomes very difficult to justify paying for the product that you may not even use. So we also have to logistically find a solution where we say, okay, We are just going to collect and freeze. We are not saying that this patient is definitely going to undergo, but we are not going, but right now I don't think our systems are optimized for that kind of planning, because it's either you go all in or not at all. So I think mechanisms for doing this are required, Dr. Pankaj.
Since we are talking of science, so maybe in another 6 months or a year, once we have the availability of bispecifics, then the question will come whether you want to go for bispecifics or go for the CAR T-cell therapy. So we should have some discussion.
Right. We are coming to that also. So okay, the next case. So some answers, some not clear, no clear answers, which is fine. I think this will, our experience and the data will pan out. So a 58-year-old man. So he had follicular lymphoma, high-grade transformation, had a couple of lines of treatment, then second line RIs. Now transplanted post an auto, 1 year post an auto, biopsy confirmed relapse. So he has some nodes. They are not huge, 2 centimeter, 3 centimeter, a few centimeter nodes in the abdomen, but not a very high burden of disease, and he is planned for CAR T therapy. It's clear that that's what is happening. What is going to be your bridging strategy for this patient? An option being no bridging, just collect the cells, infuse them. GEMOX, just conventional chemoimmunotherapy, bispecific based chemo, bridging, or something else. Dr. Priyanka?
Yeah, this is a case of follicular lymphoma which has transformed to a high grade. And now at relapse, is it the same as a high grade or is it a follicular? That is something which will be a matter. So if it remains a follicular, we will just put him on observation till the patient does not have any symptoms, or if it is a high-grade lymphoma again as a relapse, then possibly the patient has relapsed bridging. I think
so you are bringing the question of why do anything for the patient, just if it is just low grade, just wait and watch, leave them alone. Okay, but
and supposedly if it is high grade, I think the disease burden is quite low, but still high grade disease, with the disease burden we do not just sit back. CAR T is an option which has to be said to him, that is the definitive therapy. Directly, if the patient is ready for it, no bridging will be required because it is a very low burden disease, can be taken care of. And if the patient is ready for if the patient is requires funds and all for that he wants to buy some time, then definitely I will go for a sort of bridging therapy.
So your thought is that if we are ready to infuse, like our vein to vein time is within 3 weeks, then we can just leave him alone, no bridging, just collect and infuse. But if it's going to be 2-3 months, then do some kind of bridging. Any other thoughts on this? Any difference of
opinion? This
opinion?
patient is asymptomatic. It is clinically detected. I wouldn't have gone for the PET CT scan post-transplant at this time. Probably follow up the LDH clinical examination. That will decide what to do further. Having said that, clinically you have picked up some adenopathy or LDH is on the slightly higher side or a constitutional symptoms, probably definitely at that point of time PET CT is being done and that is showing this one, definitely biopsy confirmation. Definitely POD 24, this patient has to be considered for the CAR T because auto is being exhausted. Right. So that is a one thing. In that case, whether to do anything bridging therapy, again like the first case we have to discuss that, whether he has symptomatic or anything, same thing.
So if he is asymptomatic, no B symptoms.
Collected the T-cells. If the LDH is not increasing, he is asymptomatic. Probably the bulk is not that much, less than 5 centimeter. I don't think if it is a localized bulky, you can consider RT also, which is equally efficacious, not having a systemic toxicity, that also can be considered. Non-bulky, asymptomatic, no LDH, disease progression is confirmed, probably disease biopsy is confirmed. Go ahead with the collection, don't give the bridging, is mandatory. No bridging does not make any difference.
So that's
I think it's better to wait till the patient requires actually a treatment rather than just being asymptomatic and carry on with the CAR.
So you're saying, why are we even discussing this whole thing? Just leave the poor guy alone.
Practical point of view, as just being heard, sir, saying that even now auto holds good even if there is a CAR.
So I mean, honestly, this is the real patient, and that's what happened. We actually said, okay, we will wait and watch, and we did another PET, a couple of months later, and the nodes were increasing in size. So it wasn't that it was completely like inactive, dormant disease.
If it is an aggressive disease,
Yeah.
definitely it will come at some
Right.
point.
So I mean, just for the sake of time, I didn't get into all of that, but that's a fair argument. But there's also the thing that if it is inevitable that at this point, at some point this patient is going to require treatment, why do you want to, make him older and sicker and then do it? But so the question of bridging is a very complicated and controversial issue. The data of bridging, no bridging, especially if it's low burden disease. So looking it up, I think it also depends on the product that you are using. So if you look at T-cell data, they very clearly say that you should do some amount of bridging before taking the patient, because the outcomes are better with bridging versus no bridging. Whereas if you look at the axi-cell data, the data leans towards saying that if your cells are ready, just give it, don't mess around with a lot of bridging. And just offhand, the data in India has been that it's the patients who've done the best are the ones who had very little disease at the time of infusion. So I think it's good to know what the bridging data is in general, but the bridging data for the product that you are using, I think that's going to be very, very important for us, because it's, if our product is saying that, the disease burden has to be very low, then we have to go with that, because it's not consistent across different products. But at the same time, if you have to give more than 2 cycles of bridging, then it's probably a poorly selected patient, because that patient is not, you're just going to make them more and more toxic. So that's also clear that a lot of bridging does not improve. So what we did give some bridging, because we tried, even though it wasn't bulky, we did give something because we wanted to reduce it to improve his outcomes. He was fine. We were not, even though he wasn't supremely symptomatic, but looking at our own experience and the immunomatic experience, that's what we decided. But I understand some people might just say, go for it, there is no point. So this is another, okay. So this is, a real situation. What do we do? A 62-year-old woman, she has DLBCL. It impacts the thyroid. There's clearly primary refractory disease, shrinks for 2 days and then comes back in a rip-roaring way. Performance status is not so great. She's received R-CHOP, she's received R-GTP before she's come to you. She has a clearly palpable hard thyroid mass. The plan is to do CAR T. Leukapheresis is done. And so after the leukapheresis, you bridge with Pola-BR. You get the information that the product is ready. Initially, there is a slight reduction after Pola-BR, but right at the time when you are planning admission, now the mass is again increasing. There you are at day 14. So what do you do at this situation? Your product is ready, the cells are made, and the lymphoma is growing in front of your eyes. So you just go with it. The product is ready, nothing is working. You pray that it's the cells that will take care of the disease, because drugs are not. Or you try one more cycle of bridging, use a different combination, just radiate it prior to lymphodepletion, or go for bispecific. The trouble, I think, again, as was also discussed in the previous panel, was if the product is ready and you don't infuse it, that for us, because of the cost implications, it's a big challenge. So, Dr. Deepam, your thoughts on this?
It's a difficult question, and barring the option 2, all the approaches appear too reasonable. However, there are 2 things that stand out. One is that the patient's performance status is 2 or 3, so that part is a bit tricky. The second thing is that the patient has a bulky disease, and it's not a very ideal candidate straight away to go for CAR T. Of course, it can be done with a price of increased toxicities and lower efficacy, but yes, it's doable. Second thing is that we can give radiation therapy. There is data where radiation has been used as bridging therapy with the intent that with radiation, I presume that the patient has a poor performance due to the disease itself, rather than any other comorbidities. So we can, with the aim that the radiation can reduce the disease bulk and the performance status improves, and we can go for the CAR T. That is one approach. Alternatively, one can, if BITE is available and accessible, BITE can be used, but again then there are some unanswered questions. Say if we give 2 cycles of BITE and patient goes into remission, then what, are we going to go ahead with CAR T or not? So these are some of the questions.
Dr. Ramaswamy, your thoughts?
Yeah, since it is a extranodal, primary refractory, confined to only one site, definitely, as you mentioned in one of the previous slide, bridging with the RT and no RT does not make any difference. I will consider the RT, and if there is a asymptomatic, probably that also is a questionable, but because of the bulky. BITE I may not consider. The reason is because again the cytokine release, all the complications does happen, and that is escalating time. All these things are that, so that may not be applicable because you are ready with the CAR T.
Yeah.
So definitely I may consider that. So after the washing out period of RT, just 1 week is enough.
Yeah.
So probably I can consider that.
Any thoughts from the chairpersons? Pray. So
suppose the disease is resistant to radiation, resistant to BITE, and resistant to everything. Is there a role of actual surgical debulking in such a patient or no?
So, so I think this is, I don't think there's
generally,
no. Everybody says no.
Dr. Nilapu is the expertise, fortunately. Definitely, debulking is not an answer for a lymphoproliferative disorders. It's additional, that's all. But again, being an extranodal, efficacy of the CAR T may come into the picture because it's extranodal. That is also has to be considered. I would like to have Dr. Nilapus on that aspect.
Yes, I agree. I think surgical debulking is not something that we generally do unless there's a clinical emergency like bowel obstruction or something like that. Now, in this patient with a 14 centimeter mass, I think it's definitely preferable to give some additional bridging. If there's a single site that's bulky and growing and symptomatic, yes, I think radiation is a very good option. In fact, in our experience, when we give radiation bridging in a patient who has multifocal disease, post-CAR T, we see very good outcomes in the radiation, within the radiation field. Even if the disease were to come back in the future, it usually does not come back in the radiation field because radiation seems to act as some sort of an immune modulator and facilitates CAR T-cell trafficking. And there's some data for that in solid tumors as well. So in this case, I think probably radiation would be preferable. Now, if somebody has multifocal disease that's bulky and rapidly growing, we use a more intensive chemotherapy-based bridging, usually with hyperfractionated cyclophosphamide. And that generally seems to buy us some time and give some tumor reduction in majority of the patients. One other comment I wanted to make about the study that you showed about the US Lymphoma CAR T Consortium, that bridging didn't seem to have made a difference for axi-cell. So just remember that that data set came from the group of patients who were treated back in 2017 and early 2018, within the first 6 months after CAR T approval. And that was when we did not have more effective bridging options, including polatuzumab, we did not have. So, and these were mostly chemorefractory patient population. So I think we have to take that into consideration. More recent data sets show that even for axi-cell, if a patient gets bridging, as long as they have a response, they tend to have better outcomes with CAR T.
Thank you so much. I think that's very, very helpful, the comments. But we decided to infuse. At the time, we had some discussion within our group, and the idea was that the patient was very, very frailer now when she was in the beginning, and we had the cells ready, and we the data from the Indian product was not very clear, so there was this thought that, the cells are ready, the cells will do the job, let's just give them. And if there's any residual mass, then we will radiate it post. That was, the strategy that we decided. So we did that. We did get a partial response at day 30. And then we radiated, but she tolerated the radiation very poorly. I think the fact that, that it involved the aerodigestive tract, I was almost glad we didn't radiate before because I could see that I'm not sure how we would have been able to get her through CAR after that kind of radiation complication.
Because of the 800 lymph nodes, 300 lymph nodes only in the head and neck.
Yeah.
And thyroid is surrounded by a full of lymph nodes. So
yeah.
That has to be very clear how either involved nodal or involved site or something like that. Probably that is very important.
Yeah. So again, I think we have to look at our data as it evolves very, very carefully to see how, all of these are helpful tools, whether it's radiation, bispecifics, if they become available and affordable, but the toxicity becomes an issue because if the patient is so sick with grade 4 mucositis, are you really going to be able to get them through lymphodepletion and CAR T? So again, no completely correct answers, but all different challenges that we have. So just a discussion about, now that BiTEs they've been around and probably coming to India soon. We already have them from myeloma, hopefully from lymphoma also. How do you think about using them in combination, sequencing, one better than the other? Dr. Jeevan?
Yeah, CAR T is showing better response. The response rate is better as compared to BiTEs, and the responses are more durable as compared to BiTEs. So if I have to choose one, then only CAR T. But otherwise, if patient is having refractory disease, then initially BiTEs can be given, followed by CAR T can be done.
Okay, so that would be your choice. If you have to pick one, you think CAR T is winning
then,
the race?
Yeah, some bridging therapy, then CAR T.
Dr. Ramaswamy, I've asked you to speak in favor of BiTEs. I don't know if you are a believer in that or not, or you can say whatever.
Probably at this point of time, I am in India. CAR T is available and the cost-effective manner. Probably if I am there in the other part of the world, I should say a different answer. So I have to go with him. I joined.
Yeah, and with the problem with the BiTEs, you have to give multiple times. It is not one time, and the cost of BiTEs is much more as compared to CAR T. And after that, the responses are not durable. Patient will again require some kind of treatment, maybe CAR T.
So we are not getting a lot of traction for bispecifics in lymphoma from lymphoma docs in India. Nobody is willing to speak for BiTEs.
No, BiTE, we will be speaking probably down the lane because the cost will make us comfortable zone in India to say about the CAR T.
Yeah, but sometimes the patients are very frail.
Yes.
Yeah.
Possibly in those frail patients, it is much easier to give a BiTE because we had used glofitamab in one of our patients for compassionate use to prepare the patient to undergo a CAR T.
Right.
So we were successful in doing that, got around 1.5 months duration to get his ECOG performance good to tolerate the CAR.
Right. So you think they can supplement your
sequencing can be done.
strategy,
BiTEs,
but
after getting some kind of remission, then CAR T.
Right, but they are not winning over CAR T as such the way, in some as to say.
If you achieve a CR, glofitamab and Gemox, the trial is there. So if you achieve a CR with that, I think that will going to change. Then you can do an autologous transplant.
Yeah, the thing is again.
At 12 cycles you stop and there's a very good response. I think.
Give a 2 cycles of glofitamab and Gemox. If you achieve a CR, whether you can consider for transplant.
Anybody wants to argue that give the CAR and then after CAR if there's any residual disease or if you have loss of B-cell aplasia, then give glofitamab in the first 3 months, 6 months, that kind of a strategy that just give the cells, and if somebody who has CR at day 30, leave them alone, but in somebody who has PR or loss of B-cell aplasia in month 2, month 3, sort of consolidate with BiTE.
We have done to the 2 patients, so had a PR and we have given a glofitamab.
And how was your experience?
They ultimately relapse.
They ultimately relapse.
Post-CAR. Then you can do allogenic if you want to, but the people don't go for that.
Right.
Yeah, glofitamab single agent is not that effective in my experience. A couple of patients, Dr. Nilapo on that aspect, single agent glofitamab. Most of the time we are combining with this one.
Yeah, so I think it depends on what situation you use. Say in a CAR naive patient, the response rates are about 50%, CR rate of about 40%. But if it's a post-CAR relapse patient, there the response rates are much, much lower.
All patients are post-CAR expert.
Yes, that's probably the reason. But even in the post-CAR setting, if you give glofitamab in somebody who relapsed with the first 3 months after CAR T, they are the worst responders. They almost never respond actually. But if somebody relapses after 9 to 12 months after CAR T, they have a much better chance of responding.
Yeah, so my reading of the data and looking at this is that bispecifics possibly have a role in getting the patient ready for CAR. That's probably, if you have to use them both, that's probably the way to go. But it might be a very expensive bridge in some cases, right? I mean, so if you can get the same job done by a cheaper bridging option, why would you do that? But in some specific situations, it might work, because at least we know that it does not seem to impair CAR T-cell activity. Like the way we worry about Blina as a bridge, that concern is not so much with bispecifics as a bridge before CD19 CAR, so at least the ones that are available. So in terms of tolerability, maybe infections we always worry about in India, but in terms of CAR T efficacy, it's okay. The post CAR T efficacy is not very good, and the glofitamab single agent, there is no plateau. Even with glofitamab pola, actually there is no plateau. So as far as I can read the literature, that bispecifics are curing any lymphoma patients right now, probably not. So you can't, in that way, CAR T has an advantage. That's the $1 million protocol, yeah, possible. So yes, I think sequencing is viable, not clear, exactly how it can work. CAR T, the advantage is it's one time, bispecific, the advantage it is off the shelf, but no plateau with bispecifics is a concern, I think, when you're putting in that much. Okay. So for the last bit, we'll just talk about management post-infusion. So 18-year-old male, relapsed high-grade B lymphoma, he undergoes CAR T treatment in CR2. He's pretty well till day 5, but after that he develops, grade 4 CRS, inotrope requirement, receives 3 doses of TOCI. Eventually the hemodynamics too settle down, but he develops initial cytopenias that then recover. He is discharged, but then again he is readmitted with very great, severe cytopenias at day 28. So this is the marrow that we did at that time. We can see that, you can see a lot, for an 18-year-old, the marrow is pretty empty. You don't see a lot of CD20 at all, and you can see a lot of expansion of the CD19 CARs. I sent this picture to Dr. Rahul, telling him, see how active your CAR Ts are in the marrow. You can see them, we can stain for them, and we know these are all CARs and they're causing aplasia. But that is again a situation. So how often do you see severe, late, prolonged cytopenias in your patients, and how do you manage them? Dr. Ram?
I only have limited experience. I only treated 3 lymphomas and all these lymphomas had very less tumor bulk, because they were given an effective bridge and they responded very well to the bridge therapy. 2 patients were in CR and 1 patient had partial response. I did not till now, that would have a problem with HLH type of, but we usually see this cytopenias which happens over the 3rd week, the 2nd peak or the 2nd dip, around the 3rd week or 4th week, and generally it dissolves on its own. We supplement with GCSF or TPO agonist whenever it's required, and we haven't had any problems with that HLH type problems. So this is my experience, so others can share their experience as well.
Dr. Sameer, your thoughts on this, how much do you worry about this, when you're counseling the patient, preparing, how much do you factor in these sort of relatively late-ish? I mean, we say it's a one-time treatment, right? I mean, we keep saying it's a one-time treatment, but then you have month 2, month 3, and some of these patients are coming back.
Sure.
They're still in and out of the hospital a lot. So how has your counseling changed about it, or your
So
planning?
again, very limited experience with the CAR Ts, but I think for the cytopenias, I think initially it's probably dependent on the lymphodepletion chemo. And once they've got the CRS, I think the most important thing when it's resolving is probably the HLH. I think that's where, checking the ferritins and fever, and probably you did a marrow as well. I think that's more important. Disease coming back at day 30 in the marrow is probably not that common, but I think the more pressing thing is probably HLH. Once I think that's sort of ruled out with the ferritins, then probably it's going to be supportive therapy with growth factors and either L-trombopag and romiplostin and the anti-infective prophylaxis to be more sort of impressed on the patient. I think over time, I think they would sort of recover the counts in patients, but I think those are the things that I would probably look at.
Right, so this was also briefly discussed in the previous panel. So the early cytopenias we see with everybody, but about 20% of the patients experience these prolonged late cytopenias. So there's this biphasic kind of cytopenia curve. But the issue with the late cytopenia is that it's more related to inflammatory, like a cytokine storm phenomena. So the usual GCSF, romiplostin thing does not work as much. It, like was also discussed, it will typically be associated with hyperferritinemia. So really you have to go for the more anti-inflammatory, so anakinra, ruxolitinib, those are the kind of things that you will get out of it. In some situations, I think especially in leukemia, disease relapse also becomes a consideration if you're if you're seeing this, so you should keep that in mind, that maybe the cytopenias is related to that. There is of course a scoring system related to it where you can anticipate it. So I think this is something that we have started counseling patients more on, so that for the ones who experience this, they are not completely, they've planned the logistics for it, that they might be coming in and out of the hospitals requiring transfusion support or admissions for a fever well into week 2, week 3. It's only about 20%, but for those ones it becomes important. And again, with experience, anakinra has worked well for us. That's the one thing. In some cases, we've had to use steroids as well. The scoring system and all, and it overlaps with HLH. So that's the thing. So just prophylaxis strategies also discussed a little bit. IVIG, this was already discussed. Mold active antifungal, Dr. Priyanka, are you using in everybody?
As such, when there is the period of the cytopenia, initially we give, but once the ANC is more than 1000,
you stop it. So till the neutrophil, after neutrophil recovery, you stop it. How do you decide about PCP prophylaxis?
PCP, we continue it for pretty long, 6 months around we give it, and B-cell aplasia also we keep on monitoring if the patient loses it, so we continue it for
Right. And Dr. Ram, your herpes prophylaxis, how do you think about, how often do you check the T-cell levels in order to make this decision?
So for lymphomas right now, I'm not checking the B-cell aplasias. As a prophylaxis, I continue till 6 months, the herpes prophylaxis till 6 months.
Right, so that's, by and large, I don't think in India we are using a lot of bacterial prophylaxis because we have so much MDR that really bacterial prophylaxis is irrelevant for us, so that's out of the question. Herpes, PCP, at least for 6 months is standard, but there might be patients in whom T-cell recovery is prolonged, who might also be the patients who actually are good responders, because we've seen that patients who've had more cytopenias or prolonged B-cell aplasia are also the ones that are likely to stay in remission. But it makes, if you're worried about it, it makes sense to keep an eye on their CD4 counts to decide, because some patients might require longer prophylaxis, so it makes sense to do that. We are all at some frequency checking IgG levels, and the IVIG supplementation was also discussed. So just to conclude, the cellular therapies are here to stay. Just looking at the EBMT data, we can already see that allogenic transplants have been the first to be basically gone from lymphoma. The numbers from EBMT registry show a very sharp drop. Autologous, we will see how it will be impacted, especially if the cost becomes comparable at some point. If it's only a 30% difference in cost, then this data, how the ISBMT data from India pans out in the next 3, 4, 5 years, we will see if it mirrors the experience from EBMT or not. I think it's some very interesting space to watch out for, and I'm pretty sure it's going to expand as the logistics have been quite, I think, something that is better than expected, I would say, yeah. But the cost is also coming down, and we will see how it pans out, because the story is on the, the writing is on the wall. So just to conclude, these are my conclusions. People can differ. That vast majority of patients in some way, shape or form can benefit from a CAR. A minority who are eligible and have chemosensitive disease can still benefit from an auto transplant. If you're going to use it early. No point in dilly-dallying for a very long time. Bridging is important. You cannot completely discount bridging, but if you are having to give a lot of bridging, you are really not going to get that much more from it. So if you are past 2 cycles, it's really pointless at that point. So BITE as a salvage, bridging maybe before, but by itself, maybe not the solution. Post-infusion, there is a lot of margin of optimization as to how we optimize, especially the partial responders or the ones with loss of B-cell aplasia. The maintenance strategies were discussed before, but even here, whether it is BTK inhibitors or lenalidomide, the data is very, very premature on that, but it's coming. It's something to watch out for. And I'm sorry, Dr. Bharani, but I think that allogenic transplants are basically going to be gone from the lymphoma space. With that, I'd like to thank everyone, and if there's any audience questions, we can have them now. Thank you.
I just have a comment. So my patient, 35-year-old female, PH positive ALL. She had severe...
This is a lymphoma panel.
Yeah, but still I want to, emphasize some fact. So, day 28, she had severe cartopenia, ANC only 10, platelet count 40,000. We did all the workup, but she had no HLH. It was simple cartopenia, and she recovered just with growth factor support. So this prolonged cytopenia could not necessarily be HLH. It could be just cartopenia because of some reason.
Yes.
And the patient just recover with growth factor support.
Yeah, the good thing, I think, looking at all the data is eventually it, does recover. It can be sooner or it can be later in some people. I think in the patients who've previously undergone allo transplants or have had some GVH, those are the ones that can be very, very troublesome in terms of cytopenias, because if the graft is gone, but in general, I think in lymphoma, the good thing is they recover. So you have to, but the patients need to be counseled and told that to have patience, and the doctor has to have patience, and everybody just wait, and eventually they come. Yes.
I also have a leukemia question. So we have a 30-year-old patient who's in remission. He's fit. He had his blood test done last week. Everything was normal. So we admitted him for lymphodepletion, gave him 1 dose of fluci. Next day, routine lab test, liver enzyme per 800 and 750 in that range. So he's come positive hepatitis E. So now the plan we have made is once the enzymes start to come down, we'll call him back in a couple of weeks or so. So fluci, should we start from the beginning, or should we just consider 1 dose given and then give the remaining doses? How should we approach this?
I think the package insert says that if it is within 60 days or so, you don't have to repeat it, or if it is 30 days. But if it's been longer, you have to repeat it after a certain number of weeks. I have to check exactly how long.
Even if you have done the baseline virology workup, 30 days before it is mandatory to have HIV, HBsAg and anti-HIV, it should be done. That's the reason that.
But this guy has hepatitis E. So he had sugarcane juice on his way to getting his CAR T. What can you do about it? That's basically what happened. Any comments from the chairpersons? Yeah. I think with that we will conclude. Thank you. Thank you, everyone. Thank you. Thank you. Thank you for your support.
Yeah. All right, everybody, a big round of applause for our panel members and the chairpersons. All right, everyone, we request the chairpersons to please present the mementos to all our panel members and also to the moderator. A quick reminder for all our guests to please make sure that you check out from the accommodation, and if you need any sort of assistance in regards to your logistics and flights, please make sure you head to the registration desk. right, a big round of applause for all the panel members, moderator, and our chairperson. Can we go for a group photo? Ladies and gentlemen, we will now announce the winners for the CAR T quiz. I request Dr. Alok Shetty, Assistant Professor, Tata Memorial Hospital, and I request Dr. Smitha, Head of Medical Oncology, JIP, to kindly distribute the prizes. May I have you both on the stage? Dr. Alok and Dr. Smitha.
Okay, good afternoon. Just to say that we had actually more than 100 residents who had actually applied for the quiz. So there was a prelim quiz online, out of which we had 15 residents from the super specialty and 5 who were postgraduates who were selected. So we have the prize for the first we have prizes for the PGs in medicine, below the specialities. So you have third prize goes to Dr. Vishaka Gadi from Sion Hospital. Vishaka, are you here? Yes. Oh, sorry. Yeah, so I think currently we can do this. So I think there's some cash prizes lined up, details of which you will get. Now we just have a token of appreciation for now. Yeah, ma'am is here. No, ma'am. Vishaka. Okay, then the second prize goes to Dr. Akshay Kumar Chopra from KMC Manipal. Akshay, okay. Next, we have the first prize goes to Kalai Vanan B from Jipmer. Thank you. We had 2 more residents from the PG category. Are you here? Shivani? No? Okay. Yes, you can. Not, yeah. Shivani is here. Yes, I think you can also come. Okay. So next we have the prizes for the special, who are basically DM students. The third prize goes to Dr. V. Sai Kiran from NIMS Hyderabad. The second prize goes to Shubham from AIMS Delhi. And lastly, the winner of the quiz is Sai Kiran from Jipmer. So, just request all the winners to just come on stage.
Congratulations to all the winners, and I feel proud both the first prize winners are from Jipmer Eye Institute. Special congratulations to them.
Yeah.
All right, everybody, and it's now time for us to give a big round of applause for everybody who has been on stage so far. And also, it's time for a good, happy meal. So enjoy your afternoon lunch, and we'll see you all here at sharp 2. Thank you. question. Ladies and gentlemen, we'll be starting the event in next 5 minutes. I repeat, we'll be starting the event in next 5 minutes. Good afternoon, everybody. Hope you enjoyed your lunch. We shall now proceed with the final two sessions of the CAR T Summit. I now invite on stage the chairs for next session, Dr. Bhausaheb Bagal, Professor of Medical Oncology, Adult Hemo and Lymphoid Group, Tata Memorial Hospital. Can we give a round of applause? Dr. Pankaj Malhotra, Professor and Head Department of Clinical Hematology and Medical Oncology, PGI Chandigarh. And Dr. Jose Isao, Medical Director, Medical Oncology, Hematology, BMT and Cellular Therapy, Apollo Proton Cancer Center, Chennai. For our next keynote talk, we have Dr. Vikram Matthews, Professor of Clinical Hematology and Director of Criston Medical College, Vellore. Dr. Matthews completed his medical school training at Criston Medical College in 1991 and subsequently his post-graduation in general medicine, followed by subspecialty training in clinical hematology in 2001. He further pursued a postdoctoral fellowship at the Stem Cell and Leukemia Unit in Washington University of St. Louis. After returning to India, he joined the Department of Hematology at Criston Medical College, where he is currently a professor of clinical hematology and the director of the institution. His work in academic access to CAR T-cell therapy has been transformative in shaping the next generation of blood cancer care. I invite Dr. Matthews for his talk. Give a round of applause, please. Over to you.
Is there a pointer here? Good afternoon, everybody. It's the first session post-lunch. Hope to keep your attention on this topic, which I'll try to cover in the next 25 minutes. I'll be brief. I'll try and talk about CAR T cells in myeloma. And I'll start with a little case of a little bit of experience and a little bit about background about the variations in the CAR T cell constructs, a summary of the current data, an opinion on what I think could potentially be sequencing therapy, and it's a conclusion. So I'll start with a case that we treated. We had a 58-year-old lady as a doctor. She actually came to us with myeloma way back in September 2021, and you can see her parameters over there. Her cytogenetics was high risk, and her medical history, except for hypothyroidism and type 2 diabetes, which was fairly well controlled, was otherwise relatively insignificant. She got a whole line of therapy as is outlined over here. I'm not going to read out all of this, but basically she had multiple lines of therapy and never really went into anything better than a partial remission. After 4 lines of therapy, she got into a partial remission, and we actually took her up for an autologous transplant in November of 2022. And within less than a year, she relapsed, and she had a recurrence of her disease, and you can see it's really rapidly proliferating disease. The M-band is back at 4.96. And in September 2023, we started on some salvage therapy and enrolled her on the clinical trial. In less than 2 months, without really any significant response, even with the initial therapy and the bridging therapy, we gave her lymphodepletion. And this was the Origins product, which is a nanobody CAR T. And we infused, this is part of a phase 1 study, we injected her 5 million CAR T cells. The post-infusion period was relatively uneventful. She had a grade 1 CRS, nothing remarkable, no ICANS, no serious adverse effects. She did have a prolonged cytopenia. Even after the recovery from the initial lymphodepletion cytopenia, the ANC, the neutrophil count, remained low and continued like that for more than 150 days. It took more than a year for actually the counts to come up. But there's no real inflammatory component. The IL-6 crash, the ferritins I've not shown here, was not really elevated. So she really had this cytopenia without much of an inflammatory phenotype. We really didn't do anything. We just watched her. And many of these patients, even from my earlier phase trials, when they have this kind of cytopenia, they just look very well. When they look very well, often there's no need to jump and do anything. and they often just recover a given time. And she was one of those patients who had an ANC about 500, 600, platelets running at 20, 30,000, but absolutely asymptomatic and well. And we just continue to observe her. She had excellent performance status. By day 60, she was back to her normal activities and back to a normal life. This is just to illustrate the flow of her M-band during the entire period of the time that she was with us. Way back in September 21, and you can see some initial response, but not really very good response, and then it goes up, and then it's basically refractory to therapy, and it's in December 23. January she actually got, 24 she got her CAR T, and that's where it was post-CAR T. So a highly refractory patient, post-autologous, gets CAR T, and now she's more than 3 years. She continued to have low levels of detection, but at 1 year it became undetectable. So there was a very slow drop in the M-band. This was new for us. The first patient we are treating, so we didn't really have a sense of how this is going to go. She was always worried, we were worried, because she has this cytopenia and she has this M-band that's not disappearing. So every time she comes, the next time we'll think the M-band would be back. But actually it continued to go down. And more than a year later, she has no detectable M-bands, more than 1.5 years now. The MRD is negative, ECOG performance score is fantastic. She is back to work in Dubai as a doctor, and she comes once in 3 months for follow-up. Her immunoglobulins tend to be low, and we also giving her immunoglobulins intermittently. So that brings me to the whole issue of nanobodies. So this is what we conventionally understand about CAR T cells. We have in everybody in this audience, a very focused audience, you'll recognize first generation, second generation, third generation CAR T cells. And it usually involves the single chain fragment variable length of the light chains, the light and the heavy chains in a single loop. That's why it's called a single chain fragment variable length. But I think it's important to remember that most species have antibodies that look like this. They have a variable light and a variable heavy chain. There are some species like the camelids and the sharks where you don't have the light chain, you have only the variable heavy chain. And essentially when you take out this variable heavy chain and put it into a construct in place of the single chain fragment variable length, you call it a nanobody. And so this is how it will look in the context of all the other CAR T cell constructs, second generation and third generation and fifth generation. You can have the nanobodies. The nanobodies can also be second and third generation. They can have additional elements to it. So the CITA-cell, for example, is one of them. So if you look at all the FDA approved, and it doesn't have the latest one, but all of them are single chain fragment variable length second generation. And of the two that are directed against myeloma, the BCMA, the CITA-cell is different. It's a nanobody, while the ide-cel is the conventional single chain fragment length variable length epitope recognizing component. So the CITA-cell, this is how the construct look. It has two VH components, which is linked by linker, and it forms the binding domains, and the rest of it is fairly standard for a CAR T. You have the linker, you have the intracellular domain, and the CD3 zeta activation domain, and it has a 4-IBB co-stimulatory domain. So some of the so-called advantages of the nanobody over the BCMA or over the single chain fragment length variable is supposed to be that it's smaller, it has a higher binding affinity, believed to have a greater specificity and a transduction, and production is easier, more stable. The immunogenicity is believed to be lower. Some data to suggest that it's more efficacious. There's also some concern that the toxicity may be a little bit more, at least in some of the products which have used the nanobody. So with that, we'll come to the myeloma data that we have to date. To date, we have two anti-BCMA CAR T-cell products. One is the ide-captogen, the ide-cel is also called BB2121, and the cilta-captogen, autoleucel, which is also called cilta-cel for short. In relapsed and refractory myelomas, it's where it's been used after multiple lines of therapy. I'll just walk you through some of the key elements of the early data. This is the KARMA clinical trial that came out in 2021 in New England Journal of Medicine. And it was a phase 2 study, involved patients who had failed at least 3 lines of therapy. And they should have, and in this place there were 128 patients included in this trial. 140 were apheres, but only 128 actually were infused. The median number of prior treatments was 6. So you can see it's a very heavily pretreated population. The cell dose varied from 150 to 450 million CAR T cells, not a weight-based dosing. And there was actually 3 doses, there was 150, 300, and 450 million CAR T cells. And the overall response rate in this heavily pretreated groups was quite impressive. So the first trial that came out really, with a CR of 33% and overall response of 73%. The progression-free survival was 8.8 months, the overall survival 78%. The grade 3-4 toxicities were not significant. The hematotoxicity was mostly the early cytotoxicity initially. The CRS, if you look at the grade 3 and 4, was a very small component, 5% and 3% in neurological, and a small proportion of patients died during the follow-up. If you look at the cell doses, the lowest dose, 150 million, was given only in 4 patients. The majority of patients got 300 to 450 million cells, and there was a dose-dependent response. As you can see, the best response was seen in the 450 million dose, where you could see the CR rates itself didn't change, but the people who went into VGPR and PR definitely improved with a higher cell dose. So the CR remained around 28%. And that's the overall response rate that's shown over here. What did that translate to? That translated to a progression-free survival and an overall survival. So over there is the overall survival, and you can see that there was really not that much of a dose-dependent difference. The lowest cell dose at 150 did badly, but between the 300 and 150, there was not that much of a difference. But in progression-free survival, there's a trend to an improvement with the 450 million. With regards to response to those who had initial response to this therapy, obviously the ones that did CR had a better survival, and that's the overall survival of the entire cohort. If you look at the early data from the Silcaptogen, this was their initial publication that came out in Lancet in 2021, the CARTITUDE-1, and this was followed by a 2-year follow-up data of the same study. I'm just going to review the long-term follow-up data. It was a 2-year follow-up. That means the last patient was followed up for at least 2 years, and this came out a little later in 2022. So this was again a phase 1b/2 trial, at least 3 prior lines of treatment. 113 patients were apheres, but only 97 were actually infused. And the cell dose here was relatively lower, 0.5 to 1 million per kilogram. And as I said, the cilta-cel was a nanobody in contrast to the earlier one, the ida-cel. The overall response rate was 97%, and stringent CR was seen in 67%. The time to response was 1 month, and the 12-month progression-free survival and overall survival was 77% and 88%. Grade 3-4 toxicity, again, if you look at the CRS, was about the same, but the neurotoxicity, the overall neurotoxicity was a little higher than what was seen in the ida-cel, but the grade 3, grade 4 toxicity was not that much higher. Subsequently, and the next slide is a very crowded slide, the only intention is to say that subsequently phase 3 studies with both these products were done against standard of care therapy. And in a very crowded slide, I only want to point out that, as expected, these had better progression-free survivals than the standard of care on both the cilta-cel and with the ida-cel. And you can see the response rates were also better. The grade 3-4 adverse events were slightly more, but were mostly tolerable. I think if you do a head-to-head comparison, it's difficult really to compare these 2 trials because a lot of the inclusion criteria, etc., were different. And in fact, if you look at the cilta-cel trial, they tended to be little less heavily pretreated patients, etc. So people have tried to compare this data, and this is one exercise that was done to do a head-to-head comparison of the first 2 trials that I showed you, the phase 1 trials. And so this was a group that did what's called matching adjusted indirect comparison, a lot of statistical and study design terminologies over here. I'm just giving you the key points, but basically they made a lot of effort. They took CARTITUDE patients who fulfilled the eligibility criteria of the CARMA were included. And they only took the patients in the ida-cel group who got the 300 and the 450 million cell dose. They excluded the group that got the 150. So basically, in summary, to say that all efforts were made to match the populations for the recognized risk factors. And the key observations were, even after doing that phase 1 data, the overall response rate, the CR rate, was significantly better with the cilta-cel compound than the ida-cel compound. The progression-free survival was also significantly better with the cilta-cel compared to the ide-cel even in their early phase trials. And so in this graph, what they're showing you, the lower one is the ide-cel progression-free survival. The above two graphs are, one is the cilta-cel, the observed dose, and this is after the adjustments that was done for comparison between the two groups. So even after doing this adjustment, the progression-free survival with the cilta-cel product was superior to the ide-cel, statistically significantly superior. Subsequently, this year, in February 2025, a second comparison was done of real-world data. This is the US Multiple Myeloma Immunotherapy Consortium. They took patients who had received both these products, who had received it randomly in 19 centers across the United States. I'm not sure if it involves other countries in the world as well. And the data was from retrospective chart review of patients with relapsed refractory myeloma from apheres by December 31, 2022, with intent to receive standard of care ide-cel or cilta-cel at 19 institutions. An inverse probability of treatment weighting approach was used to compare outcomes by therapy type. Again, a very crowded slide, but you can sum it up to say that between the intention to treat cohort and the actual number of patients who were infused, again, a lot of effort was made to take patients from both these cohorts who were reasonably matched. And after they did this exercise, whether you look at age, you look at race distribution, you looked at extramedullary disease, you looked at other risk factors like cytogenetics, previous anti-BCMA therapy, there was essentially no significant difference in the two groups. And then if you looked at the overall response rate, if you looked at the day 30 overall response rate, there was a significantly better improvement, a 1.7-fold improvement response in the day 30 overall response rate, and almost a 2-fold improvement in the day 90 overall response, translating to a better progression-free survival, as I'll show you later. So even the best CR or better overall response rate was better with the cilta-cel compared with the ide-cel. And if you look at the intention to treat population and you look at the progression-free survival and the overall survival, were both statistically significant in favor of the cilta-cel compared to the ide-cel. In this paper, there are multiple other subset comparisons. They looked at high-risk groups, they looked at cytogenetics groups, and this pattern was almost consistently the same in terms of the better outcome with the cilta-cel. If you look at the adverse effects, because that's the next thing that we would really be wanting to look, without getting into the details of the numbers, there was a slightly higher risk of CRS in the patients in the cilta-cel group. There was also delayed neurotoxicity and an increased risk of infections. So there was a trend towards a slightly increase in toxicity profile with the cilta-cel compared to the ide-cel. And the conclusion was cilta-cel demonstrated superior efficacy and survival with a higher incidence of certain toxicities compared with ide-cel. So moving to the bispecifics, and I don't intend to cover this in great detail, just to give some key highlights in the context of CAR T-cells. This is a study that compared CAR T-cells and bispecific antibodies as third line or later lines of therapy in multiple myeloma. This was a meta-analysis that was reported, included 11 studies and 1,269 patients. And the key observations were that CAR T-cell therapy achieved significantly higher pooled CR rate, complete response rate versus bispecifics. The overall response rate was also better with CAR T-cells than with bispecifics. CAR T therapy had a higher incidence of adverse events, particularly cytokine release syndrome versus bispecifics. However, severe CRS grade 3 occurred at a rate of 0.07, relatively low in the CAR T-cell and almost negligible in the bispecific group. Hematological adverse events, including neutropenia, grade 3, and anemia, were more frequent in the CAR T-cell group. If you look at the use of bispecifics post-CAR T-cell failure, so where do we actually put this in? And if you look at that data, this is data from Germany, where they looked at the use of bispecific antibodies targeting BCMA or GPRC5D, which have been shown to be highly effective, and they've used this in patients who have received CAR T-cell therapy and progressed. And compared to any other standard therapy, IMiDs or other directed antibodies, etc., you can see that these bispecifics had a significantly improved CR. The blue is CR. You almost get no CRs in any other kind of therapy except the bispecifics. And it translates into a significantly improved survival. The follow-up is relatively short, but even in this short time frame, you can see that with the bispecifics, there is a fairly durable response, even in the post-CAR T-cell setting. So about 30% odd CR rates, lower than what you would get if you were to use this upfront, but you still get a reasonably good response rate, and it's sustained in a fairly, for a period of time compared to any other therapy. So in terms of sequencing, CAR T-cell is likely, and this is where the field is going, is likely to move to an earlier phase, and like seen in any disease, as we get to an earlier phase, we seem to get better responses and more durable responses. And so this is a field that is moving, and we don't know where that lines will actually be drawn at this point in time. Probably CAR T-cell before bispecifics. This is not a final statement. I'm sure the data with bispecifics and other interventions will continue to improve. Bispecifics has the advantage always of being off the shelf, instantly available, and lesser toxicity profile. If there's an urgent need for therapy, and if there is a waiting list or a long time, turnaround time in getting the CAR T-cell, maybe something that you want to consider as a bridge before you give your CAR T-cells, but preferably the CAR T-cells up front. Relatively safer toxicity profile means that in patients with poor performance status and elderly, it's something that you may want to consider instead of the CAR T-cell. It's important to consider that prior exposure to one BCMA targeted therapy may impact the effectiveness of subsequent BCMA directed treatments. There are a lot of other trials that are going on looking at using these therapies with other agents to enhance their efficacy. There's data going on with other novel targets. There's also an allogeneic CAR T-cell trial going on. So it's a rapidly evolving field. But at this point in time, I can think for our patients, definitely in relapsed refractory myeloma patients, we still have an option, and potentially durable option in a significant proportion of patients. We need longer follow-up in this field to really see where these curves will finally fall off, or whether we genuinely be a plateau is something that we have to see. The bispecifics versus CAR T-cell is still an evolving topic. And that again, in terms of sequencing, how will we go about it, where will we bring them in, is still, the final word on that has not been said. But clearly there's been a dramatic improvement and outcome in these patients, which all of us know would not survive more than a few months, especially, for example, the case that I illustrated to you. With that, I'll stop. I'll thank my entire team on the clinical side, the lab, Miltenny, Origin, and my funding agencies over the time. Thank you. Pardon? Yeah, sure.
Yeah, Samir. So slightly non-scientific question. So you've shown the efficacy of cell-to-cell versus ID-cell, and you've clearly shown that cell-to-cell is better. We all know that. And also,
I thought I told you for the first time, so it's okay. You disappointed me, but I'll survive. Okay.
So the sales of ID Captogene have been significantly plummeting downwards. Although they're still...
what has been plummeting?
The sales of ID cell worldwide are now going downwards because of the efficacy of cell-to-cell. In India also we've got a similar situation. We've got a nanobody construct already, and that's likely to do well. So what do you think, how will the, for other things which are non...
I would hesitate to draw conclusions that you're drawing. I wouldn't say every single chain fragment length. In this particular, in CAR T-cells, there's a lot of theory, and then what translates and what translates, because there's many a slip between the cup and the lip, to slow to speak, so just maybe this ID cell didn't work, I don't know, but all you can say is in this particular comparison, it did look like cell was better. It's not like the next CAR T-cell that comes with a single chain fragment length will have equally different, it may be better. And these are, small changes in the construct could have various impacts, that some of them are predictable, some may not be predictable. So I wouldn't say that this data implies that nanobodies is the way to go for every BCMA, or that every other CD19 should also be a nanobody. I think that is, I don't think we can make those interpretations.
Thanks.
So in post-CAR T relapse, BCMA CAR T relapse, BiTE is an option. So if whether these BCMA BiTE or this talquetamab, so both have equal function, or we opt for talquetamab post CAR T relapse rather than teclistamab?
Yeah, I don't have the answers to that. I don't looked at any head-to-head studies. Maybe Swatha, you can.
Basically, you are asking a question that if you have already used a BCMA-based CAR T, if you have already used a BCMA CAR T, whether you want to use the BCMA bispecifics or GPRC5D.
Yeah.
So we had actually one patient where the patient got the CAR T-cell therapy in Israel, and it did not make a difference, and then there was this question which arose. So there are not many studies, but people have used BCMA targeted bispecifics, and even our patient also, we used teclistamab only and not talquetamab, and it worked. It is working very well. So, so if there is a choice, then probably you would consider talquetamab, but if you don't have a choice, then teclistamab works well. Maybe a 5-10% difference only.
If you receive prior BCMA therapy, definitely the response is a little less. But like you said, it depends on what's available.
Off-target effects are much lesser in the non-BCMA. In the BCMA, they may be more off-target effects.
I'm not aware of that. Yeah.
So there are a lot of concerns regarding infection post the BCMA CAR T and even the bispecifics. What are the strategies?
There are a lot of post what?
Infections,
yes.
So
Infections and cytopenia definitely seems more than.
What are the strategies that you are using to overcome or reduce the risk of patients becoming sick due to infections in the post-CAR T setting of the BCMA?
Yeah, I don't really have a strategy beyond, there's no way you can predict this very accurately. Some people have it more than others, and when it happens, you just watch carefully. Like I said, it's very difficult to draw a cutoff, but if the ANC is more than 500, just giving you a random figure, more than 500 is usually severe, and the patient looks absolutely well, I don't see much benefit. If there's no inflammatory component, there's no HLH component, you ruled out LGL component, you ruled out all those things that potentially can be treated. It's just sit and wait and watch, and whatever we've seen till now, actually even the CD19, it recovers eventually,
So it is the same, sorry if I can.
Yes, please.
So it is the same as you are using with CAR T for lymphoma. So you are giving antiviral, acyclovir or valcyclovir.
Yeah, all those standard things will follow.
That will continue. Cetran will continue. Yeah. And antifungal, anti-mold prophylaxis for a month till the time the ANC goes above 1,000 or so.
So does it make sense to give IVIG irrespective of the immunoglobulin levels, even if it's more than 500?
No. I don't think there's any role for that. If the immunoglobulin levels are normal, there's no point in continuing to give immunoglobulins.
Thank you.
Sir, similar to ALLs and lymphomas, what are the salvage, bridging and maintenance used in myeloma CAR T-cell?
So, see, at this point in time, it's only on the setting of a trial. So it's patients who have already usually failed at least 3 lines of therapy or post-autologous. And so usually we'll try and see what agents they've not received. So if they've not received carfilzomib, so we'll usually use some combination of carfilzomib. If they've not used daratumab, we may use daratumab. So it depends a lot on what prior therapy they've got, we'll decide. Obviously, if it's before CAR T-cell, we'll try to avoid lenalidomide as much as possible. Those kind of broad things, but there's no such thing as standard. In this person, we had a completely refractory disease before she went for CAR T. So we even went up to using DT-PACE on her. So, the rare fit patients, you could even consider those.
And any maintenance you would recommend?
No, at this point, again, as I said, it's I'm not aware of any maintenance strategy in myeloma. You can correct me if I'm wrong. And again, in the setting of a clinical trial, certainly that option is not there.
So just to add what Vikram has said, so you would here also avoid melphalan and bendamustine. Bendamustine sometimes you use if there is an extramedullary disease in myeloma. So you would avoid both bendamustine as well as melphalan as a bridging therapy in these patients just to keep your T cells in a healthy state.
Okay, thank you.
Sorry, just one last question. So with our indigenous myeloma CAR hopefully being available soon, where do you think would be the best place to use it in our armamentarium for our Indian patients? What do you think is the best, strategy to use it? Obviously standard risk, high risk, looking all of that, but what are your thoughts, anybody in the panel, from our Indian point of view, Indian setting, with our Indian CAR of what is available now and all the gamut of the different immunotherapies, what subset of patients may be the best use of this CAR T?
Yeah, so I mean, at this point in time, I would use it only in relapsed refractory patients, and I think there's a study going on looking at even the high-risk myeloma patients up front, but we don't have that data. Clearly, it's likely to be better in patients when they're treated earlier, but I think it will be difficult for us to use it earlier than relapsed refractory at this point in time.
So the difference between the cilta-cel, ida-cel in USA, where the approval is after failure of 4th-line, here the origin product is actually you are using in the 2nd line. So, you will get an approval, and then, it depends on you whether you want to use as an upfront kind of a therapy or, in the relapse refractory setting. So probably the patients who are very high risk category, 17P and by double hit and triple hit myelomas, those are the one where you would like to use in the earlier setting rather than, using it after 3 or 4 where you may not get time.
Thank you.
So on same line, means I think you nicely dissected out. So CARTITUDE-4 and KarMMa-3 did compare the earlier uses. So what do you think? I mean, following up on Samir's question, do you think it would be wise for us to use CAR T early in our patient?
Early, yeah?
Yeah.
I don't have the answer to that, Balsab. So, I mean, I think myeloma being such a relatively bad disease compared to lymphoma in terms of, the conventional therapy not being that durable, I think sooner or later people will certainly try it out much, much earlier, but how to sequence it, whether you'll just stop with CAR T-cell or whether there'll be some maintenance after that, those are all questions, good questions that we don't have the answers to, But my gut feeling is it should probably come in earlier, But how earlier is what I don't know.
Yeah, I think CARTITUDE-4 was a disappointment. Probably they took line refractory patients, so probably line doesn't matter then. Refractoriness was important. So I think we need to see in our case what happens.
Sure.
As manufacturer, what should we be primed about, given that these are patients who will be on lead for a consistent amount of time?
Yeah, I don't think there's any good assay that can predict failure of manufacturing. You can try doing all these proliferation assays, but I don't think that really holds. You can only, I don't know, I mean, hopefully, they've not received substantial amounts of lenalidomide, I'm not aware of any data of recommended, like bendamustine data, somebody showed 9 months data. I'm not aware of a good washout period for lenalidomide, Are you? Okay.
So, again, not much of a data, but at least, if the 2 weeks minimum before the apheresis procedure, this patient should be off all the drugs if possible.
That's on the clinical trial protocol.
On the clinical trial, and the same is for the real world scenario.
Sure.
Any more questions? Well, thank you, Vikram, for your excellent talk on myeloma, and big round of applause.
Thank you so much, Dr. Vikram, and a big round of applause for him one more time, please. All right, everybody, and now we are moving on to our next panel discussion, and I would request the chair to please stay back. We would be calling the panelists as well on stage. All right, everybody, to conduct the next one, we have our moderator, Dr. Padmaja. Can we have you on stage? Consultant, Hematology Oncology, Stem Cell Transplant, Apollo Hospital, Jubilee Hills, Hyderabad. I would also like to invite the following panelists on the stage to discuss the case-based discussions. Dr. Manju, Professor and Head of Department, Medical Oncology, Tata Memorial Hospital, Mumbai. Dr. Rajiv, Hemo-oncologist and Bone Marrow Transplant Physician at Narayana Hospital, Kolkata. Dr. Samir, Head Department of Hematology, Dinanath Mangeshwar Hospital, Pune. Dr. Jose, we have Medical Director, Medical Oncology, Hematology, and BMT and Cellular Therapy, Apollo Proton Cancer Center, Chennai. And Dr. Puneet Jain, Hemo-oncologist at Apollo Hospital, CBD, Bilapur in Mumbai. A big round of applause for all the panelists, and over to you. All right, everybody. We will also call Dr. Girish Chananswamy, Professor. I'm sorry, Dr. Dinesh Burani. Dr. Dinesh Burani, can we have you also on stage, please? Oh, did I miss on it? I'm sorry. Dr. Dinesh Burani, can we have you also on stage, please? Is he already there? No?
Very good evening. Thank you. It's the second post-lunch session. We had lots of CAR T discussions, starting with leukemia, lymphoma, and Dr. Vikram Matthews has given a good overview and taken lots of questions. So it made my life a lot easier. I'm no means an expert in hematology in the country, but I've been fortunate enough to get the trial in my center, and having treated some of the real-life cases, I could share those views, and we can put up real-life cases and see where we go from. Certainly, real-life cases are completely different from what we see in the KARMA and CARTITUDE trials. Most of our patients are heavily treated, how Vikram has shown those patients. So let's move on. I've got a very esteemed panelist who have had lots of experience in transplant and cell therapy. And Samir also had an extensive experience in using bispecifics. I gather he has used about 16 cases, so I'm going to ask him lots of questions around it. So that's my patient one, a 56-year-old lady with a background diabetes, hypothyroidism, hypertension. She came in October 2015. At that time, she didn't want to have any chemotherapy, no injectables at all. So we somehow convinced her to take oral medication because she travels far. She took a CTD, 5 cycles, went into CR, and had an auto transplant. By then, she was convinced when she achieved a remission that she went through transplant. About 2 years, she had a relapse in 2020, not 2 years, 4 years, and she was treated at that time with a VRD until April. At that time, she had a serological progression and went on to Carfil-Pom-Dex, followed by Dara-Carfil-Dex. And it's difficult that she was progressing after a few years of auto transplant. She was continuing, and she's now penta-refractory. So how did we treat this patient? I know now we have lots of other, so I've put up how did you would have treated in 2020 with the modalities. It may be the same way we treat in a patient who can't afford a lot of new therapies at this stage. So if I start with Samir.
Since you've exhausted most of the novel agents that were available, then probably we are left with chemotherapy. So either VAD or DCEP or bendamustine or something of that nature, just to keep the disease going. Generally, it's about 6 months, 1 year of disease-free period that you may get with these, I think, at this stage.
Would anybody differ anything differently?
I mean, of course, Melphalan and tablets, that also was there, which we used to use. But I agree, I mean, there is limited options, as Dr. Samir said.
And she's got a good performance, relatively young.
I just wanted to add that she was actually very sensitive to alkylators because she maintained she went into CR with CTD, which itself indicates that probably alkylators were really helpful there, and with transplant maintaining a response for 5 years after that. So I think I would bring back the alkylator. And many times in these patients, when you use a combination of POM-cyclodexa or something like an MP, which is going to be useful. So these are the options which we commonly use for patients even in 2025, because many of them don't have affordability for DARA and others. Yeah.
Absolutely. Rajiv, do you want to say?
Yeah, the same thing, because if in my center CAR T facilities are not there, most of them can't afford bispecific. So I'll try to bring the patient into remission and do a second autologous transplant here.
Sure. Pankaj, you want to say anything?
This patient is quite responsive to the alkylators. So second transplant after 4 years is a good option to do in this patient.
So she was very responsive in the beginning, which many patients do in the upfront. With anything you give, we don't know whether she would be responsive at this stage. That would certainly be a challenge. And how bad is her relapse is another question. So what did we do? We went ahead for a chemo-based regime, and we planned for a second transplant, whether auto or allo, based on her response rates. If she went into remission, our plan was to do second auto. If not, plan for allo transplant. So she had a persistent disease, so we gave 2 cycles of DT pace from January to March. And we performed a second auto in July 2021, followed by bortezomib maintenance, which gave her a year and more. and then she started relapsing in December 2023. So second transplant gave her close to 2 years with a serological progression and a marrow disease with a good performance. So what do we do next? Want to start with Rajiv?
Yes, a post-second transplant relapse, frank relapse, 28% plasma cells. I think these two options are there, either if it is available, BITE or CAR T-cell therapy at this point of time, depending on the availability. If CAR T-cell is available, trial is available, then the patient should be put for CAR T-cell therapy.
I think if we didn't have CAR and BITE, would we use bendamustine here, or just to hold? No, probably not a cure. And yeah, and cyclo at this stage after DTP is probably little less value. What do you think? Yeah. What do you want to say? Yeah.
So I would just say that in this patient, these are kind of now has become a high risk patient. So this patient has now become a high risk patient. So you cannot say that you will give only one agent as a maintenance therapy. This patient, ideally, if you have the investigations like MRD, you would like to do an MRD status and see whether the patient is MRD negative or not. And even if the patient is MRD negative, this patient actually should continue with the therapies like double maintenance or triple maintenance, because this is a high risk. So if you give just one agent, this patient is going to relapse in a very short period of time.
So all her cytogenetics, right from the beginning, they were not high-risk disease, but certainly I think that's a great point. So the first transplant gave 4 years, second transplant gave 2 years. After 2 years, after the second transplant, every patient should go on a double maintenance rather than a single maintenance is a big question. I think the earlier relapses, certainly we could think, but 4 years remission, second transplant, but certainly a consolidative approach post-transplant, which we're not very good at doing because patients are exhausted by the time they finish the transplant. 90% of patients don't agree for a consolidative chemo followed by maintenance. They end up going on a maintenance. But something second transplant, if we did have to do it, to stress upon that, that's what you would bring on.
No, just wanted to understand, if I understood the sequence of events earlier, she had bortezomib, not just bortezomib exposed, she was bortezomib refractory, yes. Right? I mean, she had disease progression. So I'm really not sure how much, and if there was a refractoriness even to IMiDs, I'm really not sure how much these are going to add in terms of maintenance. So we really don't know whether it's the DT pace with transplant, which kept her in remission, rather than bortezomib and bortezomib maintenance, or for that matter, adding a second agent. Upfront, I understand that if you're looking at high risk, probably something like a continuous therapy is what you're looking at, post-transplant also. And using 2 agents is probably better. But in this setting, I don't think I would fret a lot thinking that we just gave one. Yeah.
But I think that's a great thinking to at least put those perspectives in front of the patient in real life when we face this. So this patient, we have got, currently if this patient is in 2025, what choices we have? Do you want to go, Manju? Yeah. Samir, you want to go?
Sure.
Yeah.
So what you mentioned is right. I mean, right now we have bispecifics, so we've got teclistamab available, and that's definitely the drug that I would go to in this particular patient. Venetoclax, if it was 11-14, now if I repeat this thing, if it's 11-14 and probably P53 negative, then maybe venetoclax may help. Ixazomib, I don't think it'll be a great drug to give for this kind of a patient, and selinexor, I don't think.
Has anybody used selinexor?
I have used it once, but no, not great at all.
So all these new agents, we're only going when we have no options at this stage. Or ixazomib, anybody used in those? I've used it in the very beginning as an IRD protocol, ixazomib, Lendex. That's a while ago, but now I've never used ixazomib. But
again, sorry, so you want to go ahead, sir, please. You're the chairperson, sir. You take precedence.
In the Boston trial, we used selinexor. It is actually a very good medicine. The problem in India is, again, we had all our patients had severe infections, severe pneumonias. Although in this kind of a situation, I don't think so selinexor will work very well. So teclistamab is the only one probably here. But selinexor as such is a very good agent. to use in the earlier lines of therapy.
So in a penta-refractory patient, if you've had can't go for a second transplant, even doesn't achieve a remission, would you use a single agent selinexor for response rates?
Never
About
single
10-20%? Never single agent with. Fine. Anything you want to say?
No. Just wanted to add that again we need to keep in mind that this is not just PI exposed, it's PI refractory and 2 PI refractory.
Yes.
So ixazomib probably is not going to have anything. I have a difference of opinion on selinexor from sir. It's a difficult drug to handle with a lot of cytopenias. And sometimes I feel that the PFS, which in this case is somewhere around 3 months, is probably when the trial decided to do the first assessment.
Yes.
And that's why that PFS came in as 3 months.
Right.
Yeah,
so
in my center, a trial was going on iberdomide, daratumumab plus iberdomide, but only we could enroll one patient. So exactly don't know the outcome.
Was it a penta-refractory patient or in combination with daratumumab?
Daratumumab in combination with daratumumab, iberdomide.
That was in the second line setting, isn't it? So you want to say something? So the same patient presents to you now, so same after relapsed after 2, what options do you have other than the bispecific and CAR? That's what.
Why not the BCMA antibody and the other things also can be kept
Talquetamab, yeah.
BCMA antibodies.
Okay.
That's
She's talking about belantamab.
Belantamab. That also can be doing a good job.
No,
it's coming back
it's
again.
Coming back.
It's
with
coming
a
back
lesser
heavily.
dose. Keratopathy, once addressed, it is lesser.
Excuse me, have you used daratumumab, carfilzomib or pomalidomide in this patient?
Sorry? Yeah, this patient is already passed through, all penta-refractory.
Okay.
So I think in this patient we had no options. The only reason I put these oral medications is somebody can't afford a bispecific to continue. Sometimes we used, before the bispecifics were launched in India, we were trying to get these tablets, trying to see how you can hold this patient. So we have got 4 trial options, the CAR T trial, trispecific antibody trial, and the CELMoDs, mezigdomide, and the AUR107 bromodamine inhibitors. Fortunately, we have had all 4 trials in our center. So this patient, we were actually fortunate to get the CAR T slot at that time. So I think, so this question is, if we had all the drugs available in the market to us, what would be your choice for this patient? Puneet, what would you choose, CAR or bispecific? I think we had these questions and discussions, but yeah.
Yeah, I think, bispecific, obviously, my choice would be that, because CAR T has its challenges, and that is what is available immediately, and there is more information about it. So only thing is the time taken to manufacture and the time taken to get the cells, and if it's a rapidly progressive disease, then bispecific is what I would prefer.
If you've got both at hand, you're not in India, you've got everything available, cost is an issue, not an issue. So you would choose CAR or BiTE in this patient?
Well, I think long-term CAR is less costly, I believe, than because teclistamab
so you say
is...
CAR.
Yes,
and Samir, what would you say?
CAR T first, but just in the situation that the next question that you're talking about, the bridging therapy, in case it was a very heavy burden disease at this point of time, then and since you've already given all these treatments so far, then there is, not right now, but we don't have TAL available yet, but elsewhere talquetamab has been used as a good bridging for BCMA CAR T, and there's pretty good data on that. So that can be given for about 4 to 6 weeks in order to get the disease under control, then use that as a bridging for CAR T.
Right. Yeah. So, CAR? Manju?
Yeah, of course. Meaning if you are in a scenario where it's either as a part of trial or otherwise available, then CAR T would be a preferable choice, given the duration of therapy which is required and the challenges which we heard about infections, more so in once you have heavily pretreated population, the infections reported in an outside country is as high as 56%. Imagine the situation with us if we are looking at this kind of patients.
So great. So we went ahead with a CAR for this patient. We did not use any bridging therapy. So I think we just discussed about, we did not use any bridging therapy because this patient did not have a heavy burden of disease not like 80%, not cytopenic. But as you have pointed out, if this patient needed a bridging because she's heavily treated, you're suggesting talquetamab or teclistamab as a bridge to go for a CAR. So these, I think we've
not
already...
Not teclistamab, please. Not teclistamab. I said talquetamab.
Talquetamab.
Because some of the patients are telling, even though BCMA is a target, they are
you could
giving
still
some.
Use
You
it.
can still use it.
So
give
you're
the
only
washout
using
period,
just one cycle or so.
Give the washout period and then probably 2 months something. I don't know. Probably as a scan.
I think Dr. Ramaswamy can come join us.
Yeah, please do. So I think it's good to see what is the response rates, adverse effects, and the length of usage. We just discussed the CAR T is one-off. You don't have a maintenance. Bispecific has to continue longer term, though the side effect profile is less. And there are practical issues about a production for a CAR T, and bispecific is off the shelf. It's easily procurable, and now it's available in India. Summary of the anti-BCMA therapies, I would like to highlight the CR rates in cilta-cel, which we have the nanobody technology in India as well, is 98%, compared to teclistamab, which is 63%. MRD negativity is 92%, versus a 46%. So certainly depth of response seemed to be higher. And the toxicity comparison, even the bispecifics are not without a CRS. I'm going to ask how many CRS you've noted, Samir, in your... You've used about 14, 15.
Grade
how
1,
many patients?
Grade 1 CRS is pretty common, but nothing more than grade 1 and no ICANS.
Okay. So is everybody's experience is about the same? And no. And sometimes by specifics, the CRS can be so severe that you may have to use tocilizumab, not just in the CARs. So this is the CRS usually happens in the first 7 days, but when you're using bispecifics, only that the first and second days, when you're using a step-up dose in the first week, when you're using once a week, day 1, day 3, and day 5 in the first week you give. There's a starting vial which you are divided, and that is the first time when you get the CRS. But once you pass through the 3 doses, 2 weeks, are you worried you can do it as a daycare bispecific?
Yes, absolutely.
Only the first time you would admit
You can
them.
even, if you decide to give prophylactic tocilizumab, you need not even admit the patient. But if you're admitting and you're not going to give tocilizumab, we generally admit for about 4 days.
So the first time you're starting bispecific, you would admit them just for 2 days to look for CRS.
About 4 days, we wait for the second step-up dose, and then some people wait for the day 7 dose also, but otherwise about the first week maybe maximum.
So about 4 days compared to
4
CAR T admission about 2 weeks. You were going to say something, Rajesh? Yeah.
Basically, this bispecific, we need to keep in mind that it is not safe drug. And okay, CRS is less, but we have an idea, okay, because bispecific is safe, we can give it like in daycare basis. But I have an experience that after giving teclistamab, one of my patients had a severe CRS, landed up in ICU, and ultimately lost the patient. So we need to keep in mind it is not a safe drug.
It's not very safe. You have to be the first week when you're stepping up. My patient as well needed a teclistamab, tocilizumab when we used the first time bispecific, especially in a patient with a heavy disease burden. So once a decision is made for CAR, we are planning for T-cell harvest, and we need a washout periods from chemo before the T-cell collection. What would be our usual washout is 2 weeks, and we need to look at a vascular access, and no more chemotherapy, no more steroids for 2 weeks, mainly because of a T-cell lymphodepletion. You were not able to get enough T-cells or potency of them, so you stop steroids. And the dose needed, the T-cells, what we would collect is 2 billion, 2 times 10 power 9. And what bridging therapies you would use, not in this patient, what are the standard bridging therapies you would use, Rajiv, if I ask you?
I don't have any experience of giving CAR T-cell therapy in multiple myeloma, so definitely bendamustine or some bispecifics can be used.
Yeah, so bendamustine can be used, some steroids, or no therapy at all if it's not bad. If it's really a pressing area, you need a plasmacytoma, you could give a radiotherapy locally. But of course, you have to have a 2 weeks treatment-free period prior to starting a lymphodepleting therapy. So this patient had collected T, 72 hours, you get a quality control saying you've got enough cells, they can start manufacturing. Day 14, it's released. We admitted on day 19 for lymphodepletion, 3 days, and day 0. So after that, this patient got discharged on day 14. So just to have a little brief of the DRL product, it's a phase 2 we're on. And this is used with a nanobody technology. And so my patient went through some degree of a CRS and ICANS. She kept having headaches. A lot of our patients, hypertensives, first thing we need to do when the blood pressures drop is stop antihypertensives before going ahead with the tocilizumab. Because it's a first patient, heavily treated, 2 transplants. I was quite concerned about giving her tocilizumab. I kept waiting on the ward with a grade 1 bar 2 with a, you could put it as grade 2 with a hypotension, but I put it down to hypertensive, so we stopped and started hydration. She settled by a couple of days with a Tmax of 101, and no tocilizumab was given, no steroids. Her handwriting has changed a little bit, but we kept everything on guard to use it, but not used anything, so she settled and got discharged. And she comes about day 48, we did an MRD and serological status, she went into remission. She kept saying that she's got a dizzy head, some kind of going to ENT, using Vertin tablets. I felt that this may be related to CAR, though you couldn't actually pin down to colitis, but it may be low-grade ICANS, which went on after 30 days as well, which settled after 40 days. So I'm now going to go into the nanobody technology with the potency. Our origin CAR is very similar to cilta-cell, and that's how you get the report and certification about the cell count. The first patient, what we had a 5 × 10⁶ dose. It's a higher dose on the first patient. Subsequent patients received a lesser dose. So when a CAR T admission, be it a leukemia, lymphoma, and myeloma, how many days do you tell the patient you're going to admit, Samir?
So from the date of CAR T infusion, about 1 to 8 to 10 days typically, and if it's a lymphoma, we generally do it as the flu-cy as an outpatient. If it's an ALL with a bad CAR hematotox score, then we maybe admit them for the conditioning as well.
So lymphoma, you're doing it as an outpatient?
The flu-cy, I'm saying.
Flu-cy.
Yeah.
But after the CAR infusion, you're admitting
on the day of the CAR infusion, we admit the patient.
For how long you're keeping them as an inpatient?
About 10 days.
2 weeks?
About 10 days or so.
10 days. So, you admit them on the general ward, neutropenic, BMT ward?
Not in the BMT, in the private room.
In the private room?
Yes.
So we unfortunately don't have the luxury for 10 days for most of the people. So we typically shock people when we say that we discharge them the next day. But we do keep a close follow-up to see at the earliest sign of CRS or anything which is coming up to readmit them. They are monitored from an outpatient basis. We haven't had much challenge with this approach. Largely, it's from our perspective that we do not have the luxury of beds and to keep them, and that allows us to do more patients, and we haven't had safety concern. Yeah.
So you've got a CAR T nurse and a CAR T team. So usually units in the West have got a CAR T nurse who's going to call the patient who is doing an outpatient CAR every single day, take the details of their fever and ICANS. They have to have a form which they write that they have a 10/10 score, and the nurse documents every day by giving a call. Perhaps if we're doing a daycare, we could do that. We don't certainly put them in the BMT ward. The first patient, we certainly had to, but subsequently second patient onwards, be it a commercial or trial, it's all on the neutropenic ward. And our specifications are 2 weeks admission for now, but I'm sure we can change it as we go. And we tell them 30 days they have to be around the hospital within 30 minutes distance if they had anything to come back. And there is a CAR T neurology person and ICU consultant who is aware of these protocols. And the tocilizumab dose is written at the back side as a PRN, and only the consultant gives a green light, then they go ahead. And the ward is stocked with the medicine for the first dose, and the second dose can be. So that's how we did. So what prophylactic medications would you use, Rajiv?
Yeah, the same for CAR T, bispecific, as well as transplant. It is antiviral for 3 to 6 months, depending on the cytopenia. Antifungal for till cytopenia is there, post lymphodepletion cytopenia is there, maximum 1 month. And antiepileptic.
It is a bit debatable. Yeah, some centers do, some centers don't. But
no.
That's something.
And PCV prophylaxis at least for 6 months. So that is a.
So in the trial, we're not supposed to give GCSF for the first 1 month. You could use it afterwards. So certainly, I think if we look at the CRS, the majority of the patients fall into the first 10 days. Probably safe to discharge them after that period. So this patient attained a remission, and so she's now about 1 year and 5 months Her light chains continue to be negative. She did have a low IgG at 300. She had one admission into hospital with infection. At that time, there's a lot of debate about putting her on prophylactic immunoglobulin supplement, but the trial did not support. They said one more infection we will do, but meanwhile, she has not had no infections, and she recovered completely in terms of immune paresis. But what is striking is she's still cytopenic to some degree. She's well otherwise. Her platelets are 64,000. Kept observing 1 year, still cytopenic, fluctuating. So we did a recent bone marrow, which showed a completely cellular marrow, no aplasia, 50-60%. This is the second patient I've noticed that there is a long cytopenia patient as well. So it may be an immune effect, or whether this patient is heavily treated, whether there is this phenomenon is happening, which may be a real life when we start doing the cases. And this is a thing. And reported toxicities, we just looked through. This is our standard, we've designed our protocols, how we're going to get the nurses to monitor the neurological deficits, and when the patient goes home, they will do it and then let us know. So this is a progress card for the juniors to write. Grade 2 CRS, you could repeat the tocilizumab every 8 hours to the maximum of 4 doses. If there is a requirement, that something is important. And the second patient, I'm going to run. First patient, I spent a lot of time so that we could discuss. So this is a 46-year lady, relapse refractory, diagnosed in 2020. She had a VRD transplant and had some radiotherapy, multiple lytic lesions on the relapse. She had a DARA cyclodex, and she consulted. So again, she has had almost all the therapies, pentarefractory, and she came in for a CAR T. At that time, she has had heavy disease. We gave 2 cycles of PAD, initial response of drop in light chains, and she was also developing cytopenia due to heavy marrow disease. CAR assessment, pre-CAR, she had a heavy marrow disease. T-cell collection was done. As a bridging, she had a bendamustine. One thing I want to highlight, she has failed a CAR manufacturing, whether this is due to the PAD chemotherapy within the 3 weeks period. Though the PAD works for a month, strictly in the trials, 2 weeks is a washout period. So that's one of the things I thought for people to be aware of, whether extensive disease, microenvironment in the bone marrow, whether we have to start thinking about these patients not to give anthracyclines heavy in the just before the CAR to spoil our T cells, or that brings back our thoughts about should we collect the T cells in those kind of patients who are going to relapse before giving any chemotherapy type of agents. So it's just a matter of thought process for future. So the third patient, with this I'm going to end, whom we have treated, a 45-year-old hypertension diabetes. It's been going on since 2023 till Feb 2025. In the span of 2 years, he has had multiple lines of therapy. The same agents have been used in multiple combinations, as you can see. So the time he has come in at the time of a 5th line of therapy, we put him on a different trial as there was no slot in CAR T, the bromodamine inhibitors. He had a continuously progressive disease, and he was taken for, at the time pre-CAR, his light chains were 1400, M protein is 4. Because he's got such a bad disease, I was expecting him to have a very bad CRS up front. He's a young diabetic, so that's another concern with the steroids and fungal infections, all these. So in this patient, I gave bendamustine. Do you think we should have used bispecifics, or what would be your thoughts about a CRS risk? And if this patient relapses, do we use bispecifics? So he's a pentarefractory, heavy disease burden just before the CAR.
No, so surely you've got to reduce the burden in some way. So you've already collected the cells.
Cells
right?
are collected.
Yeah. So in that situation, you could use bispecifics maybe. Since he's multiply pre-treated, you may consider using that, or you could just use a little bit of some bendamustine, some steroids, or something of that sort. But bispecifics probably would be a good idea.
Sure. So we used 1 dose of bendamustine, and we went for a CAR. And so he had his infusion, he had a good collection, he had a CRS as I expected, he had 105 fevers, again hypertensive, dropping the blood pressures off, and then a fluids, 3 doses of tocilizumab. He has recovered, he's doing well. So this is my final slide. Future, hypothetically, would you want to do auto transplant or CAR in patients who have got a very high risk disease after the CARTITUDE 4 trial and the CARTITUDE 6 trial, where they're using there's a randomization between the consolidation versus with a CAR versus a transplant. I know the final verdict is out. So somebody wants to throw a light on Rajiv? You want to take this forward? The futuristic, if you've got all the treatments available.
Only once we get the data, we'll have the real answers.
Right.
So CARTitude 5 and 6 will tell us the difference between autologous versus this thing. But that thing is, even if you say that CAR T is surely going to be better than autologous transplant, I mean, how can it be? They are not competitors of each other. You have to use them in tandem. And I hope there'll be a CARTitude 7 in which they're going to use an autologous with CAR T combined.
Yeah. So I think the data, you want to say something?
So just wanted to be, just want to put the caution in place. The more, robust the T cells are, there may be more challenges, though we want them to be, better, not really exhausted. So that's one thing. Second, neurotoxicity still remains a concern. So if we are able to do this and keep these patients not disease free, but disease under control for a long period of time, and then use these therapies at a later date, I mean, I would go by that till such time we have mature data with reasonable follow-up.
Yes.
And that reasonable follow-up, when we are talking of frontline therapy, has to be at least 5 to 6 years, if not longer. To say that we are not introducing illnesses in these individuals who are going to live otherwise a normal life. So I think that's something which we need to keep in mind. I know sometimes the newer therapies gives us a lot of excitement, but we do need to wait for a longer term follow-up. Myeloma is no longer a disease with 2 years outcome.
That's great.
Yeah, completely agree with ma'am. That is with a standard chemotherapy 3-drug or 4-drug induction chemotherapy followed by autologous stem cell transplant, followed by maintenance for indefinite period. We are managing most of the myeloma patients. So if it fails, then there is a possibility of this bispecific CAR.
Yeah, so I think those are the thoughts for future. Once we have the final verdict, we will know. This is just showing that there is a deeper remission, MRD remission with using slightly earlier in these trials, but the long-term data of these trials is still yet to be out. So we will know in future with this CARTitude 6 trial, whether we could use 3 cycles, CAR, and then all these information. But in conclusion, CAR T-cells is an exciting new therapy. It's great to see a lot of new trials coming to India, and a lot of new molecules like mezigdomide, ibodramide, all these coming in, which could perhaps prolong our survival of our patients. And the challenges in the CAR T manufacturing is certainly a thing. And rational combinations, using them in a sequential manner, planning ahead for that particular patient with their finances, individualizing their care is certainly an important thing. Role of MRD is strongly evolving. Getting the MRD -6 is something people are talking about. Can we cure myeloma by doing early MRD? But that's something the trials will tell us after the CARTitude 6 in a long term. In the next 2 years, we can sit and talk something different. Thank you very much. That's a great discussion. Thank you, all the panelists.
Can we give a big round of applause? And can the chairperson please present the mementos to all our moderator and our panel's members? Go. All right, everybody, big round of applause for all the panel members. All right, everybody. So we are moving out for our next panel discussion. Optimizing the sequencing of anti-CD19 therapies in RR childhood B-cell acute lymphoblastic leukemia. I would like to invite on stage the chairs for the session, Dr. Girish Chinnaswamy, Professor and Head of Pediatric Oncology Department, Tata Memorial Hospital, Mumbai. Dr. Mamta Manglani, Head of Comprehensive Thalassemia Care, Pediatric Hematology, Oncology and BMT Center, Borivali, Mumbai. To conduct and moderate our next panel discussion, I now invite on stage Dr. Surgeon Commander Gaurav Narula, Professor in Pediatric Oncology and Health Sciences, Tata Memorial Center, Mumbai. And the co-moderator, Dr. Satya Prakash Yadav, Director, Pediatric Hematology, Oncology and Bone Marrow Transplant, Delhi. I would like to also invite the following panelists on for the discussion. Dr. Manas Kalra, Senior Consultant, Sir Gangaram Hospital, New Delhi. Dr. Vikas Dua, Principal Director and Head Pediatric Hematology, Fortis, Gurgaon. Dr. Santanu Sen, Consultant, Pediatrics, Kokila Bindi Rabaina Ambani Hospital and Research Center, Mumbai. Dr. Pankaj Dwivedi, Hemato-Oncology, Clinic Vedanta, Ahmedabad. Dr. Rajat Bhattacharya, Senior Consultant, Apollo Multi-Speciality Hospital, Kolkata, India. Dr. Vasundhara, Pediatric Hemo-Oncologist, A.T. Fortis Hospital, Bangalore. Dr. Rashmi, Consultant Hematologist, Memorial Hospital, Bangalore. Dr. Nirali, Clinical Hematologist, Senior Medical Advisor, ImmunoAct, Mumbai. Can we give a big round of applause for all our panel members, moderator, co-moderator, and the chairperson. So they would be moderating from there?
More panelists and audience.
Thank you, and we are the last batsmen and tailenders, but I think, this is a CAR T meeting, so just to remind everybody that the first approval for CAR T came in pediatrics. Yes, and there's a lot that you can all learn from the pediatric experience, so thank you everybody who's staying behind for this last bit. So what we have today is we were asked to discuss how to sequence anti-CD19 therapy, but we sort of broadened it because we have options in pediatric ALL. So we're going to discuss how we sequence therapy in children with relapsed refractory B-cell acute lymphoblastic leukemia. What we have done for you today is that we have two co-moderators, myself and Satya here, and we have a case which is a real-life case. All the events did not happen to the same patient, but all events actually happened. So we'll walk you through this case and which Satya had, and I'll invite Satya to present the case, and then we will walk through the various steps and try to see whether we can convert this panel of transplanters into cardiologists. Right. So Satya, you can start.
So thank you, Gaurav, for starting this session. And as a pediatric oncologist, we always have been very, very proud, especially in leukemia, pediatric ALL, that we always teach our adult colleagues how to treat it, because the results in pediatric ALL have been so good that we said that, okay, young adults should also be treated on pediatric protocols. That's what we have been teaching you people for last 30 years. But now, you guys have started teaching us, because in elderly, you have gone chemotherapy-free protocols in a certain subset like Ph positive ALL, BALL, you are treating them without chemotherapy. So that's something of first. And in general, you have taught us that less intensive chemotherapy regimens with newer treatments available, we can manage patients. So, and that is opening a Pandora box, like side effects can be reduced. These are young children who are treated intensively. They have a lot of long-term sequelae. So from elderly patients, if they can be cured with minimal treatment, that would open the door for children to have less and less treatment, chemotherapy-based treatment, and that would be wonderful. So that brings the dilemma. We have, like, the one exciting thing I heard from the last session was multiple myeloma, which was, as pediatric oncology always felt, oh, it's incurable. They are just giving time to their patients. But now you're saying we are going to cure them. That's what, in the last session, the last sentence was curing myeloma. So imagine how much hematology has progressed, that multiple myeloma, we are talking about curing it with the current regimens. So in pediatric now, we have a lot of options to treat these ALL patients. Chemotherapy was established regimen, established protocols, great outcomes. When they relapse, we again give them chemo and do transplants. That was something standard we have been doing for ages. But now there is CAR T-cell therapy, there are immunotherapies, various targeted therapies. So how to sequence them when a patient relapses or is refractory. So we have a real life case here. So Master SG, he was a 4-year-old boy who was diagnosed in November 2019 with pre-B acute lymphatic leukemia, standard risk, on flow CD10, 19, 22 positive, no T-cell markers, and CSF was negative, normal cytogenetics, molecular genetics didn't show any high-risk mutations, and he was treated as per BFM 95 protocol and was prednisolone good responder, day 33 bone marrow in remission, CSF in remission, so MRD was 0.05% detectable, positive. On day 79, before giving high-dose methotrexate, MRD was still detectable, 0.02%. So as per the BFM protocol, if it's more than 0.1, they are very high risk and they need transplant and everything. But this is very borderline positive. And so I'll ask my panelists, maybe we can start from Rashmi and then Manas and others. So when you have this sort of scenario where your MRD was expected to be negative on day 79, but still barely detectable, what would you do, or what would be your hunch feeling that should you intensify regimens or just continue on the protocol, or transplant is indicated, not indicated, or what would you do, or what are your thoughts on this?
Such a low-level MRD is a little bit of a gray area. There's nothing set that this has to be done. We could intensify, give maybe high-risk blocks, quite toxic. Second option is to use a newer agent, move away from chemotherapy, try something like Blina to bring the MRD negative. Then after that, whether to transplant or not, again, I don't know if we should say we should transplant, but especially if the cytogenetics is a little bit on the not favorable side, and if there is a match
so
sibling,
everything is
that
pristine
option.
in this child, just except for this MRD,
Except for
otherwise
this, yeah.
everything is like, it would go a routine case, what we normally do. So I think,
With all the resources available, if I had it, I would try Blina to bring the MRD to negativity, check for an HLA match, give that option to the family saying that you still have a higher risk of relapse, and
Great.
if there is a match,
so Manas,
you could.
let's move to the, what's your take on this?
So I agree with what Rashmi has said. We would, escalate therapy for this situation. In the past, we would have given higher intensity chemotherapy because the time point 1, time point 2, both MRDs are positive, and we have ascertained it's from a good lab, and we are sure that the MRD is positive.
Yeah.
But now with the access program, we have availability of blinatumomab at our center. We would give Blina to such children. He qualifies for this therapy, and with that we would like to get a MRD negativity and consider a stem cell transplant.
So Vikas, if you want to comment.
So in this case, undoubtedly it's a time point 2 MRD which is positive. Though this patient is being treated on BFM protocol, which means that it's a high risk case. In our center we use a different protocol, which is a Malaysia-Singapore protocol that's called MAS-4. In a protocol which is quite similar to BFM, if you are time point 1 and time point 2 MRD positive, you're a high risk candidate. So you require intensification of therapy. So I would intensify the therapy. Before doing that, I would try to see whether the MRD is being done from a reliable lab or not. If
Yeah.
I have a doubt, I will repeat the MRD at our own
Great.
center, and then intensifying the therapy and then monitoring the MRD. If the patient goes into a MRD negative state, I would like to continue him on high risk
Santanu,
blocks.
if you want to comment.
So we use a slightly different, we usually use the UCAL protocol, and at that time point 1, when your MRD is 0.05, we would actually intensify it at that point, go with the higher, more intense protocol. Now the time point 2, 0.02 is kind of borderline. So I probably would not be thinking of transplant right then, but certainly I would be worried enough to say that we need to kind of keep a pretty close eye on this patient.
Yeah.
Continue on chemo, but again, monitor that MRD very, very closely.
So I will stop here because you can see there is variability. It's a gray zone that some people will intensify, some will transplant, some will give blina at this point of time. So what was actually done in this child, this is a real case. So he was given high dose methotrexate, which was due, and after first high dose methotrexate, MRD was negative. And then continued on the protocol, did okay, and during maintenance, around 1 year, 15, 16 months from the diagnosis, the routine CBC showed that counts are going down, peripheral smear had some blast, marrow showed, the kid relapsed. So MRD is a very, very powerful prognostic marker. If you have MRD positive, it tells you need to do something. This child would relapse, and he did relapse. So no ifs and buts, whatever they were saying was right, that they were worried. All of them were worried, but they didn't stick out the neck that we'll transplant or we'll do something, because it's borderline, it's very gray zone. The MRD is just slightly positive, but it's a powerful tool, and that's what it teaches us. And this kid relapsed. He was admitted, and again all the investigations done, cytogenetics, molecular genetics, everything. NGS was also sent to pick up any other mutations or any targeted therapy, which was again didn't pick up anything. So nowadays these things can be done. We can find targets. PH like ALL was also ruled out, so that if that is there, we can add some targeted therapy. So now is that this child has a first relapse, and it's quite very early on treatment. So I can start from that corner. So if you would like to comment, what would you do, or what would be your plan in terms of like chemo, targeted therapy, and whatever?
Yes. Yeah. So, sir, salvage, hello. Sir, I would like to salvage this patient with mini CVD based regimen. If it is CD22 positive, I can add up inotuzumab as well. And then since this is in 2020, we have no other options. Will proceed for us or transplant, allogeneic stem cell transplant.
Great. So the next, if you can comment.
I'm Dr. Vasundhara. So I work at Government Cancer Center at Bangalore. It's called Kidwai Memorial Institute of Oncology. So the background setting is to show that I come from a very resource limited setting. So in this setting, I would start with R3 protocol for my relapse and simultaneously start with the HLA typing of the siblings, and if not, the parents.
So transplant is indicated,
Yes.
and as per the conventional algorithm, this
Yes.
child needs a bridging therapy and then transplant.
True.
Okay, Rajat, would you do anything different, or would stick to conventional?
No, can I just go back to the case?
Yeah.
Did you do a RNA sequencing upfront?
Sorry,
did you do an RNA sequencing upfront? Because there's a reason why these kids
No, it was not done.
So I think that's now being available. I mean, the MASPRO protocol now upfront does all patients. I know there is strategy to do it only in high risk. So I think this is one of the strategies coming, that you do a upfront RNA transcriptome analysis to find out from the beginning. And as I was saying, MRD of 0.05%, whether you call it measurable residual disease or maximum residual disaster, I mean, that's important, because what TMC Calcutta, Professor Vaskar Saha, they adopted the policy that any positive MRD, any at any level, actually they put onto the high risk. And the rationality being, when the kid is diagnosed, they have 10 to the 12 leukemia cells. When you're calling MRD negative, it's still maybe 10 to the 6, maybe 10 to the 7. So anything they can detect. Ideally, we would want to do an NGS MRD to pick up those cases. So any
How would you
MRD
treat now? Like,
yeah, so now it's a on treatment relapse.
Yeah,
so it is a very, very bad disease. So we have to now, of course, go for something more intensive, bring to remission if possible, and the transplant. And now CAR T, of course, will be the other option. So immunotherapy when the disease level is
You
low.
want to give chemo or targeted therapy here?
Depending on what's the blast cell percentage now.
It's a frank relapse, marrow is full.
Yeah, you probably have to give some chemotherapy first.
Pankaj, what's your take?
So as such, this point of time we want to know what is the genetic status of this child.
NGS is normal.
It's normal.
It hasn't picked up
So
anything.
other thing is like going what I use a ALL-R3 protocol. We'll do the induction, see the MRD. MRD is negative, go for a transplant. MRD positive, Blina can be added to bring him in a negative state.
Great.
And then consider for the transplant.
Santanu, you want to comment?
Just going to say that use whichever second line protocol you want to use.
Okay.
You need to get the patient into remission. And if only chemo has done it, it's well and great. Certainly not blinatumomab or something upfront, because we know it works better when your disease load is low. Okay. So I would say chemo followed by blin followed by transplant.
So Vikas and then Manas. Yeah.
I think one point which we all would agree is that it's a very early relapse. So it's a very early relapse. I don't know, I'm not very sure how much chemo would be effective in this case. Whether conventional chemo, whether it is a R3 protocol or a BFM-RES protocol or a XYZ chemo-based protocol, will be able to bring this patient into remission or not. As Shantanu rightly said, if you use a chemo-based protocol, your patient goes into remission, then definitely you would like to use a targeted therapy so that the depth of remission goes better, and then you treat this patient with a transplant. Yeah. If your patient is refractory to chemo, then you don't have a choice, you have to use a targeted therapy. The bottom line is that to get the patient to remission as early as possible and then do a transplant.
So we have someone here, Manas, who has compassionate access to Blin site available in his hospital, which is free of cost. So the cost is not a problem. So we have to just choose. So Manas, what would you choose? So, you have Blina and you have chemo, both available in your center.
So sir, just two things that, and I understand the limitation of availability of the drug, but again, the question of using a very intensive chemotherapy for a relapse ALL is also a big question, because when you use protocols like ALL-R3, in India we have excessive toxicity. Almost, most of the patients would go to ICU, will have a septic shock, we have multi-drug resistant bacteria, and all those issues are there. So that's a big challenge for us. BFM, REZ or similar protocols are little gentler, and if we can put in immunotherapy after that, that makes the transition easy. Now, even the newer UK relapse protocols, actually the induction part is just similar to what you give in BFM protocol in the first time. So it was, a big surprise for us also how we moved from very intensive relapse regimens to now less intensive relapse regimens and trying to incorporate immunotherapy in it. As far as your second question about using blinatumomab in such a situation is that, one thing is through the access program, it takes around 3 weeks to 4 weeks for us.
Can you share your experience? How many patients you have treated?
So it takes 3 to 4 weeks for us to get the drug. So that's a big challenge. Sometimes the patient goes into MRD negativity even before we get Blina, but we still use Blina because we feel that the depth of the remission would be better in these cases and the toxicity is very less, so patients handle it well. We have used blinatumomab for 12 patients till now. One was an infant and who procured the drug, and the others were either relapse refractory ALLs or who were TP2 MRD positive. Barring 2 patients, all of them went into an MRD remission, and we could take some of them to transplant because of a good general condition. One of the patients had a very disseminated invasive fungal infection, was not even, I call him not even fit for a haircut, and he was given blinatumomab and he actually became MRD negative. An excellent, recovery from that disseminated fungal infection, which otherwise would not have been a case to even dream about chemotherapy.
Rashmi, you want to comment, and then Gaurav.
Just want to talk again about the point that Dr. Manas said about the depth of remission. So since this is a very high risk relapse, so I think all very early relapses, even if we attain MRD negativity, adding Blina on top of it, I think deepens. And very recently that the Italians reviewed their Blina data and said that who got Blina even if they were MRD negative, did better after transplant.
Yeah,
So
there
I
is an
think
NEJM paper where they've shown that the arm where Blina
Yeah.
was used as a bridging therapy along
Correct.
with chemo,
Yeah.
they had better outcomes compared to just chemo and transplant. So
Yeah.
there was 15 to 20% better outcome in Blina arm.
Yeah.
So great. So this child, Gaurav, you want to comment or should I move ahead? Yeah.
Okay,
You have CAR T available, so would you straight away give CAR T?
We have it all. So we've treated 80 plus patients with blinatumomab now on the humanitarian access program. So I agree that with this patient, that would the way we would go probably at this stage. We would so getting back to the same trial, which was just quoted. The other part of that was also that a lot of patients could not make it to the post-induction time point from where they could be randomized to receive blina or not. So that is something which has to be taken into consideration. The toxicity of the induction itself was high. So we prefer now a chemo-light induction to be followed by any patient who's planned for blina, followed by transplant and CR2.
So this was what was done. The child was started on BFM res protocol and went in remission, but MRD was still positive after F2 block. It was 0.02% after giving F1 and F2 blocks of BFM res. And it persisted after a couple of more chemos. It never became negative, and then was given blina, which Manas had suggested that should be used and would have been preferable, but because the drug was not available, it was imported later on and was given. And after just one cycle of blina, patient became MRD negative, which was just lingering on 0.01, 0.02. And he had a matched sibling donor available, so a transplant was done with TBI-based conditioning, and patient stayed well for about 1 year and then relapsed again. So this is a second relapse. So now we are in more challenging territory, what to do now. And I think we can start from that end, like a child having second relapse after a bone marrow transplant. Should we give up or should we offer them something? That's where
CAR T-cell
probably 10 years back it was the end. Nothing can be done, go home. But now we have options, so yeah.
So again, CAR T-cell therapy would be the better option
So
over here.
you want to give CAR T as a straight away an option, and that's great. Yeah.
At that point of time, yes. So second transplant, get the patient into remission, and then go ahead with the second transplant.
So CAR T was not available at that time when this kid relapsed, and that was the problem. But anyway, you want to comment?
No, I would go with the second transplant. That's it. No other option. We
So
don't have
there
access
is
to
the data that if you relapse more than 6 months after the first transplant, some of them can be salvaged, but 30 to 40% with the second transplant. But those who relapse very early, within 6 months of the first transplant, to salvage them is difficult when CAR T was not available. So if you don't have CAR T available, it looks dismal scenario, but the only hope is that child is relapsed a bit later and still in good shape. So Rajat, you would not want to...
So it fits with the first CAR T we used in Singapore on my patient, PH positive ALL, on treatment relapse, done a haplotransplant, relapsed about 18 months post-transplant. And at the time CAR T was not available, so I said, okay, I think that's it. And the parents said, no, just give something, so a bit of vincristine and prednisone, and went into remission. Not MRD remission, but some sort of remission. And by the time our CAR T product got approved, so we did the first CAR T as in MRD, low-level MRD situation. So I think that will be the choice. So give something gentle and then CAR T. I think we have already had a TBI-based transplant. So
Pankaj wants to give his.
So one more drug we have, anatuzumab. So before we want a second transplant, we want a CAR T. Why not to child bring into a remission? So using though there may be something about doubt using anatuzumab followed by CAR T, whether it will boost the T cell or not.
So you need a bridging therapy, and you are thinking that maybe we can use that in this scenario and then do a second transplant. Santanu, like any comments on your side? Anything?
I think I agree with what everybody said, and for me the key would be to actually counsel the patient that we know that whenever we are going for a second transplant, by the time we are just that little bit desperate. But I agree completely. If the child stayed well for a year, then certainly we would kind of counsel them, let's go for a second transplant. And yes, that's a good idea to do a bridging and then go for a transplant. And of course, today's day and age, if you have CAR T, this is the time point that we would actually think of
candidate for CAR T.
So in the first go, in the first go, we have used Blina, a targeted therapy. It was a myeloablative conditioning which was used, and now the patient has relapsed. So the prognosis might not be very great because we are talking about 2022. If this would have been 2025, undoubtedly CAR T would have been suggested by anybody who is sitting in this room. Doing a second transplant, and that too with a myeloablative conditioning, will not be possible because the patient will just fall apart and you will be landing nowhere. So if this is 2022, then we would try to bring the patient into remission again and doing a RIC or a reduced toxicity haplotransplant so that you can have some GVL effect that might bring some hope to this family.
Okay. Manas, you want to comment? Okay. So, INO was used as a bridge for second transplant. So patient got a cycle of inotuzumab and became MRD negative. Just one cycle, did very well. And after that, discussion was done with the family for a second transplant, and he had a haplomatched donor. Father was the donor. A transplant was done, and trioflu-based conditioning was given, and that was tolerated very well, and he was discharged in a stable condition. First chimerism was 98.6% donor cells on day 20, then stayed well, and around 3 months later, his chimerism started dropping, mixed chimerism, 88% donor cells, and the marrow was done, CSF was done, they were clear, MRD was negative, but you have mixed chimerism in a child who was very, very high risk, has already had 2 relapses. So what should we do? Should we, relapse is expected here, so should we intervene right now, and what would anyone, maybe Manas or Vikas or Santanu, you want to comment? What would you like to do?
So an evolving mixed chimerism in a patient who has ALL, and clearly a difficult ALL, probably is like an harbinger for next relapse that is going to happen. So I would be very worried for this patient. Would consider doing DLI if he doesn't have a very active GVHD or something to control the leukemia.
Okay. So, yeah, Vikas, you want to comment?
Okay, so I do.
Girish has a comment, yeah. Yeah, Girish.
Would you use Blina now itself rather than go through 2 transplants and etc.? Would you put CAR T in 2025?
Very interesting question. So you're talking about now the primary presentation of this patient way back in 2019, post 2 cycles MRD positive, what to do here. So actually it was interesting at that time, but I think there were a lot of views. Most of them of what we would agree with. I would agree that we would intensify therapy at the first MRD time point itself and not continue on the standard risk arm at that time. And at that time, after that, presuming that we got the same MRD result after intensifying and consolidation, if he had this MRD, I would agree that he would do well on Blina, but just to differ with what Manas said, when you get the Blina through the assistance program, it is for the US FDA approved indication, which unfortunately is set at 0.1%. So this patient would have been ineligible for the blinatumomab at that time point on the assistance program. But yes, as a drug, it would work. Yeah. Is that for real? Because we got 25 minutes over here.
Yeah, we still have time.
Yeah. Why are you drinking the? Okay.
Okay. So donor lymphocyte infusion is one thing which Manas has suggested, and that's what was done. The patient's immunosuppression was stopped.
Sir, in a scenario like this,
yeah.
I'm so sorry to interfere. In a scenario like this, when you have had 2 transplants, you have mixed chimerism. I do agree with Manas that we would prefer to give DLI provided there is no GVHD. But sometimes what you may have is that your cellularity might not be great because you have already had 2 transplants, a lot of chemotherapy was given. Your cellularity is not that great, and with DLI, you may have bone marrow aplasia. So you may be ending nowhere. So there is another option of giving a CD34 stem cell boost, which would not have any negative impact. You can just improve the cellularity of the marrow, and that might help in bringing up the chimerism as well.
Yeah. But would the boost alone be enough?
Satya, I had a comment. This is probably
in case the DLI would be the best option, but in case your marrow cellularity is not great
then you can
and
add on.
your chimerism is low, then the option of boost can be explored.
Just a comment about DLI. It has best option. It is the best option in CML where it has maximum efficacy, and AML is the next one, lower down than CML, and ALL has the least efficacy of DLI. So it's just like a losing game. You're trying DLI, but we are not expecting great, unless in a haplotransplant they get severe GVHD after DLI. They tend to, some of them do achieve a greater chimerism and probably don't relapse. But most patients, DLI is not very efficacious. So this child had DLI, didn't do much, and he did relapse, had a frank relapse.
Satya, can I just comment? Majority of the mechanisms are actually HLA loss if you have a PTCY.
Yes.
So DLI sometimes do not work.
Okay.
And it's very difficult to find out what is an HLA loss. The HLA flow is being developed to look at the chimerism to see where the cells are. Is it donor or recipient origin? So that's why probably, it is very difficult to look at HLA loss. So if that works, then DLI is not going to work.
So now we come to the discussion that CAR T was what was thought in the beginning. Now it is available. We had a trial going at TMH, and this child had relapsed third time. So Gaurav was contacted, and CAR T was sort of prepared that this patient will be getting CAR T. He accepted this patient. So what bridging therapy would you like to use until the kid reaches TMH? Any one of you, Rashmi or Rashmi can.
So if CAR T is planned,
It is planned. He has been accepted on clinical trial. It's just a matter of few months till the child actually reaches the TMH. Till that time, you have to manage.
Yeah. So obviously not a very myeloablative therapy. Something to just keep the disease under control. I have heard of people just even doing it with like oral 6-MP methotrexate, but I wouldn't.
So you are thinking of some gentle chemo, and keeping him alive and stable.
Yeah.
Manas, what would you do?
So we need to harvest good amount of T cells to prepare CAR T. In active discussion with the team who will be doing CAR T, we would plan the chemotherapy regimen, which would essentially be a very gentle drug. Generally, steroids, vincristine based therapy, pegasparaginase, like 3-drug kind of an induction, or the option of using inotuzumab based, but in this particular case it has already been used. Blinatumomab has been used, and obviously we don't want to use the drugs which would make CAR T ineffective or difficult to actually work in the body. So gentle chemotherapy is what we would go for.
Because ma'am has a comment.
I have a question. I'm not a CAR T person, so I don't want to comment. But can you not repeat inotuzumab at this stage?
That's also an
Maybe
option.
1 or 2 doses, because that's much safer than giving
So
again aggressive
because
chemotherapy.
you want to
Absolutely, ma'am. I think if the blast cells are expressing CD22, we can use inotuzumab, because rightly said by Manas and Rashmi that you don't want to blast this patient with a heavy dose of chemotherapy. Either a gentle chemotherapy or a targeted therapy would be our choice.
Yeah.
Sorry to go back, but we had a mixed chimerism in this patient. So what is the blast percentage or the MRD positive?
At that time, MRD was negative. When the first mixed chimerism, he relapsed few months later.
Okay. The serial MRD was checked and he went into.
So at this point of time, what sir mentioned that we can give stem cell boost. So probably a split chimerism will help us decide whether the DLI patient will benefit more from DLI versus a stem cell boost.
Now we are preparing for CAR T. So what bridging therapy would you like to give? You will give chemo, you want to use some targeted therapy.
Right.
You will have this scenario because
to,
CAR T is available now.
So since the patient had responded to INO before.
So just take opinion from Gaurav, what he wants, and maybe use that because he's going to do CAR T. So so this kid got inotuzumab again and responded beautifully, became MRD negative with just 1 cycle, and then was referred to Gaurav, and CAR T happened, and he's still alive more than 18 months post his CAR T cell therapy, and is MRD negative, doing very well. So over to Gaurav to take rest of the discussion.
Thanks a lot, Satya, for bringing out all the dilemmas that dog us in the absence of an alternative therapy. As you can see, this our panel consists of some of the most experienced transplanters in the country, pediatric transplanters in the country, and some more in the audience, and madam over here also. And you can see that this case tested everybody to the limits of their knowledge and experience. So what we can see now is that this panel discussion is about the sequencing of therapy and not about CAR T-cell therapy itself. So I'll just sum up briefly that what's happening. It's patient got CAR T and he's fine so far, and is it happily ever after? As we can see, when it comes to CAR T-cell therapy, we talk about this part, in all our discussions, what happens after we give the CAR T. But as you can see, and this is a typical case for which demonstrated that all the action has actually occurred before that. So, this was the most difficult part of managing the patient rather than actually the CAR T journey itself, because the CAR T itself, though the patient had about 4-5% blast at the time of getting the infusion, just sailed through, had just grade 1 CRS, just received paracetamol, no tocilizumab, was getting bored in the CAR T ward. You met some of these patients yesterday, and discharged and remains in follow-up. And he's quite a brat, as Satya will remember well, and he's a very energetic kid, and it's such a delight to see him. So this is the dilemma, and so we are discussing now how to sequence. So I just want to highlight again what we have discussed so far. Most of us classify our relapses according to this table, and this would definitely qualify as from the first relapse itself as a very high risk relapse, because it was an all treatment relapse. And this shows you the outcomes of patients who have been treated with, this is a review of nearly 10,000 patients from the COG trials covering nearly a decade and a half, with those who were treated with early regimens and those who were treated in the later clinical trials after being relapsed. And you can see that for patients who relapsed early, both the earlier trials and the later trials, and this all included transplant. Remember, transplant has been around for 50 years or longer. All these patients included transplant trial patients. The lines are not budged. The dark line shows you the earlier trials, the gray lines show you the later trials. And whether the relapses were early, intermediate, or late, this has not budged in 2 decades, and with transplant alone, this remains the curve. So even what we are talking about in this patient, from the very beginning, from the first relapse onwards, he was destined to be in the lowest of that curves. That means we are talking about less than 20% outcomes from that time onwards, with the best possible outcomes with chemo and transplant. So now we have CAR T. So just looking at some of the data, and we are glad that this paper has just been accepted in Nature Medicine Blood Cancer Journal. These are the trial patients which treated patients like the one which we just talked about. This was about very, very heavily pre-treated and high-risk group of patients who had effectively no options at all. Median lines of therapy were 3, ranging from 2 to 6. The 6 lines of therapy was this patient and another one. They were like this patient. There were 2 patients with 2 prior allogeneic transplants, and more with at least one prior allogeneic transplant. And they have all had heavy burden disease prior to infusion, and some of it came down because of bridging therapy, etc., like in this patient with anatuzumab. And these are the doses that they received. The toxicity was very low. Almost all patients had a grade 1 CRS, but very few had grade 2 CRS. Very few, just less than half required a tocilizumab rescue. And it was also, in some patients, the tocilizumab, in 2 patients, it was given only for basically CRS grade 1, which was just persisting a lot. So 102, 103 fever with no hypertension, parents getting anxious, so we gave it. And only 1 patient of neurotoxicity who had pre-infusion complications like COVID, etc. So overall, the profile was very safe, much better than what we see with the established trials. And now the data is also out. Both the papers are published. We have a lot of data now on this particular CAR and the others also which are coming now. This was published in Lancet Hematology, trial led by Hasmukh Jain for adults above 15 years of age with relapsed refractory BALL and with relapsed refractory NHL. And you can see the swimmer plot shows you very good response rates which are sustained. Almost all those who had a complete response went on to have a sustained response. And though in NHL the results don't seem as spectacular as that with ALL, but they are very much in line with the accepted CAR T products worldwide. And this is from our accepted paper now in Blood Cancer Journal, which you should hopefully see in print in a week or 10 days, and which shows you that as we went up the dose level, we started getting complete responses reflected by the green bars, and almost everybody who went into a complete response at this dose level has had a sustained response. But a partial response was never meaningful. Whenever there was a partial response, that means we are talking about stringent CR criteria. Complete response was defined as MRD negative, and morphological remission with MRD positive was decided as partial response as long as they had a 1 log reduction. Partial responses were not meaningful, so achieving MRD negativity is the goal here. So with these kind of results and these kind of safety data, let's go back to this patient and see how we can sequence CAR T into the scenarios that we just saw. So let's go one by one again. Satya, your case, so let's start with you. What would you have done differently?
At the first time point when he had MRD persistent positivity, at that time, definitely like Blina, if it was available, that Manas had suggested, and that would have been something which should have been done, and that would have possibly led to MRD negativity, and just then give chemo and see how he goes. And if he had relapsed, then definitely CAR T should have been an option for this kid, because it indicates it's a very resistant disease, high-risk disease, and possibly CAR T in retrospect at the first relapse itself would have been the best option for this kid, avoiding all the toxicity of 2 transplants.
So you would try effectively second-line chemotherapy, but reserve transplant for a relapse. Vikas, you.
So if this boy would have had a relapse in 2025, or I would say would have come to us in 2025, let's put it that way, time point 1 MRD positive, time point 2 MRD positive, for sure if it is positive, then what Dr. Gaurav showed is that even in the best of the centers, if you do a transplant, the outcomes are close to 25%. So I would straight away refer this patient for a CAR T-cell therapy or do a CAR T in our center.
Right. So at refractory time point itself, we would consider CAR T, right?
So
being a very high risk rate.
Sir, one comment on that. Whatever the other available reports on the CAR T-cell, though they are a very heavily treated patients, they have the high relapse rate, so that means at least 50% of the relapse. So at one point of time, they need a transplant. So this patient also, even you give the CAR T cells and he become the MRD negative, even then ultimately consolidated with the transplant.
Right. So we are talking about now 2 situations. We are talking about relapse and we are talking about primary refractory. Rasmi, you have views?
This is more of a question for me. Like, I agree with the sequence that consider Blina or CAR T, but would we still take the patient to a transplant? I don't know.
Okay, after CAR T.
After
so
CAR T.
that was the next question for which Rajat has a view. So,
can I just tell you what my Singapore experience was? They were very, this is Vikas's hospital, which is not where I worked. They used to identify these high-risk ALLs. So as soon as they have a high MRD at the end of induction, they will apheresis the cells and freeze it, and then find any excuse to do a CAR T, because they believe that CAR T can avoid transplant, TBI-based transplant, and many of these. I think that's concept is being explored in Cassiopeia trial, where you'll identify at the end of induction high-risk MRDs and try CAR T as a definitive treatment, so that you can select out patients which can actually just be cured with the CAR T. I think that will be the future. And my hospital also sort of took a similar approach later on. That is not by choice, by patients' family's choice. That when we offered high-risk MRD, that you give some more chemotherapy and then do a TBI-based transplant. And then we offered, okay, we have an option of a compassionate CAR T. All the parents opted for CAR T, despite knowing that this is not an approved product. We have no long-term data. And this is completely, something we don't think about, their perspective. They did not want the child to go through the CAR T, 5 weeks of, the transplant, 5 weeks of TBI and things. It's very difficult to understand.
Yes.
Knowing more than 50%, actually whatever we did relapse, but then that was how their perception was. So I think CAR T is going to come front. Question is whether we can avoid TBI-based transplant by using a CAR T much more upfront. So that's, I think, the future.
Right. 3 interesting points which have come up, but chairperson gets the right.
Rajat, if the patient said they have money only for one, would you do CAR T or BMT in that situation?
That's not a question to ask, Rajat.
I think nobody can answer it. We have to ask the parents again.
No, but we like Vasundra's thoughts on that. Yeah.
Satya, what would you do?
Vasundra first. Vasundra. She's the one who has
just
to
money
face that.
for one treatment. Well, then with the current, if I can bring to MRD remission, then transplant has currently the better outcomes. If we cannot bring to MRD remission, then CAR T.
Vasundra.
So, Dr. Gaurav and myself had a discussion just before this meeting, and this was about the resource limited setting, wherein I have resources just for one. So I think in a setting like ours, like a government hospital, wherein I can go for just one therapy with 15 to 18 lakh, it's going to be chemotherapy. If chance was given, either go for Blina and then the transplant. But I have a question for Dr. Gaurav, because see, the question is, if there was a choice of Blina versus CAR T, now in the hindsight we know that this is a very bad prognostic patient who is relapsed like multiply, doesn't have a great chance. But in the hindsight, the question is, if the choice was between Blina versus CAR T, which one is better? For a center like us, it is, for some reason we got an NGO who has, so Blina versus CAR T, which one would be a better option for a center like us? And I still think that going forward, consolidated with the transplant, post Blina or post CAR T with the transplant might have given a choice.
Right. I think now, the game is wide open now. I'll come to that, but Satya, you have some thoughts here.
So I'll just add to your question that as a transplant physician, my bias is toward transplant, so that's a bias. But looking at the science and the overall, like the data we have, so conventionally relapsed ALL, especially the first relapse or very high risk in CR1, once we get them MRD negative and do transplant, nearly 60 to 70%, 60% are cured with allo transplant. So that's quite a good and established outcomes are there. And transplants have become very safe. Even haplo transplants in children with ALL, they're not very difficult to do. TRM is much less. So it's definitely an option. CAR T, the data is about 40 to 50% are cured with CAR T. But it has been used in more relapsed refractory settings. So once you start using CAR T earlier, maybe your survival curves will go up. But we need that data, and then maybe transplant would go down and CAR T will be up and might become the first choice, what Girish is. So it's like if you have to choose between the two. Right now, this particular case, I have had a couple of cases like this before, where persistent MRD positivity was indication for transplant. They have all relapsed. So I think those who have persistent MRD positivity on day 79 and beyond, they are the most difficult ones to treat. Even allo transplant may not be able to cure them, and they are best candidates for specific targeted CAR T-cell therapy possibly. So this particular case in retrospect is definitely an indication. But if it is pH positive ALL or prednisolone poor response or some other things which are there, some other adverse, and then you are doing a transplant, possibly transplant still stays a good option, but MRD positivity is possibly CAR T is more better. Yeah, thank you.
So I just wanted to know, what is the present cost of CAR T versus transplant today?
Right, ma'am. So the CAR T, I think ImmunoAct is marketing at around under 30 lakhs now. And
30 lakhs.
And what we have heard from Immunil is that their target price is also around 35 to 40 is what we have heard, but we have not used it yet, so I cannot
So
tell
comparing
you.
the cost,
And this is the cost of the product,
Yeah.
so we do have to take into factor the cost of the treatment
but
also.
that might happen with even the allo transplant. So those
So
would figure
maybe about 40 to 45
that will
would
get
be
eliminated.
Allo
That
would
cost.
cost around 15 lakhs or so.
So 15
and with
lakhs.
prior chemotherapy, which would again cost 5-6 lakhs to get them to the transplant, or some bridging therapy like inotuzumab, again costly. So it would be neck and neck, almost very little difference
So
eventually.
that is what I wanted to just point out to Dr. Vasundra, who's in a government setup, that we also work in a public sector setup, but we have been spending for haplos even up to 30 lakhs through donor funding. So why not go for scientifically correct treatment or better treatment if it is proven beyond doubt? I know there is still time and the data should mature enough for us to feel that long term also this will persist, the survival and the response. So once we have that, I think I would also switch to CAR T rather than go for an allogenic transplant. Another question I have to either the panel or to Gaurav is, suppose I give CAR T today, I've spent that much. I might still need a transplant later. True. As a consolidative. That can be tricky in a government setup. So there you will have to be...
That is only for the product.
Yeah.
You know, the care, the flu, cyclo, the lymphodepleting chemotherapy, post CAR T care, we have to factor that as well.
Yeah, but if you need only CAR T, you don't need a post-consolidative transplant.
That's
then
if it persists, if your B-cell aplasia stays on, then you may
I think a whole lot of points have been...
These are the questions one needs to ponder on.
So let me just sum up the points which have been brought up.
One comment I'll make
we
is
have
that...
the chair's permission already because the chair is
there are centers in the world.
I can ask the organizers, can we continue this discussion? We can. So please go ahead.
Just one comment here is that, when we look at, because, Dr. Yadav nicely said that, okay, it's around 60% for this, 40-50% for the very bad ALL CAR T came. So, the efficacy is also neck to neck. Only, I think, very important thing, mainly for students, is that we have to consider that maybe CAR T will come at less late effects price. So that would be the most attractive thing that, which so far our BMT has not been able to do, because TBI based transplant is going to lead children to have, issues with IQ, mathematics, second cancers, many hormonal issues, many other problems will appear at 10, 12, 15 years post-transplant. But so far it appears that CAR T doesn't have that kind of a problem. So that will be an attraction.
So let me, Manas and all of you, you've thrown up all these points. Let's try and put them all together. Okay, let's take these situations one by one. Let's take high-risk relapse first. Okay, and I have some suggestions here. The other is also, now you already brought it up before, we were planning to bring that up anyway. What is the role of transplant post-CAR T? So now that you all brought them up anyway and we discussed all the various options, let's try and put some thoughts together and see if we can get agreement on them. There is data about what to do post-CAR T. So let's cover that first and then let's decide like what we could do. Okay. Post-CAR T, there's a very nice review written by Nirali, and it came in Blood in last just over a year ago, 2 years ago back. What she did was that divided into pre-infusion risk factors and post-infusion risk factors. Those which are pre-infusion risk factors are the very high-risk patients who have event-free survival less than 10 to 30%. Now these patients are those who have got high tumor load at the time of CAR T infusion or had not responded to blinatumomab previously. MLL rearranged because they undergo antigenic shift. CD19 DIM expression, non-CNS extramedullary disease. These are all known to relapse post-CAR T. Okay. So these patients should be upfront considered for a transplant. If you are taking them up for CAR T and can achieve a remission with CAR T, it is recommended. The other is the post-infusion risk factors. So here in post-infusion risk factors, it boils down to two. One is the loss of B-cell aplasia. Prior to 6 months is a clear indication of impending relapse. Almost 70 to 80% of these patients will relapse. So if you're losing B cells are returning in the circulation prior to 6 months after CAR T, you should consider for a transplant. Otherwise, you can wait and watch. And the other is NGS-MRD to pick up the CD19 negative relapses. So you may not pick up B cell aplasia loss early. You may still be there. The B cells may still be absent. But that is exactly the kind of situation in which CD19 negative relapse may occur. So that if you monitor by NGS-MRD, which can detect a much lower level of MRD, then you may be able to take a call to transplant early. In all other patients, it is okay to wait and watch, is the consensus which has evolved. But why just transplant? It's a, if Vasundhara wants to do it, and she had one shot and she gives the CAR T, why just transplant? There is data to suggest that just maintenance chemotherapy might work just as well. This is a paper of retrospective, albeit, in the UK, and by Sara Gurashian paper with Ajay Vora and group, where they analyzed patients who had gone on for transplant and or just received maintenance chemotherapy for early loss of B-cell aplasia. That means B cells were coming back before 6 months, then those patients were decided to take for transplant. Those could not go for transplant, they were just put on oral 6 MP intakes and a VCR 3 monthly kind of regimen, maintenance kind of regimen. The outcomes were comparable. Now this is limited data set, but it is already strong enough for people to consider it as a trial in the West. I think this is the study which we need to do, to answer this question. So madam, I hope that answers your question. We have options for CAR T. Let's get them to CAR T first. So now just think about how do we plan to use CAR T in this setting. We heard diverse views. Here's a suggested algorithm. Looking at all the data in hand, looking at the safety of the CAR T options which are available, I'm not just including one, I'm saying all the 2 approved ones. Whichever one you choose, let's look at this. Okay, in a high risk relapse, that means a very early medullary relapse. Now we are not talking about the primary refractoriness of this patient. Let's consider that separately. We are talking about the first relapse which occurred in maintenance. Not in CR after a salvage induction. That means I would still try a salvage induction, but is not going into a clinic, into MRD negative, because if they do, then you could probably move on for transplant. And with blinatumomab, which knows, you can give blinatumomab and improve the outcomes of transplant from that 20-30% which we were seeing. Very high risk cytogenetics like 17-19, TKI resistant, pH positive, or P53, any post-allo transplant relapse. So right at the first relapse itself. Or if allo transplant is not feasible for any reason, that you may not be able to take up the patient, no donor, no sibling, cannot go for a haplo, whatever. And third line and beyond. If the patient has reached third line therapy, definitely we should be thinking of CAR T. Can we agree on this for high risk relapses? For high risk relapses.
Just P53, they're not good candidates for CAR T. That's what I understand.
So actually, why not? Because P53 is not a good candidate for anything. So even with transplant, they are at risk for enhanced risk for second malignancies. I would rather treat with the CAR T. Yeah.
So will it matter if it is germline TP53 or acquired?
So this is interesting. TP53 or germline TP53 or cancer genetic syndromes have traditionally been excluded from clinical trials.
Exactly, because they would
were
never
excluded
do
from
well.
our clinical trial also.
They would never do well. So you're talking only of acquired.
We do not have the data. No, we do. But I would suggest that for a germline also, if he had to be treated,
okay,
why not treat if they are otherwise indicated? If
because they do
criteria.
so badly even with transplants.
Yeah,
I mean,
we are talking about TP53 in a high risk relapse. We are not talking about upfront.
Germline, I have had one kid and we transplanted. He's doing very well now, more than 5 years post. So he had a Lynch syndrome. I think the Leaf-Remani, the LP. So the kid had osteosarcoma and then developed MDS AML after that for osteosarcoma. Then we had the allotransplant, doing okay. So they are not similar. The acquired P53 has, I think, more mutations than the germline one. Germline has just one. This has more. There is some problem.
So what I would say is that TP53, if they were meeting these criteria, I would not deny them CAR T.
Okay.
I would not say you can't get a CAR T and go for transplant. That's it.
Dr. Gaurav, what is your take on Vikas this idea? So what is your take on very early extramedullary relapses on CAR T?
Okay, so now this is
CNS.
Yeah, this is out of syllabus. I'll come to that. I'll cover it. Okay. So let's just try and get the consensus on these issues, and then we'll come to the ones which are not covered, and maybe we can then wrap up after that. What about the intermediate and low risk relapses? Actually, the dilemmas will come here. For the high risk, I think it becomes very clear. If the patient has an intermediate risk, we are talking relapse, not primary refractory. Chemotherapy followed by standard stem cell transplant is the standard of care, and it should be pursued, is what we feel, because we are not saying that CAR T can replace transplant in all these patients. For high risk, yes, but in an intermediate risk relapse, we know giving blinatumomab over here can improve the outcomes of transplant. So if patient can go for blinatumomab, this is established, large randomized controlled trial, the data is there. If the possibility is there, but I would say that patient should get the full 2 doses of blinatumomab in that case to get the depth of response, which allows for an improved outcome with the allogeneic transplant. Inotuzumab plus minus chemotherapy followed by allogeneic stem transplant is a very good alternative over here and could be pursued. However, for any of the reason, if this strategy is not working, that means you're not able to achieve your MRD clearance for any reason, or you achieved that and it came back prior to the transplant. This is a situation where CAR T would definitely be indicated. Can we have some agreement on this, or you have diverse views? Fairly all right. We would agree with this. Now come to that first situation. Yes, go ahead.
Yeah, so in intermediate or relapse, where you have mentioned chemotherapy followed by blina followed by a consolidatory stem cell transplant. So instead of blina, CAR T may also be used as a bridge over there.
It could be, but that's what. So, the value of blinatumomab over there has been proven in large randomized controlled trial. So that's evidence. If the patient asks me what is the evidence for, then that's what the evidence is for. The problem is practically, I would say that if the patient has to get the best outcome as per the available evidence, then the patient should get the treatment as per that evidence, which is 2 full cycles of 28 days of blinatumomab, which is very difficult to give. In fact, it will be much more costly than the CAR T. Okay, so I would agree with you that practically it would become difficult to give blinatumomab, but those who have access to the program, like Manas does and we do, we have these options available. And in an ideal world, if it is available, then that's what you could do. So that's how it would. But in effect, most of those patients would end up using CAR T prior to transplant. If they were high risk, in intermediate risk, we have that little bit of flexibility. Vasundhara.
Dr. Gaurav, in the case of stem cell transplantation, we have the dictum saying that going with an MRD negative status for transplant gives you the best outcome in ALL. Now, coming to the CAR T therapy, this might be a little off-key question, but having a small MRD positivity, say for example your 0.02, 0.05 or say 0.1%, would going directly to CAR T be the most beneficial one versus going with blina versus post-blina CAR T versus directly CAR T, and you have a better outcome? So because you're not tampering with the CD19 expression and all that.
So here exactly is the point which we are trying to make. As Satya has already pointed out, doing a transplant in a patient who has not achieved MRD negativity is pointless. Okay, but the case does not apply for CAR T-cell therapy or for blinatumomab. But the other part is also there. These are not magic wands. You can't give it to a patient with frank relapse and 50% blast. They have a lot of complications, and so we do need to bring the disease burden down. So for the low MRD situation which you are talking about, I'd rather not take for transplant, and we would go for CAR T and just take it as a one-time treatment.
Would you give blina and then CAR T or go directly?
No, blina followed by CAR T is no point. No point. 2 very expensive therapies followed by each other, there is no point. No.
Can I ask
and
you
both are CD19 directed.
Ask you one question. Sometimes you plan for the CAR T and then the patient goes on to MRD negative remission.
Prior to CAR T.
So no you will still go ahead. Yes. But what is the patient has a B-cell aplasia? Because I was listening to Stephen Grupp in Singapore about a month ago. He said, be worried about those patients who are going into MRD negative to CAR T with the MRD negative remission because they have gone into MRD negative and has a B-cell aplasia because there is no CD19 or 2219 to drive the CAR T. So he just put a word of caution that be careful with these patients.
Yeah, so you're right about that. So that problem usually comes up when you use a B-cell targeting agent. Not as much rituximab because it still spares them every B cells, but definitely when you use anotuzumab, for example. So anotuzumab can result in complete B-cell aplasia, and when you go for a CAR T immediately after that, there is a worry that the CAR T may not expand very well because it's not getting the antigenic challenge to proliferate and to be active. But that concern is not really borne out as far as results are concerned, but maybe the data sets are small. We are now routinely using anituzumab prior to CAR T. We don't see complete remissions usually, but if we do also, they are short-lived, and the patients, most of them, so I have not encountered a complete B-cell aplasia going into CAR T yet. I guess we will build that experience as time goes on. But any other views on that? Okay, so let's look at refractory now. Now, refractory, we agreed that in the patient, for this example, at the time of post-consolidation MRD positive, if the consolidation had been intensified, would have shown this patient to be clearly chemorefractory. And from that time onwards, it would have been, to answer your question, Girish, so in our policy, it would have been transplant in CR1 would have been the goal of therapy thereafter. And if you had achieved a CR1 with a second-line therapy, then we would have moved to a transplant. If you had not achieved a complete remission with the second-line therapy, then we would consider CAR T followed by transplant because this patient would be chemorefractory. Of course, presuming that blinatumomab followed by transplant would have been an equally good option over here. Coming to extramedullary disease was your question, Vikas? Yeah. So extramedullary disease, CNS is usually an exclusion, and so it is always good to clear the CNS disease before going in for CAR T. because of the risk of neurotoxicity. The concern is not efficacy, it has been shown to clear the CNS very well. So that's really not the concern anymore. But non-CNS extramedullary disease, like in that algorithm which Nirali evolved, it does show that they do not respond very well. So though it has been an exclusion for the trial criteria, but we did have a patient who probably had testicular disease, was not clinically detectable at the time of going into CAR T, but on day 8 of CAR T, he had huge scrotal swelling and a lot of edema over there. And then it was very clear that he had CNS testicular disease, and it was the CAR T which was clearing it out there. And it's cleared, he's clear so far, but we don't have enough data to answer your question sufficiently, except that non-CNS extramedullary disease does not get cleared very well with CAR T, is a known risk factor. If it does get cleared with CAR T, you should be thinking of a consolidative transplant.
The reason I'm asking this is because I was discussing with Professor Allen. So they have treated around 6 patients who have got extramedullary disease in the CNS. They have just given CAR T to these patients and they have been doing fantastically well. The longest follow-up is of 6 years. One patient was treated 6 years back, and then now it's been 6 patients. All 6 are doing well. Those who had extramedullary, early, very early, I would say, CNS.
So CNS is very good. So CNS, it works well. There is no doubt about that now. The only concern is safety, which also, I don't think is that big a deal. You give 2 to 3 TITs to a patient and the CNS sort of clears, and then you can go ahead with CAR T at that time. You don't really need to give it in a patient with active disease. Chairperson takes precedence, Rajat.
No, I'm now going to play the role of chairperson by saying that we need to wind up in a minute or two, because I think everybody might be having some flights to take, etc., even including the panelists. Dr. Ramasu.
So we have heard the chairperson has said so.
One question. The case where patient received 4 DLA, that from the father, the child might be having the patient own T-cell when it is relapsed, or the sibling T-cells will be there, the father T-cell will be there. The father T-cell had 4 times, and the last dose was more than 1 million cells the patient received as a DLI. So only the CA was component of the CAR was not there. After the patient CAR was not there, T-cell was given to the patient already. So when that did not work out, so probably the chimeric antigen has made the difference, or because basically we gave the T-cells.
You're absolutely right. So very interesting question. There is a concern. Whose T-cells did the patient get? We call it autologous CAR T, but the patient did not get an autologous CAR T. He got an allogenic CAR T from the donor because of mixed chimerism. We had repeated the studies. It was still about 60-70% at that time when we gave him the CAR T. So yes, most of the cells were the second donor cells. The other 40% were other sibling cells. So he got a mix of somebody else's CAR T, not his own. So it's called autologous CAR T, but it wasn't.
So probably being the CAR is available now, no more DLI should be there. As we know very well, DLI will not work out for the lymphoid spectrum.
Absolutely.
So probably.
So good you brought that point out. It brings us another point. We thought that will this patient get GVHD? So that was because we're going to give him a high dose of allogenic cells. In this, and whose allogenic cells? I mean, 2 donors probably. So yes, but it did not bear out. There were no signs of GVHD either in this patient or in the other patient who had a double transplant. We had not seen it. Yeah. So we, with the chairperson's. Yes.
I just wanted to comment that Revati Raj has the maximum experience of this early CNS relapse. She has said transplant do not work. She does transplant and always relapse. So she asked, and I asked Alan this same question. He said, no, these sort of high risk early CNS relapse, they will give CAR T.
Yeah, so I would agree with that. But there's, like I said, you don't need active disease. You can quickly clear out the active CNS disease and take up for CAR T. Yeah. So with that, thank you all for your attention and staying up till this late hour. And thank you for the discussion. Thank you.
All right, everybody, can we give a big round of applause for our moderator, panel members, and our chairperson? I would request the chairperson to please present the mementos. Can we go ahead? Can we have some background music? Thank you. All right, everybody, the applauses can keep going on. Thank you so much, everyone. A group photo. Thank you so much, everyone. Thank you for the discussion. And now we would like to call upon Dr. Manju for the vote of thanks, Professor and HOD, Medical Oncology, Adult Hemato-Lymphoid Group, Tata Memorial Hospital, Mumbai. Over to you.
So we have come to the end of 2 wonderful days, and on behalf of Leukemia Lymphoma Foundation, Tata Memorial Center, and ImmunoAct organizing team, I would like to express sincere gratitude to each and every one of you who came all the way, shared your experience, knowledge, and made us much, much wiser. A special thanks to all our international speakers, Dr. Satwa Nilapu, Dr. Kirsten Baird, Dr. Terry Fry, for bringing in, and showing us that what lies for us in future, and whatever experience and knowledge they had, how we can contextualize to our setting. What I just want to, highlight at a special part of this meeting was focus on access and affordability, which is rarely to be seen in many of the meetings where only science is talked about. And the reason is, I just want to remind all of you that where we have reached today is all because of our patients and caregivers who placed their trust in us and made this possible. So I think it's our duty now to make sure that whatever innovation has come in, it's accessible and affordable to them. And it truly takes a village to make sure that an innovation of this scale reaches to the ground, to those who need it. And we are very, very grateful for Dr. Raghuvanshi, Dr. Singh, to come here and show us that there is willingness from the regulators as well as from the people in the government to support these kind of innovations. We like to thank all the industries through whose corporate social responsibility we were able to treat so many patients in our setting, and it's still continuing. So thank you, each one of you, and have a safe travel and peaceful remaining Sunday, whatever it is left behind now, and see you sometime soon. Thank you.
Thank you so much, everyone. Have a beautiful, beautiful day ahead and have a safe travel. This is Isha Nirban. Thank you once again.